हेलो राजू। हेलो। चेक 1 2 3 4 5 6 7 8 9 0 चेक। हेलो चेक। हम्म। हेलो चेक। हेलो चेक। चेक 1 2। हेलो चेक। चेक। हेलो चेक। जाओ बाहर जाओ। हेलो चेक 1 2। हेलो चेक। चेक 1 2। हेलो चेक। चेक 1 2। হ্যাঁ হ্যাঁ, একটু কই দূর থেকে বলছো না সামনে থেকে? হ্যাঁ ঠিক আছে। হ্যালো চেক 1 2। হ্যালো চেক। তুমি কাউন্টডাউন দাও, আমার অডিও ক্লিয়ার আছে? হ্যাঁ হ্যাঁ হ্যাঁ। হ্যালো চেক 1 2। হ্যালো চেক। চেক 1 2। ঠিক আছে ঠিক আছে হ্যাঁ ঠিক আছে, এখানে অডিও লেভেলটা যদি কম বেশি থাকে বাড়িয়ে নেবো। ঠিক আছে, চলে আসো, ভেতরে চলে আসো।
হ্যালো
হ্যাঁ হ্যাঁ, শুনতে পাচ্ছি অডিও।
হ্যালো
হ্যাঁ, তোর অডিও আসছে, আমার অডিও আসছে তো? তোর হ্যাঁ, কালার বার আসছে। তুই একবার ওটির ফিটটা দে। বলছি তোর ওখানে কি কোনো ল্যান্ড কানেকশন অ্যারেঞ্জ করা যাবে না? আহ, কি প্রবলেম হচ্ছিল, আসছিল না? হ্যাঁ, আচ্ছা। তো ভয়েস কিন্তু পুরো ফুল ক্লিয়ার আছে, হ্যাঁ। ভয়েস নিয়ে কোনো ইস্যু নেই, ভয়েস পুরো ক্লিয়ার আছে। তুই কি হেডসেটে কথা বলছিস না? হ্যাঁ, আচ্ছা, না, ভয়েস একদম ক্লিয়ার আছে, কোনো অসুবিধা নেই। হ্যান্ড মাইক যদি কথা বলে না, একটু বাড়িয়ে দিস, হ্যাঁ। হ্যাঁ, যদি ডক্টর তো হ্যান্ড মাইকে কথা বলবে না, যদি হ্যান্ড মাইকে কথা বলবি তাহলে একটু বাড়িয়ে দিবি, আর হেডসেটটা একবার চেক করে নিস না। চেক করতে বল। लो, लेवल बहुत लो है, बहुत लेवल लो है। রাজু, রাজু, আর একটু লেভেলটা বাড়া। হ্যাঁ, হ্যাঁ, ঠিক আছে, ঠিক আছে, ঠিক আছে। অন্য অন্য আরেকটা যে ল্যাব আছে ওটা দেখে নে একবার। রাজু, এটা নয়েজ আসছে হঠাৎ। হ্যালো রাজু, একটা নয়েজ আসছে। হ্যাঁ, এবার অফ হয়ে গেল, এবার অফ হয়ে গেল। হ্যালো। না, এবার আর আসছে না। আর এই অডিওটা না ক্র্যাক করছে, দেখ।
माइक का लेवल अगर चेक कर तो ये ऑडियो फटी आ रहा है। हाँ 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 हाँ। ये क्या है, कॉलर है कि हैंड है? हाँ तो कम, उसको कम कर दे एकदम। नहीं, फट ही आ रहा है इसका आवाज। हाँ ठीक है, हल्का सा खाली बेस बढ़ा दे, बढ़ा के। ठीक है, ये कंसोल का है तो। हाँ ठीक है। हाँ हाँ, OT1 का कॉलर माइक बोल। दोनों का कॉलर माइक खाली चेक करवा दे पहले। हेलो। ये माइक को म्यूट कर अपना, कॉर्डलेस माइक को, कंसोल माइक को। ये नहीं, फेस लाइट नहीं हो, फेस लाइट नहीं আসছে। হ্যালো হ্যালো।
এগুলো তো ভিক্টোরিয়া হলে ছিল, এটা তো মিনার্ভা হলে তো নেই।
কি
লাইভ কেস এনআরএস যেটা আছে, এই হাওড়া যেটা নারায়ণী আছে, এটা তো ভিক্টোরিয়া হলে আছে। হ্যাঁ, এটা ভিক্টোরিয়া হল, কিন্তু এটা প্রোগ্রামে কিন্তু এটা দিয়েছে এটা
কথাটা ছেড়ে ওটাও ছেড়ে দাও।
প্রোগ্রাম বুঝেছো?
হুম, ভুলভাল মল চেপেছো। हाँ ठीक है, हाँ ठीक है, ठीक है। OT2 एक बार चेक करा के म्यूट करके छोड़ दो। राजू तेरा वाला माइक थोड़ा सा ना कम कर दे, ऑक्स फट आ रहा है पूरा। हाँ ठीक है, ये कौन सा माइक है? हाँ ठीक है। OT2 का माइक खाली कॉलर एक बार चेक कर ले, करके तेरा म्यूट कर देते हैं, कॉन्फ्रेंस शुरू होने वाला है। हाँ, कौन सा हॉल है ये? OT1 तो, OT2 तो, ठीक है, ठीक है चल। हाँ म्यूट करके छोड़ दे, ठीक है, म्यूट कर, म्यूट करके छोड़ दे।
Check, check 6 1 2 3. এটা হলের হাউলিং তো পেজটা আরেকটু পেজটা একটু দিয়ে দাও check 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 6 1 2 3 check 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 check
हेलो। हाँ वीडियो मिल रहा है, अनम्यूट करिए। नहीं, अनम्यूट करिए अपने आप को, आपका म्यूटेड है। हाँ इस पे बात करते हैं। हेलो। हाँ जी यार, ये टेक टू डाउन सर। हाँ वीडियो टेक टू डाउन। हाँ ठीक है। ठीक है, आपका इंदौर है ना? हाँ, इंदौर और हैदराबाद एक साथ ही ज्वाइन होगा, स्विच होके होगा। ঠিক আছে প্রপার। এটা দ্বারা করে নিতে আমাকে। ठीक है। ठीक है सर, म्यूट करके रख रहे हैं।
For sure, it was the development was GLP and GI1. And that is really so basically the not
molecule that he deserves to modify. One and for my experience, I need 4 or 3 years more than 4,000. It's a game changer not only for diabetes, you can take out the insulin, you can take out hypertension. It gives complete prevention of diabetes. So this is congestion and increasing cost. And in villages, everybody has got today, not 20, 30 cases. 20 to 30 cases to be recorded. Like, this is the only oral peptide in a pill. You can change the world. Yes, okay.
Its effect on lipids and blood pressure is not to that extent as expected. What is your comment? Reduction of weight is there, taking care of glucose is there, but surprisingly, lipids and hypertension is not properly happening. It's not made to address those parameters because overweight related complications. Yes. But it has shown to reduce LDL and triglyceride factor. So it has some effect on lipids as well, and definitely we have seen reduction of obesity and weight. So it has got multiple factors. Lipids effect are not to the extent that body weight.
Actually, the effect on lipid and hypertension is kind of secondary factor. If you reduce your body weight salt in there, if you reduce the body weight like this, like all the time, but when you reduce the blood pressure, when you go to the this study actually does not look for.
Does not look good. And definitely we feel that some of the registry data have shown reduction of blood pressure. So if there is a 10 to 15%, 20% reduction in body weight, this is going to give you a reduction in blood pressure.
And the beauty, the unknown beauty of oral semaglutide is actually only anti-diabetic which can work with the patient. It increases heart rate. So it is this drug, pacemaker drug, like it increases kind of rate by all the oral semaglutide. So it has got many more potential in the treatment of cardiovascular disease. And thanks to this, we are going to listen from Arindam. Arindam is going to speak to speak on cardiovascular disease, elaborate on more detail.
Thank you very much. Wonderful. To be honest, practice induction was there. In fact, body induction, practice induction, and physical parameter induction, right? The other fields of the body is very clear. So, usually, starting with your instructor, you have to select the overall scheme of the disclosure. Now, gender is distributed according to rapid financial data. For example, in pioneer trial, it is the evidence. I will briefly go through all the pioneer trials, and most of the pioneer 6, the cardiovascular risk reduction study with oral semaglutide followed by semaglutide. Now, as we all know, the consequences of therapeutic inertia in diabetes, as by Dr. Kapoor like to mention, I mean, young patients, where this diabetes is newly detected, but there are markers of atherosclerosis. If we do not catch them young, what are we going to expect? In this macrovascular complication, we all know about infarction, heart failure, stroke, cardiovascular events. In fact, at one point of time, it was not very clear targeting HbA1c, whether it reduces macrovascular complications or not, but later on, after the long-term follow-up data of PKP, we know if we catch these diabetic individuals young and target a very stringent HbA1c goal, long run, maybe up down the line, 10 years, 12 years, it is possible to reduce macrovascular complication as well. And this area where new molecules such as inhibitor, GLP-1, as well as SGLT inhibitor were not there, if we catch them young, it is possible to reduce macrovascular complication. Microvascular complication, the data is more linear and clear cut. If we reduce it,
ঢাকুরিয়া আমরি, হ্যালো, ঢাকুরিয়া আমরি, পাপ্পু, অডিও।
Check.
আপনি এটা স্টার্ট হয়ে যাবে, এরপরে আর অডিওটা চেক করতে পারবো না। হ্যাঁ, বল কথা।
Check.
হ্যাঁ, শুনতে
Hello.
পাচ্ছি, তোর লেভেলটা একটু বাড়া, তোর লেভেলটা একটু বাড়া, শুনতে পাচ্ছি। হ্যাঁ, যে লেভেলটা, আর্টস লেভেলটা, এটা একটু বাড়া। আরো বাড়বে, আরো বাড়বে। এটা
Check.
কি
Hello.
কনসোলের
Hello.
মাইক বলছিস না হেডসেটে বলছিস? বেস, বেসটা বাড়া, বেসটা বাড়া আর গেইনটা হালকা একটু বাড়া। অডিও লেভেল অনেক কম আছে, অনেক কম আছে। হ্যাঁ, শুনতে পাচ্ছি, কিন্তু লেভেলটা কম আছে। আমার এখানে বাড়ানো ওই ম্যাক্সিমাম ভলিউম করা আছে। ফেটে যাচ্ছে, অডিও ফেটে যাচ্ছে। আস্তে 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 কথা বল বাপ্পু। ফেটে যাচ্ছে, অডিও ফেটে যাচ্ছে। অডিও পুরো ফেটে যাচ্ছে। হুম, আগের থেকে ঠিক হয়েছে, এবার শুধু ভলিউমটা বাড়া। হুম। হ্যাঁ, হ্যান্ড মাইকটা ঠিক আছে, কিন্তু হেডসেটটা ঠিক নেই, অডিওটা। হ্যাঁ, এবার ঠিক আছে, এটা ঠিক আছে। এটা কি হেডসেট? হ্যাঁ ঠিক, এটার একটু লেভেলটা শুধু বাড়া। দাঁড়া দাঁড়া, ওটা সুনীলা কথা বলছে বিশ্বজিতের সাথে।
দাঁড়া 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 দাঁড়া।
বল এবার মাইকে বল পাপ্পু। হুম। হ্যাঁ এবার বল।
হ্যালো, তোর গেনটা একটু কমা, বলতে বল, গেনটা একটু কমা। সেম অক্সটা বাড়া, গেনটা কমা, বল। 1 মিনিট দাঁড়া, হোল্ড কর। হ্যাঁ বল। হ্যাঁ, আরো একটু করা যাবে? তুই গেনটা কমা, গেনটা কমা তোর ট্রিপলটা একটু কমা, তোর ট্রিপলটা ওখান থেকে কমা। হ্যাঁ, ট্রিপলটা কমা। হ্যাঁ, এবার দেখ। না না দাদা, ঠিক হচ্ছে ঠিক হচ্ছে। অক্স থেকে দিয়েছে। হ্যাঁ, ওটাই কমিয়েছে। এবার দেখুন, এবার দেখুন। হ্যাঁ, অনেকটা ঠিক হয়েছে তোর। হুম, একটু ট্রিপলটা আরো কেটে অক্সটা হালকা একটু। হ্যাঁ, এবার বেটার হচ্ছে। হ্যাঁ, এবার এবার হালকা তুই সেন্টটা হালকা 1% বাড়িয়ে দে, একটা একটা পয়েন্ট আরো বাড়া। 1 পয়েন্ট সেন্ট খালি আরো বাড়া, 1 পয়েন্ট। ছেড়ে দে। আর আর একটু বল। তুই একটু দূর থেকে বল, দূর থেকে বল, একটু দূর থেকে বল, যে কলার মাইকটা লাগিয়ে। ঠিক আছে, পাপ্পুকে বল কোনোদিন জীবনে মাইক টেস্ট যেন না দেয়। ঠিক আছে, গলাটা ঠিক করাবে তারপরে হবে। হ্যাঁ, ঠিক আছে, ছেড়ে দে। ঠিক আছে, ছেড়ে দে, ঠিক আছে।
হ্যালো বিশ্বজিৎ, পাপ্পুকে বল একটু গরম জলে গার্গল করতে। হ্যাঁ ঠিক আছে। হ্যাঁ ঠিক আছে, ঠিক আছে, দুটোই ঠিক আছে। ঠিক আছে, ঠিক আছে। বল 1 2 3 4 5 6 তোর আঁচটা একটু ঠিক ছিল, এখন একটু মনে হয় বেশি হচ্ছে, একটু কমিয়ে দে, একটু কমা। হ্যাঁ ঠিক আছে, ঠিক আছে, হ্যাঁ ঠিক আছে। হ্যালো 1 2 3 4 5 6 7 8 9 0 চেক। হ্যালো চেক 1 2 3 4, হ্যালো চেক 1 2 3 4 5 6 এরকম করে বাপু চেক করছিল।
আচ্ছা ঠিক আছে, সবাই শুনছে, একটু চুপ করে থাক। খালি চেক দে, চেক দিয়ে ছেড়ে দাও। না আবার তোর সেন্টটা কম কর, ফেটে যাচ্ছে আবার। তো কেন করছিস ওটা? নর্মালি যেভাবে কর। হুম, ঠিক আছে, চেঞ্জ কর। এই আছে তো আমাদের। সিঙ্গেল সিঙ্গেল দে। হুম, ঠিক আছে। হ্যাঁ ঠিক আছে, ঠিক আছে, ঠিক আছে। কোনো কেস দেখাবে, পিপিটি দেখাবে কিছু? তোর সেন্টটা আবার কম কর একটু, সত্যি অনেক বেশি আছে, সেন্টটা কম করতে। হ্যাঁ এবার ঠিক আছে, বল এবার বলে যা তো একটু।
পিপিটি যদি দেখায়
হ্যাঁ
এখানে ইনপুট আমাদের করা আছে, স্যার
ঠিক।
দেখাতে পারবে।
ঠিক আছে, ঠিক আছে, হয়ে গেছে। তো এখন থাক।
এখান থেকে পিপিটি সফলতা করে ফেলাচ্ছি, হ্যাঁ
স্বপনদার ওখানে গিয়ে কি করবি তুই?
ইয়ে আছে,
হুম,
শুভশ্রী আছে,
হ্যাঁ তোকে স্বপনদার ওখানে যেতে হবে না তো?
আচ্ছা
শুভশ্রী
ঠিক।
ঢুকছে আমার সঙ্গে কথা বলছে।
হ্যাঁ দাঁড়া তুই, আমি বলছি।
না 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 না
আচ্ছা না না না, এক মিনিট দাঁড়া, জিজ্ঞাসা করি আমি স্বপনদাকে কি আছে।
গাড়িটাকে গাড়িটাকে দাঁড়া মিউটটা আনমিউট কর দাঁড়া তোর অডিওটা বেশি না পাতা আওয়াজ চেক হ্যালো চেক 1 2 3 4 হ্যালো চেক নে তোরা বল একটা অডিও দে তোরা 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 হ্যালো চেক 1 2 3 4 5 6 তোদের অডিওটা তো আমার শুনতে হবে না ওর তো মিউট করা আছে এনআরএস মেডিকেল কলেজ মিউট তো আগে আনমিউট কর লেভেলটা বাড়বে আজ থেকে একটু লেভেলটা বাড়াতে বল হ্যাঁ লেভেলটা কম আছে হ্যাঁ হ্যাঁ লেভেলটা বাড়বে আরো আরো বাড়বে আরো বাড়বে আর একটু বাড়বে কি মাইকে কথা বলছো এটা হ্যান্ড মাইক না হেডসেট হ্যাঁ লেভেলটা বাড়াও তুমি কি আক্স থেকে দিয়েছো তো একটু আক্সটা কমাও হ্যাঁ কমাও একটু গেনটা বাড়াও মেন মাইকের অক্সটা একটু বাড়াও আর মেন অক্সটা দেখো তো কি লেভেলে আছে বলছি মাইকের যে অক্সটা আছে ওই অক্সটা কি লেভেলে আছে আর মেন অক্স যেটা আছে 1 2 3 4 যাই হোক মাইকের অক্সটা কম কর হ্যাঁ এইটার যেটা এখন যেটা বলছিস ঠিক আছে এটা শুধু মেন অক্স লেভেলটা একটু বাড়া দেখি তোর টিবিলটা একটু কম কর টিবিলটা কম কর টিবিলটা হ্যাঁ এবার বল হ্যাঁ একটু কমা একটু কমা একটু আঁচটা কমা হালকা একটু কমা হ্যাঁ একটু দূর থেকে বল হ্যাঁ হ্যাঁ ঠিক আছে এবার হেডসেটটা বল একদম হেডসেটটা বল কম লেভেলটা কম কর আক্স লেভেলটা কম কর হ্যাঁ হ্যাঁ একটু কাউন্টডাউন দাও একদম ঠিক আছে এটা হেডসেট তো একদম একদম ফাটাফাটি আওয়াজ একদম ফাটাফাটি আওয়াজ 1 2 3 4 5 6 7 8 9 0 চেক হ্যালো চেক ঠিক আছে 1 2 3 4 5 6 7 8 9 0 চেক সঞ্জয় একবার একটু বল সঞ্জয় একদম ফাটাফাটি কি বলছো মন্টুদা যে কোনো একজন বলো, আমি বুঝতে পারছি না। হ্যাঁ, হ্যাঁ, সঞ্জয়, সঞ্জয়, আইটিসি থেকে যে অডিওটা যাচ্ছে ওটির মধ্যে, ওইটা অডিওটা বাড়বে না ঠিক লেভেল ঠিক আছে? ঠিক আছে, ঠিক আছে, ঠিক আছে। ছোটন, তুষার, এবার তুই এটা ডিসকানেক্ট করে ইয়েতে উম, ওই লিঙ্কটাতে জয়েন কর।
Check, check. Check 6 1 2 3 check. Starting to.
Hello, can we connect to Manish Banshal? He's connected. Can you have him on the screen? Yeah. Hi, Manish.
Yeah, good morning. Good morning.
Yeah,
I will just pull the curtains to reduce this light.
yeah. Aniruddha.
Yeah.
So we'll start exactly at 10 o'clock. And now this time, Icon, we have two halls, Minerva and Victoria. And morning session started with your diabetes first, then you had CD presentations. Now we'll exactly start at 10 o'clock. And thanks for joining us. I mean, I'm so excited to have you on board and waiting for your beautiful lecture. So give us just 4 minutes and please stay back.
Sure. Yep.
Stay tuned. Yeah.
I'm there.
ফুল স্ক্রিন করবো হয়েছে না এটা এক কাজ করি এক সেকেন্ড ঠিক আছে তো ঠিক আছে তো
Well, namaste, namaskar, namaskara, swagatam, suswagatam to the city of joy, Kolkata. And here we are starting off with a 2-day of celebration of knowledge and what not. So we look forward for the 2-day celebration. But as of now, welcome to the first day of EIIC Con 2023. And the first case that we are having, the first session rather that we are having is structural heart disease. And for this particular session, we have the privilege of the following dignitaries here. In the chairperson panel, may I have the privilege for calling upon Dr. Arup Das Bishash on the dais. May I request the presence of Dr. Achut Shorkar on the podium, requesting Dr. R.S. Joshi to please join him, and requesting Dr. Manas Banerjee to please come up on the stage in the panel of chairmen. And to moderate this particular session, we have the presence of Dr. B.N. Jha, Dr. Rajashree Mondal, Dr. Tarun Praharaj, Dr. Atanu Shaha. And we have this particular 3 topics to be covered in this session. And for the first topic is TNTR and MR by Dr. Manish Bansal. He will be joining us online. So ladies and gentlemen, can we have your eyes on screen, please? Doctor, now it's up to you.
Over to you, Manish.
Good morning, everyone. First of all, I thank Professor Soumitra Kumar, Dr. Pandey, and Dr. Hazra for giving me the opportunity to speak on this important topic. My topic was TE for MR and TR, but I think that would be too vast. So I will be speaking mainly on echo for TER procedure for MR and TR. Now we know that the advent of this procedure, TER, transcatheter edge-to-edge repair for MR has provided us a good solution to treat chronic symptomatic MR in patients who are not fit for surgery. And the mitral clip is the main device that is used for this purpose, the other being Pascal device. So I'll be using the term mitral clip to refer to TER here. Different sizes and designs of the clip are available to suit the patient's needs in specific conditions. This procedure is currently accepted for 2 types of MRs, that is degenerative MR, which means flail or prolapsing mitral leaflet, or functional secondary MR. The procedure is done completely under echo guidance, TE guidance, along with fluoroscopy, and echo plays a very important role right from the patient selection to the actual conduct of the procedure. So we need for this procedure a patient who's got chronic severe MR, and the MR is creating symptoms for which the intervention is required, but at the same time, surgery is not feasible because of high surgical risk. So this would be a patient in whom we would consider this procedure. Now, once we contemplate this procedure, we have to first perform a transthoracic echocardiography to overall assess the suitability for this procedure. If it appears that the patient could be suitable for mitral clip, then we do a comprehensive transesophageal echocardiography evaluation for not only assessing the suitability, but also to rule out any contraindication to the procedure. Number of criteria have been laid down to define what is the best anatomy for this procedure. But we know that with increasing experience, more and more number of operators are now dealing with more and more complicated lesions. But by and large, a central pathology without any calcification at the grasping site, with good mitral valve orifice area, good length of posterior mitral leaflet, and not excessive tenting or flail would be an ideal anatomy for this procedure. Now, once this procedure is being done, we have to first confirm the anatomic suitability once again on the table and rule out contraindications. And then the next step is to do the septal puncture. Now, septal puncture has to be very precise. If the septal puncture is not in the ideal location, then it becomes very, very difficult to perform this procedure. So for this procedure, we want the septal puncture to be done in the center part of the mid part of the septum, away from the aortic valve. So we do use a biplane imaging to precisely define the site where we want to puncture the septum. Here we have bicaval view, and this is the short axis view. In both these views, we locate the tenting created by the puncture needle. And once we are satisfied with this, we go to 4-chamber view to measure the distance of this puncture site from the coaptation plane. We want this distance to be roughly 4 centimeter to allow sufficient space for maneuvering the clip delivery system in the left atrium. So once we are happy with the site of puncture, then the puncture is done. And after puncture is done, the clip delivery system through the guide catheter is advanced into the left atrium, again in echo guidance. Once it reaches left atrium, the clip delivery system is maneuvered towards the mitral valve, like as we can see here. Once we are just above the mitral valve, then comes the next very crucial step, and that is to align the clips in relation to the mitral valve pathology. So here we have this 3D TE view of mitral valve as it is being viewed from the LA side. So we have LA appendage here, septum here, aortic valve here, PML here, and AML here. So we use biplane imaging once again to align the clip with the defect side. This is our bicommissural view, which goes through the medial aspect of the mitral valve to lateral aspect. So it shows us the mitral valve in its entirety from medial to lateral dimension. And the other plane that we use is perpendicular to this, that is LVOT view. It shows us anterior posterior orientation. So we align our clip in these two views simultaneously. In the bicommissural view, we want the clip to be directly on top of the site of the defect. So as we can see here, this leaflet is flail and we are positioning our clip here. In this view, we have to make sure that this clip is neither to anterior nor to posterior. Once we are happy with this, we can confirm this by using color also, that the clip should be bisecting the jet. Then the next thing that we have to do is to make sure that once the clip arms are opened, they should be perpendicular to the coaptation plane. And for this, we use 3D imaging. And so here, as you can see, this clip is off axis. It is not perpendicular to the leaflets, so it needs to be rotated like this. Once this is done, the clip arms are closed, clip is advanced into the left ventricle, arms are opened again, and same alignment process happens once again. Once the alignment is done, then the clip with open arms is brought towards the mitral leaflets in the zoomed LVOT view, and we have to make sure that both the leaflets are falling on the clip arms. Once that happens, we have to quickly grasp or capture both the leaflets between the clip arms and the grippers here. Once that happens, the clip is closed, and then we check the suitability. So we check the stability of the clip. We look for the MR reduction. We have to make sure that there is no significant mitral stenosis created by this. If it appears that the clip is not reducing the MR sufficiently, we can release it and redeploy it. Sometimes we feel that the one clip will not be able to take care of the problem completely. In that case, we deployed the first clip and then deploy another clip. So this is how this procedure is done. This is the pulmonary vein flow pattern. As we can see, this was before complete systolic reversal, which is reversed after the procedure. And here the final outcome. As you can see, the clip is quite stable. There is hardly any MR. And this is in 3D. this mitral orifice is converted into a double orifice valve with a tissue bridge in the center. Now, this procedure leaves a small ASD, which we created to cross into the left atrium. Most of the times, nothing is done for this. So this was about MitraClip. A similar procedure has now been extended for tricuspid regurgitation also. At most of the places, same hardware is being used as for MitraClip, but dedicated TriClip hardware is also being developed. Unfortunately, it is not available in India at present. Now, unlike mitral valve clipping, tricuspid valve clipping is much more challenging because of various reasons. First is that the tricuspid valve anatomy is much more complex. We know that there is already one extra leaflet here, unlike mitral valve, which is a bileaflet valve. But recent studies have shown that in nearly 40% patients, there are 4 or 5 leaflets. So it makes the anatomy very, very complex. At the same time, imaging of tricuspid valve is also very complex because it is the most anterior valve in the heart, and therefore it is the farthest from the transesophageal probe. There's acoustic shadowing because of the annular fibrous tissue in the aortic and mitral valve. There may be aortic or mitral valve disease, which will also create shadowing. So all that makes very difficult to image the tricuspid valve. And therefore, we need to use multiple windows. The 4 main windows are mid-esophageal, distal esophageal, transgastric, and deep transgastric. I'll just quickly show you one case which we recently did here at Medanta, which is the first and so far the only case of tricuspid clipping done in India. So before that, just as for mitral valve, various criteria have been laid down for this procedure also, which indicates suitability or unfavorability of the anatomy. So this patient that I was talking about was a 57-year-old gentleman. He had SCV related CLD, was awaiting liver transplant. He had chronic AF, which was cardioverted once, but he again developed AF. And because of this AF, he developed progressive biatrial enlargement and tricuspid annular dilatation, leading to severe TR. Tricuspid annulus was 46 millimeter. So with this TR, he could not undergo liver transplant, and something had to be done for this valve. So this is the TR. As we can see, it is severe TR. So we decided to do tricuspid clipping because he was not fit for surgery. So for tricuspid clipping also, we use biplane imaging. This is lower esophageal RV inflow-outflow view. In this, if we go through the anterior leaflet, we see septal and anterior leaflet here in the orthogonal view. If we go through the posterior leaflet, we see septal and posterior leaflets. So these two views are most important for us. They show us the anatomic defect, site of regurgitation. And then the other view that we use is transgastric view, in which we see all the 3 tricuspid valve leaflets unfast. So it is like 3D TE of mitral valve. So this is anterior leaflet, tricuspid septal leaflet, and posterior leaflet, and this is the TR jet that we can see here. So in this patient, we again use the same imaging. This is the clip, as we can see. This is biplane imaging, and this is transgastric view showing the clip location towards this commissure. We know that the leak was mainly from here, but the clip is positioned here. Since the tricuspid valve was very enlarged, it was apparent to us right from the beginning that he would need 2 clips. So we positioned first clip towards the commissure. So like this, and the valve was, both the leaflets were grasped. This is septal leaflet, this is anterior leaflet. We can see the same thing in fluoro also. With the grasping of this, these 2 leaflets with the first clip, there was reduction in TR, but TR was not completely eliminated. We expected that, and therefore second clip was brought in, and it was deployed just next to this first clip. So this is the first clip, this is second clip, as we can see here in fluoro, and finally 3D images. So 2 clips side by side, one here, one here. There is mild TR between the 2 clips. This is the final outcome, as we can see here. Resulted in significant reduction in TR, and the patient could undergo liver transplant within a week's time. So this is how these 2 procedures are done. As I mentioned, echo is very, very important. It is critical at every stage of TER procedure performed for MR or TR. Thorough understanding of TE imaging for mitral valve and tricuspid valve, as well as specific requirements for procedural guidance, are essential for success of these procedures. Thank you so much.
Thank you, Manish. Dr. Aniruddha first, then Dr. Kumar. Any question, Dr. Kumar? Professor Kumar? So wonderful presentations, two good presentations for us. Professor Kumar, yeah.
Manish, wonderful presentation as usual. You can
Well,
hear me, no?
Yeah.
So,
Well,
two clips. I mean, what are the risks of having a TS? I mean,
So TS is very unlikely in such a well which is hugely dilated. But after deploying every clip, in fact, even before releasing the clip, we check for TS. So TS is usually not a problem. In case of mitral clip, MS is a problem. So before releasing the clip, we make sure that there is no MS created because of the clip.
Right. Manish, if you have 4D eyes in your lab, like on your 3DT, you see the aorta on the top, 12 o'clock, appendage goes to the left side, whereas in 2D, you have appendage on your right side of the screen. So if you have 4D eyes, where do you see the appendage, on the left side or the right side? Eyes?
4D eyes.
Eyes, yeah.
Okay. So
No-
to be
no
very
idea.
honest, I have no experience of using eyes, so I will not be able to answer that question.
Okay, so 4D eyes also coming for mitral
Yeah.
clip. Now another question, for mitral, you clip the posterior leaflet first, but in this case, tricuspid, you catch the septal leaflet first?
So in case of tricuspid valve, it is recommended to clip septal and anterior leaflets.
Septal
rather
and
than
anterior.
posterior and septal.
So for
because-
that, you have to go to transgastric rather than your 2-chamber or 4-chamber. So transgastric
actually-
is,
Yeah, transgastric shows us the location, but for grasping, we use biplane imaging in the lower esophageal, as I showed, the view in which we see both the leaflets, just like LVOT view. So we need to see both the leaflets falling on the clip arms.
so which type of clip did you use, GTW or NT, wide or extend?
For this, it was used GTW.
GTW.
Yeah.
Okay. Thank you, Manish. If
Okay.
you really want to stay back, please stay back. Now we'll go to next session.
So I will take the privilege of thanking Dr. Manish Vansal on behalf of EIIC Con 2023 for the contribution. Now we move on to the next topic, and I would invite Dr. Aniruddha De, the topic being TAVR Echo. So welcome.
Thank you for the organizer giving me the opportunity to tell these topics. See, for the TAVR, everything is, we depend on the CT. But believe me, my colleagues, the echo can be of some help, particularly during pre, during, and the post procedure in echocardiography. See, the primary indication for surgical or percutaneous treatment of aortic stenosis, we know, is the severe aortic stenosis. Now the indication is two. Either it is severe symptomatic AS, irrespective of LVF, or severe AS with diminished LVF, irrespective of symptoms. We have to do some intervention. There are varieties of valves using the TAVR. The most important two are used mainly. This is the balloon expandable sapien valves or the self-expandable Medtronic, the core valves. But what is the imaging in the patient undergoing TAVR? We know the CT is the best, and we mainly depend on the CT, but still echo has some role. Of course, the fluoroscopy during. But if you look at this chart, the V4 TAVR procedure, though the primary means of TAVR valve sizing is the CT, still there is a role for echocardiography. I'll tell in the later slide. During TAVR, we can do only the fluoroscopy, but again, the role of echo. But if you see after the TAVR procedure, mainly the echo, there is no other modalities is used. So what is the role of echo prior to TAVR? So establish whether indication for TAVR are present, that is severity of the stenosis, whether it is really severe. And the subtype of aortic stenosis is the high versus low gradient. Then the assess LV ejection fraction, and the assess is assist also in TAVR valve sizing. Then types of aortic stenosis. We know the majority are classic high gradient ones, but there are low gradient and preserved LV in 10 to 25% patient, and a few percent low gradient and the diminished EF. So first is the severity of the aortic stenosis. You have to find out whether it is severe or not by the peak velocity, by the mean velocity, by the dimensional index, whatever is the method we have. But there are 10 things we can look before prior to the TAVR by echocardiography. What are those? First, I told you is the confirming the severity of the aortic stenosis, whether it is really severe or not, because that depends on. Second, to exclude the presence of sigmoid septum, basal septum hypertrophy is a very important factor, which may lead to the balloon migration when using particularly the balloon expandable valve. So that has to be noted. Third is the aortic calcification. Severe asymmetrical calcification of the aortic valve may result in incomplete expansion of the valve and results in PVL. Fourth is the bicuspid aortic valve, not preferred with the TAVI for two reasons. Why? One is the higher incidence of PVL due to elliptical opening, leaving the two holes on either side of the prosthesis. And second is its association with aortopathy, more incidence of vascular complication. Then another very, very important that is not you can do in the CT is the mitral valve assessment. Because you know the aortic annulus is in close proximity to the mitral valve apparatus. So placement of the valve too low in the LVOT can approach upon the anterior mitral valve leaflet. Moreover, dense calcification within the aortomitral curtain or mitral annular calcification may increase the risk of paravalvular regurgitation due to asymmetrical expansion of the valve. Not only that, moderate or severe MR is seen up to 48% of the patient undergoing TAVI. And during implantation, the guide wire or the delivery catheter may interfere with the mitral subvalvular apparatus and worsen the degree of MR. And the worsening MR is included in the differential diagnosis of acute hemodynamic instability during implantation. And as such, the operator should be aware of any baseline mitral insufficiency. That has to be kept in your mind. Sixth point is that to exclude the LV thrombus. Left ventricular thrombus is a contraindication to TAVI, and this should be excluded prior to the procedure. Seventh is the coronary ostia. To measure the distance of the both coronary ostia and the aortic annulus by utilization of the QLab software in the 3D, you can do beautifully. Echocardiography can identify the risk of possible coronary obstruction. And last, number 8 is the aortic annulus. See, for aortic measurement of aortic annulus, CT is the best. But you can assist in by the three-dimensional echocardiography. You can do a fairly acute assessment as of CT in aortic annulus determinant, because we know under or oversight can do the complication. Next is the T help to choose the proper axis. Presence of the mobile plaques of the thrombi in the descending aorta and the aortic arch is a contraindication for femoral access. Not only that, you have to look at the both descending aorta and the aortic arch in the both the views. So T study conclusion that senile calcific high gradient aortic stenosis of trileaflet aortic valve with preserved. If symptoms is present, refer for TAVR evaluation. Is absent, consider stent stenting. Now, what the echocardiography can help during TAVR procedure? Should I use TE or transesophageal? The majority recommendation is that it support the favor of the TE for TAVR. Initial experience we know you do is the general anesthesia. Now we do the moderate sedation. Previously we used to do the endotracheal intubation. Now there is no endotracheal intubation. Previously we do that always the TE guidance. Now even we can do even with the TTE guidance. So what to look for during TAVR and echo? There are 3 important points to look: TAVR valve function, paravalvular leak, and the complication. But when proper procedural TAVR valve sizing is done, and when newer generation TAVR valve are used by an experienced TAVR team, complication is minimum. So what are the markers of good implantation? See, if you do the echocardiography, there is short axis circular rather than ovoid. Long axis, you do proximal in just a few millimeters in the LVOT. And the valve gradient should be less than 2 meters per second. And there should not be any paravalvular leak. See, this is the optimal shape. If you give this type of shape, this means good. But this is the suboptimal shape, is ovoid one. This is the optimal location. There is no excessive protrusion into the LVOT. But this is definitely the suboptimal location where it is landing below the OPT. That I'm not going to be. Then the aortic valve gradient, the pre and the post TAVR, it should be less than 2 meters per second. There should not be optimal gradient is the 2 meters something. Then you look for the paravalvular leak in all the views. That is very, very important, because you know Even less than 10% is we called in mild. 10 to 29% is moderate, and if it is more than 30% circumferential, it is severe. So you have to determine both in the circumferential way. If AR occupies more than 30% of the prosthetic circumference is consistent with the severe aortic paravalvular leak. Then you can look the Pacer half times and the holodiastolic murmur for the severe AR. So T can unmask the reason for hemodynamic decompensation during the TAVI implantation. So confirm proper device deployment, coronary artery obstruction, pericardial tamponade, severe MR, aortic injury or dissection, left ventricular perforation or embolization of the valve. Now, what to look? A few words on the post-TAVR only. Assess TAVR complication by pericardial effusion, by LV rupture because LV were related, or RV rupture, pacing were related, or annular rupture. C. Echocardiography remains the standard for the long-term follow-up for the evaluation of the post-TAVR complication. I'm not going to the aortogram, but these are the normal transthoracic echocardiogram you can see after the TAVR after the TAVR. But if we have to look at the three things in the three views. See, in the parasternal long axis view, look at the double echogenic layer. That is very, very important. Double echogenic layer, and of course the color Doppler you see. Then in the short axis, you see the dentition pattern. That dentition pattern, you look like the short axis view. And in the mesh shape frame, you can see in the apical views. Now you can be in the 2D and E Doppler, you can see certain valvular dehiscency, even can sound from AO to RV, you can look at it. Then the basal hypertrophy of the septum, you can look at it in the 3D way, very good way. Sometimes you can even look at the intra-procedure aortic dissection during the TAVR complication. And of course, this is the circumference area of determining the paravalvular regurgitation. You can do in any of the views in the T, they're all paravalvular, the different varieties of the paravalvular regurgitation. You can see this is the peri-aortic hematoma. You can see in this TAVR complication as well. And this is a severe form of paravalvular regurgitation. But if you do the transapical approach, sometimes you can land in the apical pseudoaneurysm that you can determine in the transapical approach. Of course, the most dreaded complication is the translocation of the valve into the ventricle, and you can determine that. So my take-home message is echocardiography is a key aspect of care in the patient undergoing transcatheter aortic valve implantation, that is the TAVI. And the goals of pre-procedure and multimodality imaging for TAVI include ensuring patient suitability, assessment of the access site, selection of the proper valve, and developing the procedural plan where echocardiography still has some role. Thank you. Goals of imaging during the TAVI procedure include proper valve sizing, providing immediate assessment of the valve position and function, and immediate identification of the complication. And echocardiography is still the essential for long-term follow-up after the TAVI. Thank you.
Thank you, Dr. Deb. How do you assess low flow, low gradient scenarios? What are the echocardiographic criteria which can tell us, look, this patient is going to benefit from TAVR and is not going to benefit from TAVR?
Yeah, low flow, low gradient is a different entity. We know that. We have to determine the LV ejection fraction. We have to determine the dimension index. We have to determine the aortic valve area. And of course, the aortic valve flow, you have to determine. That's why you can determine it is a low flow, low gradient stenosis. And of course, you can do the TAVR. It's not a contraindication to TAVR, but you can do it.
Right. Any question from... Now, these when we put these patients on the table, like when you're doing TAVR, once you enter the LV with the wire, and many times we have seen that gradients are not there. I mean, not to the extent of gradient what the patient came inside the lab, like suppose his gradient was 100 millimeter, and once he's on the table, it is not exactly 100 millimeter, maybe 50 millimeter. We get surprised whether the echocardiography was right or wrong. But I'm sure that 100 millimeter was there, nicely detected and nicely measured the gradient. Now, if you have 100 is equal to 40 millimeter on the table, once you put a valve, then what you see as a gradient later in the life, when his physiological condition come back, then may not match. So how do you satisfy as an echocardiographer to the operator that whatever you are seeing on the table is the right thing you are seeing?
Yeah, that's a very good, very, very good question. See, not only the gradient may not be what you were talking about this bit, but I told you the most important thing is the shape of the building, where you are doing the circular shape, your landing zone is in the proper position, and there is no paravalvular leak. That means you are certain. Maybe your gradient may be little higher, it can improve after that. Maybe your sizing may be little lower side, then it can give you. Of course, the pressure recovery phenomenon is still there in aortic valve, even that can happen here also. So the most important thing is that is your area, that is the absolutely circular shape. Your landing zone is absolutely proper, not protruding with the LVOT, and there is no paravalvular leak. Maybe a little gradient, of course, in later life, you can see there are a lot of patients that is ultimately going into the normal things.
So, right. So that means you are saying that whatever the gradient may be pre-TAVR, but on the table you are happy with the echocardiographic features.
Yes.
That should be the end point of
Yeah,
your TAVR. It should not leak. It should not be nicely open, is circularity, etc. So that there is a huge role of echocardiographer in the field of structural heart disease now, and we should work as a team. Otherwise, like we can land up with complications, wrong assessment of your valve and LA closure or mitral or clips. So we have to discuss this thing with the echocardiographer beforehand and during the procedure, and perhaps we have to take the help of the modern echocardiographer. I would say the modern day angioplasty, like modern day echocardiographer who understand TE and the structural heart disease very nicely, and they can help the IC or interventional cardiologist, the nitty-gritty or the paraoperative help. Sometimes it is very difficult to have this kind of image quality like through the TE. So do you think that in the future we have talked about ICE? So though ICE is a very costly instrument, do you think there is a role for ICE in the future to replace TE, those patients who are having cirrhosis, esophageal varices, or doesn't want a anesthesia? Role of ICE.
Yeah, that's a very important thing. See, I told you that before 10 years back, we used to use the general anesthesia. Now we're not doing. The 10 years back, we used to use the TE always. Now, even the modern day, that is telling in the transesophageal echocardiography, even the 3D thoracic echocardiography can give you a lot of guides. And of course, there are, in fact, there is a beautiful editorial is coming now that whether still we use TE or even with the expertise hand, we can do the thoracic echocardiography with the advanced echocardiography that you can do. Of course, I have a lot of slides of the transesophageal echocardiography in the during TAVR and the after TAVR, but due to lack of time, I could not show you because the 8-minute time is not agreed.
So thank you, Dr. Dey. I think it's time to move to the other hall for inaugurations. We'll come back here at 10:40 for the next session. Thank you.
Thank you so much, sir. Thank you, Dr. Dey, for your contribution. And now I will request all the dignitaries to please move forward beside hall, that is hall number A, for the inauguration ceremony. Post that dot at 10:40, we start off with the next session, that is for the modern PCI. So I will request each and everyone to please come back to this hall at 10:40. I will thank all the dignitaries here on the panel for the wonderful session that we have here. Thank you so much. We move on to the hall A for the inauguration ceremony. Thank you so very much.
Hello. Live case from Hyderabad and Indore will start at 11 a.m. sharp. Hello, am I audible? Okay, yes, sir. So 11 a.m. sharp, we will start from the Hyderabad and Indore both will be on the switching port. Okay, okay. Thank you, sir.
হ্যালো, চেক। ঠিক আছে। এটা কি মাইক, হ্যান্ড মাইক না হেডসেট? ঠিক আছে, একটু হ্যাঁ, ইয়েটা সেন্টটা কমিও, সেন্টটা, হ্যাঁ। ঠিক আছে, ঠিক আছে, ঠিক আছে, মিউট করে দাও।
Hello? Can we connect to Indore lab? Just to have a check on them. And AIG hospital, yeah. So they are ready and that's Indore. All right.
Hello, Indore.
Yeah.
Hello, Indore, please switch on your mic.
Hi, Sarita, Doctor. Yeah, Sarita, Dr. Hajra here. We'll start exactly at 11 o'clock. Your case. Okay, just give me just. Okay. Morning, all good. Nice, very nice. Thank you. Mute them and
Yeah.
please
Indore,
connect.
you can mute yourself.
Yeah. Can it?
Yeah.
AIG Hospital, Hyderabad. Yeah, hi. Excited to see you. Yeah. So we'll start within few minutes. We'll start. Abhijit, you can join us. So mute both of them. We'll
Yeah.
start exactly 11 o'clock.
They will mute.
What we'll do, we'll switch from one lab to another lab. Yeah.
So we resume our sessions after the inauguration session. This whole session will be particularly an online session where we will have that privilege of seeing what goes into the operation theater and all. We can already have a synopsis on the screen, and the session will be modern PCI C prep treat, go for zero. And for this particular session, we have our privilege of the presence of our chairperson, Dr. Soumitra Ray, and Dr. S.B. Roy. And the moderator of this particular topic will be Dr. Prakash Hajra, Dr. N. Siddiqui, Dr. S.B. Bhattacharya, Dr. Rana Rathore Roy. So we start off with this session sharp at 11, where we will be having the details here on screen. But as of now, we start the session and the live screening and will be there from 11.
So thank you, Dr. Sarita, and my other friends from Apollo Hospital Indore. Dr. Sarita has contributed so much in the field of intervention cardiology in the central part of India. And overwhelming success of her in the field of intervention cardiology makes others jealous because of his delivery, the content, the command, and up-to-date informations. So I welcome on behalf of CSI EICON to this conference, and we'll have one parallel lecture, Dr. Devdatta Bhattacharya. So we'll go back to Dr. Sarita first. Then we have another phenomenal performer, Dr. Rajiv Menon and his team, who is heading the hospital, EIG Hyderabad. Very young personality, but he's as good as any legendary figure in our country in the field of interventions. So let's go back to Dr. Sarita Rao, Apollo Hospital Indore, and let's start the case. Over to you, Sarita.
Yes, ma'am, clearly.
Everybody on the panel. I'm Dr. Sarita Rao, Senior Intervention Cardiologist, and I work at Apollo Hospital Indore. So this is our cath lab where we do all our cases, and we are the pioneer in rota ablation, intracoronary shockwave lithotripsy, and TAVI procedure, Central India. This is the console room of our cath lab, where we have performed more than 20,000 procedures in the last 10 years. And I have done the first TAVI procedure, the first shockwave lithotripsy, the first dedicated device, then they use it to the TAVI cell.
Yeah, go ahead, Sarita. Abhijit. It's a very complex case. Yeah.
It's unprotected dominant circumflex and the lesion at the ostium looks quite tight. So probably putting IVUS or OCT won't be possible. We'll have to exchange a wire over the microcatheter with a rota and start with rota probably.
So let me go ahead and show you what I did right now. Here we go to the first,
So Sarita, do you have a choice of IVUS? You have a choice of stent, choice of guide, choice of where? Do you have a choice of IVUS? Because one hospital has one IVUS, but in broader perspective, do you have a choice of IVUS? If you have a calcified, very tight lesions, easy to do and easy to prep.
So I've taken an ear one side, I've taken a set in front. Because there is a possibility that I might need to outside my work. So I'm prepared for it. I've also put in a temporary pacemaker because this is a patient with a normal insert. Also, so my choice of side is the other one, set in bench. The second thing is that with regards to imaging. Now, our test does go. So calcium is very well demonstrated both on IVUS and on OCT. But then the depth of calcification is better demonstrated on OCT. But the fact is that the OCT is quality. And many times you're not able to cross. Like in this situation, I was able to cross the IVUS, not able to cross the OCT. Sometimes, and so sometimes you don't really how to work.
Yeah, just a minute. There is a question from the floor for you, Dr. Arindam Pandey. Yeah, go ahead. Mike. Yeah.
Just as he gets the mic, I'll have one question. Did you get the mic? Yeah, okay, go ahead.
Am I audible?
Hello? Yes, I think I am audible. So very complex case, Your approach is very fantastic, taking a 7 French femoral, taking a AL. So I just want to ask a simple question. Initially, it seems to be very tight lesion. So your IVUS you could not negotiate. So at this point, you pre-dilated with the balloon. So second option is to take the rota upfront without pre-dilating. Taking a 1.5 rota will give you very good understanding of the lesion characteristics as well. And probably this can help in the further procedure, whether you need to upsize the rota bar or you can take a IVL, doing a rota tripsy kind of thing. So what is your opinion regarding not to pre-dilate, taking the upfront rota?
So, Dr. Arindam has very well noted. Now, sometimes go up straight away to program. But this is situation, you're going live wanted to have a debating if possible, just to see where and we. But again, sometimes if you're not we're going to have time to go down. I want to what is my plan, what exactly is the situation inside before I want to go in. So always better idea
Yeah. Okay, before you go further, just one last question. So what do you think of the IVUS images? Were you expecting this? Because I thought that the calcium was not really that bad. Looking at the angiography, the calcium looked much worse. I was suspecting that there would be 360 or 270 calcium, but really I cannot see that. And probably this might not, I mean, you could do this without doing rotablation and giving a very high pressure dilatation with a 3 or a 3.5 balloon. So what do you think about that? Where do you think on the IVUS, where do you think the really tightest bit of calcium is?
Okay, Sarita, go ahead with your work. I mean, show us your beautiful hands. Yeah, good. What speed? 200. 200. Right. So, Dr. Devdatta, do you think in retrospect, if the rota is not going so nicely, flying nicely, it proves that it was calcium? Dr. Bhattacharya?
Yeah. I mean, the fact that the rota is not going very smoothly, I think the angulation is also playing a part, and it is a very tight lesion. And of course, there is calcium. What we were discussing was she obviously, Dr. Sarita said that there were calcific nodules, which we couldn't pick up on the images that are being transmitted here. And as you can see, she has crossed it, and we can see what it looks on IVUS now and compare with the images that were there earlier. So I think first she dilated with a 2 balloon, and she said that the balloon had a waist. And so I think it's a reasonable thing to do rota. What I couldn't see on the calcific images, what I thought was that if she had a high pressure balloon, that could crack it as well. But at that point, I couldn't see the calcific nodules very well. So, so she has done it, and maybe she can do the IVUS again.
So when your rota doesn't pass, you have to either increase the support with the Amplatz type of catheter. You can go with a guideliner to increase the support. Third thing you can do is increase the burr speed. Fourth thing you can do is downsize the burr and again go to the 1.5. So probably 1.5 is crossing, and this is the bad position for the stuck burr as well as the perforation.
Okay, keep on working, Sarita. So we can see the movement of your rota wear was quite jumpy and quite rough. So how do you check your horses? I mean, this rota wear moving out from the distal vessel, coming to the middle of the vessel. So how do you control your wear? Yeah, so to keep the wear inside the targeted zone, you should not give too much of pressure. Otherwise, what is happening? The guide was coming out, yeah, coming back, yeah.
Any thought on orbital, ma'am? Probably in this situation, the lumen gain is going to be the ultimate target for us. Probably orbital will give more luminal gain probably. Yeah. Yeah.
So Dr. Sarita, I would do repeat the IVUS now. Now, what I wanted to ask you was that after you had done the rotor run, looking at your pressures and your ECG, you're quite fine. But do you check with an angio that everything is okay and you have not produced a dissection around that bend or stuff like that, or it's not your routine practice? If you're happy with the pressure and the ECG, then you don't do anything. Yeah. Okay.
That looks good. I mean, yeah. Yeah.
Yes, yes. Cutting balloon at high pressure. Take a good size cutting balloon at high pressure. Wolverine will be a very good choice. So if this, yes, and this vessel looks more than 3.5 for sure. So I'll take a very big cutting balloon here.
Which side?
3.5?
I'll take a 3 at least and
Three.
go at 18 atmosphere. 18 atmosphere.
Yeah, better to
Yeah,
go
the,
with
the only thing about the Wolverine is that this is the circumflex and this has a very acute bend. And sometimes there you can find a trouble getting that Wolverine across that bend. But let's look at the IVAS first and then we will have a better idea.
always better to go with a lower size balloon with a high pressure.
So
rather-
3.5 vessel, I take a 3 balloon
Yeah,
and go
instead
at
of 3
18,
with
18
the high
atmosphere.
pressure.
Out
with
of
high-
different cutting balloon and scoring balloon, I think
yeah.
Wolverine has the best profile regarding the negotiation.
There we are. There we are at the calcified. Can you press on the fluoro as well? So yeah, press on the fluoro as well, please, so that we can correlate.
We can do a boost here.
Yeah.
With IVAS, we can do a boost so that overall calcium burden can be taken care of. We can see that. Do a boost here.
I think you have done enough with the rota and balloon dilatation. Either with a cutting or a non-compliant balloon will work here. My only concern about the Wolverine is that bend, whether the Wolverine will go around that bend. But the Wolverine is a better balloon than the older version, better cutting balloon. So you might be successful in taking that Wolverine down that curve.
I think even that high pressure non-compliant balloon nowadays will also do the same job because he has bitten the boy so nicely by rota. The naughty boy is falling in line, and whatever you want to, place, it will work. Like normal stenting without cutting balloon or high pressure balloon will work.
So, we had the calcium with the rota, so demonstrated very well on the IVAS. Now we have taken the suggestion of panel, and they're going in with a Wolverine. This is a 3.25 into 10. And you take it.
Right.
Wolverine into 10, perfect calculation. Wow.
Go down a bit. Go down a bit.
It's okay. So you can. So behavior of the balloon is very important.
I
If
think
the
the balloon
balloon is
was-
behaving nicely, opens up nicely, that you have done enough cutting. Yeah. Yeah, Arindam.
Yeah. Yeah, I can see the rupture of the balloon. So at 18 atmosphere, balloon got
No,
ruptured.
actually, she has got very fast. And
Yes.
cutting balloon,
is
usual
not
dig
it.
time is slow and so in live case, this can happen, but I'm sure she knows.
I think everything will be okay because so much of calcification won't
Just,
let anything to happen. And at this point, do we go with IVAS again or
No,
I
just
could-
stent it.
I could see it's a very nice opening of the balloon, so we can directly go ahead with this tent.
Yeah, just I think
Yeah,
it can be done.
Very good, very good.
Yeah, just
This was the last one.
yeah. Yeah, what do you think? I think you should stent it now.
Yes.
Now,
What size 10?
this is why I think this was such a good idea. Are we then, something, we're going to
3.5 plus. Yeah. Yeah.
I think we'll leave you there. We'll come back to Sarita again. Can I go to AIG? AIG, Dr. Menon. We'll see your final result, Sarita. The case is as beautiful as you.
Hello, Hyderabad. Hello, Hyderabad. Yes, sir. Please go ahead.
Truly. Yeah, Rajiv, good morning. Welcome. Yeah. Dr. Subhananda. Come here.
Hajra is calling you. কফিটা নিয়ে তারপর আসছে দেখ আমার তো দিল না কফি দেখলাম খালি তুলি তোমাকেই কফি দিল
Rajiv, go ahead. Yeah.
Yes, we can see.
We can't see your ECG. Can you fix the ECG for us, please?
Then I will just tell you what we did. In the meantime, I think I will request the panel about what their plan would be for this type of a coronary artery disease as far tortures and stenosis at multiple places, not for proximal made as well as this. Over to you, Dr. Azim.
Where did you start doing the IVUS from? Do you have a reference injection so that we can understand it better?
And I think we are able to see the we can just go ahead to the first scene. One side, then we just one second. Now we can move forward again. So this is I think see very clear.
We have a question here. You know, first of all, what is your wear? Did you put a rotawear on or did your microcatheter crossed? Yeah. Okay.
We can't see the microcatheter. We are seeing the IVUS images. Yeah. Show us the distal, how much from where you are starting to do the IVUS. That we can't see yet. You couldn't. Okay. So you went with rota. So you exchanged and you are now doing rota and then you will do IVUS, right? Okay.
A question to Dr. Rai. If you have a tortuosity vis-a-vis no tortuosity, do you change your speed? Tortuous RC, the speed, initial speed.
No, I would rather go with a medium speed that is between 160 to 180, not more than that. And the most important is the size
180
of
is
the
quite a speed.
Huh?
180.
And what is your plan? Will you going to upgrade the bar or you will go with other devices? Are you going to upgrade the bar? Because the distal vessel is quite large, I believe.
No.
or you use an IVL or some other gadgets to. Yeah. Okay.
Yeah. So if you have a tortuous solution, better to stay away from upsizing the rotor rather than be happy with 1.5. Use other weapons to deal with the enemies, like left out enemies like calcium, fibrotic lesions. Yeah. So you can see a lot of concertina now.
Is it a rota extra support?
This is a 2.5, right? Yeah.
So we just from that point. From that midpoint is IVAS which you actually started seeing. So I think can you just get the IVAS please? You're not able to mix and so IVAS full screen and we have IVAS full screen. Yeah, so you are able to see IVAS?
Yes, we're able to see IVAS.
Okay. Great, so it is. Put it in the report and from there, we're able to see IVAS. I'm not sure if the business can be on the usually with the city to and that applies for after agreement. You so it's either with a great. That's when we are. The issue is now to read so that how can you just keep on whether we do further block modification or let's say
Your proximal part of the artery, still there is a lot of plaques and you need more dilatation perhaps ostium up to ostium of the RCA maybe.
I think
The
the preparation is nice. I think you should not go by this IVAS fear. I mean, the IVAS may not show each and every detail of calcium breakage, but the enemy is very weak now.
Yeah, there are two things. One is that the IVAS didn't cross across the distal lesion, so that you have to do based on your angiographic image and what you feel, how the balloon expanded. And the other thing is that we feel that the osteoproximal RCA, which you are going to stent as well, that needs further pre-dilatation, maybe with a 3.5 balloon. It is quite safe to dilate it with a 3.5 there. I would
Yeah.
be a little careful dilating the heavily calcified portion with a 3.5 balloon, especially the part that you couldn't see by IVUS. But I think the whole vessel, instead of a 2.5, you should pre-dilate with a 3 and the osteoproximal with a 3.5 before you stent it.
Yeah, if you can test the water by sending 3 mm balloon and see the contour of the balloon. If the contour of the balloon is nicely formed, like it is a formed balloon rather than indentations or dog boning, then you need to have additional equipment. Don't you think, Dr. Rai, that this is the time to pass one long 3 mm balloon, see the behavior of the balloon. If the behavior of the balloon is good, then you can take out your stent and just put it. Yeah. So that's what we are thinking. Go ahead. Time is running out. We cannot buy time. Yeah. Yeah. Go to the angio. Angio should. Yeah. Your balloon is flying very nicely. Balloon is behaving nicely, though eccentric little bit.
Not really nice, that the
Not
proximal
very
part
nice.
is not opening
Not
nicely.
very nice. So this place needs little bit of nudging. Yeah. Not bad, but
Mm.
okay. Accept.
Eccentrically opening. So the point is, what is your opinion that if you think that the artery is 4 mm, do you think for a plaque modification 1.5 bar is the optimum?
So what he's saying, what he's asking, upgrading the bar from 1.5 to 1.75 in 3.5 plus vessel. It's you're careful about the guide. Yeah.
Yes. Yeah, that's perfectly right. But sometimes we see that when the artery is very large, say 4 mm, there's 1.5 bar would be very small to have a plaque modification. Maybe you need bar to artery ratio. If you have to keep it around 0.5 to 0.6. If you go with a very small bar where the bar to artery ratio is 0.4, that makes no sense sometimes.
I think if you have the luxury of having IVL here, you can combine rota with lithotripsy. If you're not happy with the cutting balloon, rather than going for 1.75 bar, because 1.75 bar will cause more concertina, perforations, and
Just
these
take a picture.
special
Just be careful with that osteal. Yeah, you might just the balloon is jumping
Yeah.
around a bit as you're doing that
Especially in
dilatation in the
presence
osteoproximal area. Just be
Yeah.
a little careful there.
Yeah, especially in concertina, if you cut, it will cut so much of pajama. This is artery has become a pajama now. So 1.75 bar will cut the whole pajama. You'll not see any artery left after 1.75 bar. So this is folded artery now. This is like a rolled up artery now. So whatever he's doing, I'll fully support. But Dr. Rai has is differently. He's a rota monster. So it should be the best weapon should be, or the strongest weapon should be played by the master of the art, the master of operator. But for the majority, I think stay away from 1.75. Yes. Yeah, so we have one wrestler here. We have one wrestler here, Dr. Rai, but rest are just ordinary man here.
Yeah, the point is, my point is very simple. Say, in a very large artery, if it is tortuous, there is always a trade-off. In a tortuous artery, you need a little smaller bar. But in a straight artery, you take the, larger bar for plaque modification. Say if it is a 4 millimeter blood vessel and you are going with a 1.5 bar, sometimes it does not make that amount of plaque modification so that you can move in with even with IVL balloon. So I would rather, go with a slightly larger bar where the bar to artery ratio I would make around 1.5 to 0.6. Initially, in the initial period of rotablation, it was 0.7, 0.8 for debulking. Now we have come down to 0.5, 0.6. That is important, because not always 1.5 bars are adequate. It depends on the size of the artery.
Yeah. 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 Yeah, it's very easy to catch a man's snake rather than leg. If you have a proximal LAD or left main, you can catch. It's a big neck. It's easy to catch because it's just in front of your guide. So 1.752. But out here, if you really want to catch the leg of the RCA, you have to take 1.75 all the way down to the RCA. It is a hell of a job. So I concur with you, but we have a rota monster and he is one of the best operator here in Calcutta. So he has his opinion, but opinion is all accepted. Go ahead.
Just show us the there we are. We still feel that proximal needs a little preparation because the stent won't expand there. Otherwise, there was a lot of fibrosis there, and we think. Did you use a 3.5 balloon there?
Can we go to Indore Apollo? Yeah, Rajiv, Rajiv, beg your pardon. I leave you there, and we'll go to Indore for the last angiographic view from Sarita. Then we'll come back to you. Sarita, are you there? Yeah, beautiful Sarita. So, show me the result map. Yeah.
Based on our IVUS findings, we've taken 428. So we stand in the right. Next, please. Next, please. You have also taken position. We did a post dilatation. The distal post dilatation will be done with a 4.5 well. We measure the 18 atmospheres of pressure. Next, please. Next, please. Then it will go up, right? And then for the final part, we did it's the 5 into 6. And we got up to 80 atmospheres pressure. Next, please. We check the position with the stent hooks. Next, please. And then we put a final IVUS run. This one, and then next, please. Was the artery at the end of the procedure. Can you please show the IVUS run, Mr. Sagar?
Yeah. Yes. Make it big. Make it big. IVUS. Make the IVUS big.
So we have good opposition. We have no intersections, no geographic miss. Very good. LSA. Now, the distal LSA has gone up to 10.88. At the tightest point, the LSA from 2.4 went up to 9.52. And the approximate estimate, I would say, went up to 15.91.
Beautiful. Eccentric,
Yes.
well opposed, and eccentric. So you get more MLA, but you have to accept the eccentricity. So sometimes you have a circular, but the less MLA. Sometimes you have eccentric, but more MLA. So you can go either way. Yeah.
So I know.
Yeah, 100%. If you have a circular stent with lot of MLA, that is the best scenario. But if you have an eccentric, lot of MLA, may not be that best. But don't try to go for the best, because best is the enemy of good. Yeah. So, Sarita, thank you very much. And this is the way how to present your hospital, the operator, your team in a live case. So, friends, today you have learned the image, the prep, and the delivery, and to finish in time. So you get 10 out of 10. And we really indebted you for your contribution to EICON. Sure. Yeah.
Was great for us too. And thank you so much.
Thank you. Thank you. Congratulate for a roaring success in life, and all the best to Indore Hospital and his heart team. Thank you. Can you go to Rajiv Menon? Then we'll start the lecture.
Yeah. No, that is better. That is better. Okay. Fine.
So as it will take 10 minutes to complete, so we move forward with a live session by none other than Dr. Devdatta Bhattacharya, and he will be covering modern PCI, defining a new standard of care to better more patients' lives. So welcome, sir. And before he takes up the stage, I will request those who are sitting at the back side of the conference hall, I will request everyone to please come forward. वैसे भी हम लोग बहुत सारे online sessions करेंगे, so it will be very much like enlightening for you as well to witness it from the front. So मैं request करूंगी जो भी पीछे बैठे हुए हैं, आप लोग please आगे आ जाइए। যারা পিছনে বসে রয়েছেন সবাইকে একবার করে রিকোয়েস্ট করব, প্লিজ সামনে এখনো জায়গা রয়েছে, প্লিজ সামনে এসে বসুন, কারণ কি অনেক We move forward with a session with none other than Dr. Devdatta Bhattacharya.
ফুল স্ক্রিন করছি, যাচ্ছে না তো, এটা ফুল স্ক্রিন তো হচ্ছে না, কেন হচ্ছে না? পাওয়ার কথা, কিছু আসেই নি তো এখনো। আরে পোডিয়াম আমার চার্জারটা ওখানেই আছে তো।
As we said, the presentation, please allow us some time so that we can just go with very smooth manner. So requesting each and everyone, फिर से जो पीछे बैठे हुए हैं, प्लीज सामने आ जाइए so that we can start off with this session. मैं फिर से एक बार बोल देती हूँ, the session of this is modern PCI, defining a new standard of care to better more patients' lives. So this will be taken care by Dr. Devdatta Bhattacharya, and before he takes onto the stage, what a wonderful session we had. We are ongoing with one more case that we are already here, the live session. So it will take 10 minutes of time. So we will utilize it in a good manner. We will have the open session right now. And then when the time is up for the surgery, we can go ahead and see all the final results here. But as of now, just taking few moments of your time so that we can just set it up and have the presentation on the big screen. So allow us few moments of time.
Full screen. Full screen হচ্ছে না কেন রে? এই তোমরা পেছনে যারা আছো সামনে এসো তো, এই টেকনিশিয়ান আর ডিএনবি আর ডিএম, তো পেছনের রোতে কারা বসে আছো তোমরা? সামনে এসো।
এটাই বেস্ট ছিল, আমি এতক্ষণ ধরে ভালো করে বলছিলাম, কেউ শোনেননি। এবার স্যারের কাছ থেকে একটা বকা পাওয়ার পর সবাই সামনে। ওকে, তো সবাইকে রিকোয়েস্ট করবো, যারা স্যার কিন্তু এবার বকে বকে বলে দিয়েছেন, এবার কিন্তু সবাইকে একটু সামনে এসে বসতে হবে প্লিজ। চলুন, সো আমরা একটু সময় নিয়ে নিচ্ছি জাস্ট সেট আপ করে নিই, তারপর আমরা শুরু করবো আমাদের।
এই ম্যাক নিয়ে সবসময় ঝামেলা হয়, আমার ভালো লাগে না এই জন্য ম্যাকটা আনতে। শুরু হয়ে গেছে সেশন, দে রে বাবা ছবিটাতে। তোমরা কিছু একটা করেছো তাই না, মানে এই তো বেসিক আইভাস ইমেজেস।
উপস্থিত আছেন না তাদের উপলক্ষে বলা, আজকে যখন রেজিস্টার করেছিলেন না আপনারা সবাই একটা কুপন পেয়েছিলেন তো? ইয়েস, ওকে। সো যখন লাঞ্চ করতে যাবেন তখন ওখানে একটা বক্স রাখা থাকবে, ডে 1 এর 2টো কুপন ওই বক্সে ফেলে দেবেন। আপনারা মনে হয় আইটিনারি দেখেছেন আজকে একটা লাকি ড্র রয়েছে, তো তার জন্যই বলা যে ডে 1 এর যে 2টো কুপন রয়েছে সেই 2টো কুপন কিন্তু লাঞ্চ করতে যাওয়ার সময় অবশ্যই মনে করে ড্রপ বক্সে ফেলে देवें। सो मैं रिक्वेस्ट करूंगी जितने भी आए हुए हैं इधर पे जो भी मौजूद हैं सबके लिए, जो 2 कूपन्स आपको मिले हैं रजिस्ट्रेशन के टाइम पे डे 1 के जो दो कूपन्स हैं, प्लीज आप लोग वो कूपन्स लंच के टाइम पे बॉक्स पे वहां पर दे दीजिएगा। वो लकी ड्रॉ पे हम लोग जब डे एंड पे करेंगे उसके लिए लगेगा। सो again just to clarify, please do submit the lucky draw coupons for day 1, which will be placed, the box will be placed right where we will be having the lunch area. So please do not forget that. And we are about to start off. The technician team is here, so it will be solved in no time.
হ্যাঁ, আরে এটা দেখাতেই পারছে না, কি মুশকিল। না না আসছে না কেন? হ্যাঁ তোমারটা বলো। স্যার এটা ওইখান থেকে করাই আছে তো, এটা সরাও, এটা সরাও স্যার বলে দিন, তারপর তোমরা আবার ট্রাই করে দেখো একবার।
এখানেই করা
This one came from the man. Can you get it saved on a?
I think it is always, I feel very small when I talk after Devdatta Bhattacharya. But probably my fate has given me a chance to welcome him here. Anyway, My job is to say a few words about how I do plaque modifications. So, you know that when we started angioplasty, there were certain contraindications to angioplasty as because it was a balloon. And initially we were doing angioplasties only to type 1 blood vessels, type A blood vessels. Now, thrombus containing calcified lesions, extremely tortuous lesions, these were contraindications. And after stenting, and we had a little, air of relief that we can put a lot of stents across. And so our, nights are nicely slept up. But, the demon came later on when drug-eluting stents came, a new subset of disease appeared. One is the in-stent restenosis and the stent thrombosis, all of which requires some modification of the blood vessels so that the stents are open nicely. So then came the concept of plaque modification. Now, how you do it? This is almost an artery which you have shown, we have seen in the live case. And this is a very calcified right coronary artery, which is a extremely tortuous and diffuse lesions we need miles to go across the artery down to the PDA and PLB. So here, what problems I can anticipate? Number one, I told you that if I put a stent across, that stent will not expand nicely, and you will have stent thrombosis or in-stent restenosis. There will be a higher risk of dissection and perforation that people are scared of. Difficulty in passing equipment down the artery. If you push the stents very hard, you will have damage to the stent polymer. Then that damage to the stent polymer will have effects on drug kinetics, as well as the potential stent deformation and loss. Sometimes stents are lost. We have seen that a lot of times. So we need a plaque modification. What is a plaque modification then? It is if you find a calcium, you will have to have a fracture or redistribution of the plaque. Initially, when there was balloon angioplasty era, we have seen that the balloons can pulverize the plaque like a sand. Now, if it is a very calcified lesion, rock-like, balloons are not enough. You need to fracture the plaque. And conventional balloon tears the arterial wall at the weakest point. The problem of balloon is, if you put a balloon across, the balloon will rupture the plaque at the weakest point. That is the between the junction of the hard part and the soft part. And there will be perforation and nasty dissection. Cutting balloon, scoring balloon creates control incision, and then came next. And if we look at look at our shelves, we will find a lot of armamentariums which act against calcium. Of them, NC balloons, cutting balloons, angiocurves, laser, rotational atherectomy, orbital atherectomy, shock waves, so on and so forth. But how a cutting balloon and scoring balloon acts? I told you that balloons are not enough to crack the calcium everywhere because they can break the wall at the weakest point. Where cutting balloon and scoring balloon, if you look at it, you will see that when you do a POBA, you're actually, the area of the blood vessel is as a whole increased. So the vessel area is increased, the plaque area is increased, plaque compression is there, all can be found with POBA. But at the junction of the vessel enlargement and the normal vessel, there may be a rupture. Whereas you use a cutting balloon or a scoring balloon, and you will find that the vessel enlargement is not that much, but the compression of the plaque is almost same. So that is the beauty of the scoring balloon or cutting balloon, and so they act better sometimes. Next is orbital atherectomy. Next is the rotational atherectomy. Next came the rotational atherectomy. So rotational atherectomy initially was used for debulking, is used to ablate the plaque, and then it ablates the plaque as it is moving in a very fast rotation. What it does, it pulverizes the plaque. And when you push a balloon in, there will be a friction. Always there is a friction which will prevent the balloon to go in. But when you use a rotational atherectomy, the bar is spinning across the vessel wall, there will be orthogonal displacement of the friction, and you do not require a lot of support of the guide catheter. So the guide catheters may be hanging, and yet you can have a good rotational atherectomy throughout the artery. So basically, the chance of injury to the vessel ostium is less with rotational atherectomy, and it is an easier way of putting the device down, because the rotational atherectomy can overcome the orthogonal friction and gives allows the bar to enter the blood vessel in a nice way. So it always, that's why I asked that question to the operator. Yes, when you use a larger bar, you have to think that whether that bar and artery ratio is optimum or not. If you have a bar which is only at least half of the girth of the artery, you know that your bar will sail through. That is the point which you need to memorize, because for the beginners, how will you know which will be the optimum bar? You just measure the blood vessel diameter down and choose your bar according to it. If you choose a bar of around bar to artery ratio 0.5, you know that you will be able to sail through. No, nothing will happen. Now, if you use a larger bar, or if you use a very fast rotation, what will happen? It will cut down the lot of calcium, which will not be pulverized. It will be rock-like spicules which are thrown into the circulation, and there will be problems. You can have a very slow flow. You can have a sometimes slow flow may be such, then after a rotational atherectomy, there will be profound stunning of the blood vessels and the patient may die. So plaque modification by rotational atherectomy is facilitated by smaller bars. They said 0.6, but I would say that it will be 0.5 to 0.6 with a lower speed, less than 1,80,000 RPM, leading to pulverization and initial cracks and fracture. Then came the orbital atherectomy. Orbital atherectomy is almost like a jackhammer. It moves in an optical direction, and it is a very slow process because it has got diamonds both in forward and backward. So it cuts when it goes forward and backward, but the movement is always depends on the rotation. If you use 80,000 rotations, the diameter will be less. If you use 1,60,000 rotation, it will be diameter will be double. So don't go to very high speed and go very slowly, go out in and go out, so that you will have a magnificent plaque modification. And I can tell you, when the difference of the two procedure is, after a rota, you can have an artery which is very stiff. You need to use a cutting balloon, you need to use a scoring balloon, even an IVL to have a proper plaque modification. But if you use orbital atherectomy nicely, you will have, even with a 4 millimeter, compliant balloon, you can open the artery at 6 atmosphere, 8 atmosphere. The artery is nicely malleable. You can put any device in. So that is a very important addition to our calcium armamentarium. And also after that, lithotripsy. And lithotripsy is also fine, but again, the lithotripsy balloon is bulky. So you need to have something to allow the lithotripsy balloon to go in and have its effects done. So another very important point is intravascular imaging and IVAS and OCT. And sometimes, and as you go with very complex cases, it would be difficult for you to put a IVAS catheter or a OCT catheter initially. But remember, after the, after you do a rotational atherectomy or something where you can push a device in, before putting any device or before stenting, always do the imaging. So imaging at least do twice before putting a stent and always after a stent. So you know that what is the angiographic calcium, and these are all theoretical stuffs. I do not give a lot of importance to that because it is to us not well as this helps, because you cannot put your IVAS or OCT catheters always before you selecting the bar. That is your clinical judgment, what bar you need to take, and after that you definitely take a IVAS catheter or OCT catheter to for your stent size and for your vessel preparation. So this is another theoretical thing, and I'm not going into it. So this is our small study which we published in Anatolian Journal of Cardiology 2-3 years back, and there we used a single bar and we maintained that ratio 0.5 to 0.6, and we used a lot of cutting balloons and scoring balloons and putting stents, and our stenosis rate is less than 5%. So this is a small study which gave us a lot of confidence that yes, even a single bar with some mathematics is enough to have a good result in calcified blood vessels. So I would rather go some cases. Again, these are, this thing.
We just have to go to the hospital to finish that case, and then you can carry on. Just for a moment. Just ওদের ওখানে নিয়ে গিয়ে let's say them goodbye, and then yeah. So you are going to show us your final results. Okay. কতক্ষণ আছে ট্রান্সমিশন কতক্ষণ আছে? Okay, so you have not yet stented the proximal artery, right? Okay. Okay, we can see the distal part of the artery stented quite nicely. I can see a little region there that is that unstented, that between the two stents? Yeah. So yeah, so the plan is to leave a gap between those two stents and then stent the proximal RCA. Okay. So we will continue with our lecture here, and we'll let you finish your case and stent that osteoproximal RCA and post-dilate it, and then we'll come back to you for the final result. Okay. 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 Thank you. Carry on, Shubhanam.
So can I have my slides, please? So okay. Now what we do, strategy to rotablate the RCA and stenting of the RCA lesion. So what can happen. This is the 1.5 bar, and you see, no, it's a 1.75 bar, and you see that we have done the proximal bit. So we thought that we'd go with a smaller bar to the distal artery, but it is going up to that, and it's not going beyond that. So we thought that, and it was not possible to put the bar in the middle with the help of Dyna. So we dilated the middle of the artery with a scoring balloon, and then we tried to go with the balloon, and it was not going across the stent. So we needed a rotational atherectomy there. So we took a 1.5 bar through a Guidezilla stent starts, I put a DEB there in the stent. And ultimately, I put a stent in the proximal part of the LCX from the ostium, post-dilated it with a balloon. And this is the final result. So we had a nice result. So what is my plaque modification toolkit? Plaque modification is the key for proper stent expansion and future outcome. Rotational atherectomy is the oldest and maybe the primary tool in very severe, tortuous, long lesions, calcified lesions. Rotational atherectomy, once you do a rotational atherectomy, you always need something to support it, like a cutting balloon, scoring balloon, maybe IVL sometimes, and should be backed by proper guide wire bias. If your guide wire bias is faulty, you will land up in complications. Orbital is an excellent tool for the big vessels and very short lesions. Thank you very much for patient hearing.
Thank you, Shivananda. I will probably have some time for questions. Shall we go to the
Yes,
live
please.
case and finish, or shall I give my presentation? Whatever you want. কি
Okay.
করবো?
Sir, we will have your presentation
Okay.
now. Okay, so we will thank Dr. Shubhanand Ray for plaque modification toolkit. And now we move forward with the next section with Dr. Devdatta Bhattacharya. And the topic is modern PCI defining a new standard of care to better more patients' life and IVUS 1, 2, 3 essentials. Can we have the presentation on screen, please?
Okay, so this lecture should have been before Dr. Shubharan Ray's plaque modification lecture, but there was some technical problem. So I will be brief because the session, I think, is running beyond its time. So, pictures are running. Okay. So you can see these are very basic IVUS images. So those who have just started doing IVUS or those who want to learn about IVUS, these are images of normal concentric and eccentric plaques in the top panel. Can I have is this a pointer? So, কতক্ষণ এর 10 মিনিট লাগবে কোনটা রে এইটা না Okay, so what you need to see in this image is three things, and this is the IVUS transducer. This black thing around that black circle is the media. Then this little shiny thing internal to the media, that is the intima, and this bright thing outside the media is the adventitia. And if you can identify this, it is the first step in doing IVUS. You can start interpreting images, because if you can trace the media, that is very important. If you can trace the media, you can interpret images. It is as simple as that, and I will show you why. So this is, you can see this is a normal vessel. There is no plaque. This is the lumen. And remember that the transducer is 1 millimeter. This dia is 1 millimeter. So even if you do not have these markings, you can have a guesstimate of the vessel, of the diameter of the vessel. And you can see these markers here. I hope you can see those markers. Can you see the markers? আরে কেউ কিছু বলে না কেন? দেখতে পাচ্ছ কিনা বলো না? So these are 1 millimeter. Okay. So this vessel is 1, 2, 3.5. Okay. So if you go on to a diseased vessel now, this is a concentric plaque, and you can see the media all around here. And this is the lumen. So the plaque is in between the lumen and the media. So that is the plaque. And you can see it is all round. So it is concentric. You can see that there is a break here in the plaque, and that is due to the wire artifact. So this is the wire there I'm pointing out, and this gap is due to the wire artifact. Okay. And now we come to the eccentric plaque, and you can see most plaques are eccentric. you can see a structure here. Can you see this linear structure here above? It will come back. Just wait a moment. This is a pullback actually. So I'll show you when it comes. There. It will grow in size. There, that's the pericardium. Okay, so you can see this eccentric plaque here. This is the transducer, and you can measure the plaque as I told you. So this is a soft plaque. This is a normal plaque. This is a concentric, and this is an eccentric. And next we come to soft, fibrotic, and calcific plaque. If the plaque here, now you can trace plaque. Okay, so you know how to trace the media, you know how to trace the lumen, and in between is the plaque. And if you see that the plaque is lighter than the adventitia, that is a soft plaque. It is a darkish appearance. If it is more or less the same as the adventitia, it is a fibrotic plaque. So here you can see, I can show you, this is the plaque here. So this is a fibrotic plaque. And on the other hand, if it is much denser than the intima, then it is a calcific plaque. And in IVUS, in beyond calcium, you won't be able to see the structure. So that is how you identify calcium. And you can see that this is a pullback. Again, it starts little calcium here, but as it goes up, the vessel, you can see that this is a concentric calcium which is hugging the catheter. So this is very hard intimal calcium. And as you were seeing the wonderful cases of rotablation, you need rotablation for this type of lesion. Okay. So let me go to the next one. So these are slightly complex images. So you need to know, you need to understand or be able to identify dissections. And just look at this. There is a break in the intima. You will be able to see a break in the intima. And that is I'll just there. Can you see the break in the intima? So that is the dissection. Okay, this is thrombus. This is thrombus here. You won't be able to identify thrombus always on intravascular ultrasound. The HD IVUS is better, but this is what thrombus looks like. Okay, and the last one is hematoma, and this is also very interesting. So I'll play this for you. This is the catheter is coming up. So a lot of findings here. Look at this carefully. So what you will see is there was that. Can you see that? Okay, I'm sorry, this is not very good picture for you. Let me go and see. Okay, I'll come back to that later if I have time. So this is most important. This is stent under expansion and this is non-apposition. So people confuse between these two. Here you can see that the stent is actually opposed to the intima, but if you look at the vessel, in the context of the size of the vessel, the stent is not fully expanded at one point. Here you can see that the stent is more expanded, but when you started, you saw that the stent was not so much expanded, and it usually happens where the plaque is the most dense. So you have to go and dilate this, because if you have a residual plaque volume which is greater than 50%, then you have very bad outcomes in terms of restenosis and stent thrombosis. This, on the other hand, is non-apposition, where the stent starts have not been opposed to the intima, and there is a gap between the intima and the stent struts. And this usually happens in the proximal part of the stent, where the vessel has become large. See, this is the distal part of the stent. As you go up, the proximal part, especially in the LAD, as there are not lot of branches, and you will see that there is non-apposition. This was at one time thought to be very dangerous in terms of stent thrombosis, but little bit of non-apposition is less dangerous than under expansion. What is the danger in non-apposition? So if you have a non-apposed or malapposed stent in the left main, which is a very large vessel, when you go in the next time, you can actually go under the stent struts and you can damage the stent. So that is the significance of non-apposition. And I will come to this stenting bit now. So I was supposed to talk to you about how IVUS works in stents. So what you want to see in IVUS is landing zones. You also see this in coronary angiography. But in IVUS, what you do first is you mark your landing zones, what you think is proper in angiography. And then you start doing angiography from the distal landing zone and you come up. So you want to find a normal segment both distally and proximally, and you want to land your stent there. So this is normal. So this is a demonstration of normal. I think I showed you the first picture. So you can see the media all around. There is no plaque at all. This is a normal segment. However, when you're landing a stent, you will not always be able to find a normal, an absolutely normal segment like this, because some vessels, as all of you do, those of you do angioplasty, a lot of disease throughout the vessel. So you have to find a place which is less than 50% plaque burden. So this is how you do that. You can see the media here, you can see the plaque here, and you can calculate the plaque burden very easily by drawing two lines. And if it is less than 50% plaque burden, it is safe to land a stent here. However, you can see this region, and this is very diseased. You should not land your stent here. And you should not miss this either when stenting, because that would be a geographic miss. So I have 2 slides left. So this is, we have also discussed this. This is a lipidic plaque, this is a fibrotic plaque, and this is calcium. So I need not go through this again. Okay, so you find your distal landing zone and your proximal landing zone, and then you define your stenosis area, which is the most severe. You can see, as we had discussed, there is calcium here. You can't see anything beyond it. So maybe you need to modify this calcium. You can see your proximal landing zone. Typically, the proximal landing zone and the distal landing zone will be more or less the same in the RCA. But in LAD, if you're putting a sizable, a long stent, it will be different. So you can see that the proximal and distal landing zones are free from significant disease. And you can see that there is this very tight calcific disease here. So the plan would be to prepare this lesion and land your stent here. And in between, the IVUS will tell you what is the length of the stent. Okay. So this is your optimal landing zone. So these are certain pictures after you have landed your stent. So here you have landed your stent very well. This is a proximal optimal landing zone. But here, however, this is a pullback. And if you look at this, you will see that there, see, distally there is a miss. There is a geographic miss. So there, you can see there. So as you are coming from distal to proximal, you will be able to see that there is a plaquey area here, which is greater than 50% plaque burden, and you have missed it. And this is what you see when you have an edge dissection. So you can see it very well in this picture here. There, you can see the edge dissection extending into the media. And you have to decide a proximal edge dissection. There could be a proximal or a distal edge dissection. Small proximal edge dissections are less dangerous, but if you have a dissection like this in the distal, you have to stent it. And this is what is called the distal lumen reference. So how will you know that your stent is well expanded? So you measure your distal lumen reference, see what your area is, and if your stent expansion is greater than 80% of the distal lumen reference, then you're fine. And here you can see that the stent expansion, and you can do it across the stent. So this gets done very easily in OCT, but in IVUS you have to do it yourself. And this is the proximal lumen reference, and this is the stent area. So if you have a very long stent, then the proximal and the distal will not be the same. So you should have a proximal lumen reference as well. And this is again, this stent is expanded, but here you can see that this is a lot of, there is this stent, sorry, this stent is the same as this stent, and you can see there is a lot of plaque around this here. You can see the media around here. So this is an under expanded stent, and you want to expand this further. So I think this is the end of my presentation here. So what I tried to show you was what was normal, and how you implant your stents, what is the area where you want to dilate them maximally, what is your proximal and your distal reference, and how you determine whether your stent is actually well expanded by calculating the expansion area with reference to the distal landing zone. And then there are edge dissections that you want to see, and there is in the proximal part of the stent, you can have malapposition, especially if the vessel grows larger. And before you do it, you assess your vessel, you assess your distal and proximal landing zones, and the nature of the plaque at the area of the tightest stenosis, depending on which your plaque modification strategy would vary. So thank you very much.
Thank you.
And Prakash.
Yeah, I think we should move on to the next session. with
Yes,
Rajat.
there's ACTA.
Yeah, Rajiv, are you there with us? Yeah, beautiful. Yeah. Rajiv, you're back with us. Audio? Yeah. Yes. Yeah. So this is Boston IVUS. This is HD IVUS. Yeah. Yeah, it's as good as OCT. Yeah. Yeah, and also the artery is pulsatile, so that means the enough calcium breakage. If you don't see the pulsatility, but you see the circularity, that means the stent is expanded, but you have not broken the calcium. So vasomotion usually nowadays seen with IVL, good rota, and the calcium modifications like orbiter. So that is important, pulsatility. And there are a lot of newer stents which can bring pulsatility back into the circulation, like bioadapter stent. So if you do not have very severe calcifications, still is worth modifying this calcium, because the life after stent, behind the stent as such, the calcium itself, it can grow with time, and there will be some space still can be occupied by this calcium. So whatever you do without modification of calcium, the MLA, like intuitive MLA, will be much less. But if you remove this calcium nodule and the calcium,
This
definitely
is the gap between your two
Yeah,
stents, right?
Yeah.
Yeah. Yes.
Yeah.
But what was your thought process between leaving the gap between the two stents? Yeah, I mean, if the problem with that strategy is that the distal bit of the stent that you want to expand, you have to be a little extra cautious because you don't want to produce an edge dissection there.
Yeah.
Show us the osteoproximal part.
That's
Okay.
hostile.
Okay, yeah, you need to do a 4 mm balloon there. Yeah.
Right. So that's, yeah, thank you. Excellent, beautiful, and really indebted to you for a beautiful demonstrations. It is as smart as your face and your stature. And thanks to that whole team. He works in a very beautiful hospital, one of the best center in the country. With very good setup. Thank you very much, Rajiv Menon. Over to you. Thank you.
Thank you so much. Such a wonderful and amazing session that we had. And I would thank Dr. Bhattacharya for this wonderful session that we had on this. And along with that, we move on to the next session. So this was the end of the previous session. And now we move on to the next session, that being mechanical circulatory support in CHIP. And for this, I would have the privilege of calling upon the following dignitaries on stage. May I request the presence of Dr. S.C. Mondol. May I request the presence of Dr. Neeraj Prasad. May I request the presence of Dr. D.P. Sinha, all the way from Bhagalpur. May I request the presence of Dr. Saroj Mandal and Dr. Dilip Kumar to please come up on stage as the elect panel of the chairperson. And to moderate this particular session, we will have the presence of Dr. Shushila Sripad. We will have the presence of Dr. Chandran Mishra, Dr. Chanchal Kundu, and Dr. Kingshuk Kaur. And we will have 3 sessions, 3 topics that we will be covering. The first and foremost topic that we have is all we need, just AIBP. From Dr. Kuntal Bhattacharya. We will be having him online. So can we connect him here
Over to you,
so that
Kuntal. Indrani Sham, you can join us. Over to you, Kuntal.
Good afternoon, sir. So, I think I am audible.
Yes, you are audible and beautifully visible.
Okay, thank you, sir. I'm just from your hospital because the next live case I supposed to assist. So we're a little bit late. I must congratulate the entire team of AICON for such an excellent and extravagant conference you have arranged. And I must feel privileged to be a part of it. So all we need just IABP, that is intra-aortic balloon pump. So disclosure is none. Now CHIP cases are increasing day by day. The number of cath labs have increased in our country. Now the CABG case has significantly reduced because of smaller size cath lab where bypass surgery is not available. So CHIP number has also increased. So CHIP may frequently suffer intra-procedural sustained hypotension, which in turn jeopardizes coronary perfusion gradient. So that is a very important hemodynamics. And loss of coronary perfusion leads to profound myocardial ischemia, which quickly depresses the already impaired left ventricle and may lead to cardiovascular collapse and cardiac arrest. So if we see the BCIS-1 trial, actually for CHIP, the IABP is not very much frequently used nowadays. Availability of impella across the globe has increased. So the IABP has got a little bit backfit. But the largest randomized trial so far, the balloon pump assisted PCI, yielded negative result in the short term, but demonstrated a 34% relative risk reduction in all-cause mortality at a median follow-up of almost 3 years. So this is the basic differences of different MCS. The intra-aortic balloon pump reduces the afterload. The mean arterial pressure definitely increases. The cardiac power output increases, but cardiac index is not so much increased, maybe in the term of only 0.5 liter per minute. The pulmonary capillary wedge pressure decreased with IABP because of reduction in the systolic blood pressure and reduction in oxygen demand by the myocardium. So these are the temporary mechanical circulatory support which can be used during CHIP, but most of our experience are with cardiogenic shock. So let us discuss a little bit about cardiogenic shock. Now, choice of devices and choice of patient is very much important, and most of the time it is center preference. because in many centers, because of the cost constraint and the availability of the impella is not there. So many of the centers, the patient of cardiogenic shock in primary PCI or in chief elective cases, IVP is the choice. So the factor to consider when and what to advise. If we see the SKY shock stage classification, these chief cases will be under class A because they are at risk or LV is jeopardized and there is no backup support from the other system, like you want to do a left main or bifurcation when RCA is occluded. So this SKY has nicely described this shock stage into a 3-axis model. And with this 3-axis model, you can decide which patient will be beneficial for IVP, because IVP you can keep for maximum 3 to 5 days if there is no vascular complication. In Impella, you can move maximum up to 7 to 10 days, though the recommendation is up to 2 weeks. Now, the cause of shock may be various in a patient of acute MI or in case of selective chief cases. Now, if you consider the MI with cardiogenic shock, most of the time it is multifactorial. The patient may have a multivascular diseases, left main or proximal LAD occlusion, or patient is having occlusion of the RCA along with your LAD. The role of IVP is in decompensated heart failure is better and well proven in comparison to the MI with cardiogenic shock. And the mortality benefit of chronic heart failure with decompensated shock is better with IVP. Almost early IVP insertion gives rise to 84% survival benefit. But the same thing, if we consider in case of IVP shock trial with cardiogenic shock post-MI, we can see there is no significant difference in 30-day mortality, and there is no difference in major bleeding, peripheral ischemic complications, CV, and sepsis. So without revascularization, if we use IVP to do our cardiogenic shock management, then probably the result is not so good. So when you apply temporary device, so all chief cases, if Impella is not available at your center and you are thinking that patient is not suitable for CABG either, so IVP may salvage some of your complications. So this is the device strategy according to the SKY criteria. So up to SKY stage B, and up to C, the IVP used in almost all the centers is covering 50%, and the Impella alone is covering only 18%. So it is the 1,400 patients data, and the decompensated heart failure patient with post-MI, whether patient is undergoing revascularization or not, 50% patient in stage C and stage D, most of the center use IVP, though it is a class 3 recommendation in recent European guideline. So first thing is you should trigger not too late. So when you are taking a patient of shock, whether it is a primary PCI or compromised LV, put your IVP before you start your injection. It is just a matter of extra 5 to 10 minutes. In cath lab, we access from groin. If your femoral artery, there is no calcification, tortuosity, then it is a very easy procedure, and it will give you peace during your procedure. So if patient develops shock during the procedure, the shock precipitates another more advanced shock. So if you see the patient developed a stage C shock, very soon by 24 to 48 hours, the 6% to 20% patient goes into the stage C and D shock. And if it is a further de-escalation of your therapy is not possible, the patient is on high inotropic, patient is having high diabetes, acidotic, then patient may go into irreversible shock stage E. So the early implantation of any device for either a chip or a primary PCI with cardiogenic shock is the cornerstone of therapy. So the careful patient selection is very important, and balance between the risk and benefit should be always keep in your mind. So always consider the hemorrhage, infection, hemolysis, limb ischemia, embolic and thrombotic events. So when you are putting an IVP post-procedure, before removal of IVP, patient should be adequately anticoagulated. So very high bleeding risk patient, this is sometimes not possible, and you have to remove your IVP earlier. Another very important thing is use of CCO catheter or PA catheter. By that, you can measure your multiple hemodynamics and cardiac index as well as pulmonary artery pressure index. And by that, you can guide your therapy, whether the patient is really beneficial for IVP and how much fluid you can give during your procedure or post-procedure. So these are the device configuration according to the hemodynamics. So put a PA catheter before the procedure, see the RV function and LV function. If PI is less than 1, pulmonary capillary wedge pressure is higher, then probably IVP is a choice. If the patient is more seriously affected and there is a biventricular dysfunction with PAPI of less than 1, but pulmonary capillary wedge pressure is less than 18, and there is more RV dysfunction, then Impella is probably a better choice. To improve survival in cardiogenic shock is neither a drug nor a device, rather it is a multidisciplinary approach. A shock team with the help of critical care specialist is also important. Sometimes associated infection and sepsis also can give rise to severe shock, and uncontrolled diabetes with onset of metabolic acidosis, particularly with increased lactate, is another cause of irreversible shock in patient. This is a patient who was received in our emergency with a history of mild chest pain with recurrent syncope. The initial ECG was not very significant, but patient on admission, the blood pressure was 60. There was metabolic acidosis. Then suddenly patient, after 15 minutes on arrival, the patient goes into a asystole and arrest. With the blood pressure of 60, we have taken the patient to cath lab. In ECG, there is no significant changes. But in view of immediate arrest and some chest discomfort, we did a TPI. And in echo, we see that there is RWMA in the LAD. But this is a very peculiar patient. He's a 38-year-old medical representative. Initially, we thought it could be dissection or something else. There is no significant changes in of MI in any territory. So we have taken a shoot, and there is severe acidosis. This patient behaves very badly during your procedure. And this is the angiogram of this patient. The LAD is occluded in the proximal part. The LAD is occluded in the proximal part. Sorry, it is not running. I don't know why it is not running. So the patient is having severe acidosis. And this is the blood pressure with 20 adrenaline, 16 noradrenaline, and with IBP 85 by 37, very poor diastolic pressure. And this is the actual picture pre and post revascularization, the LAD, but the patient is having persistent shock. And ultimately, we have done a CCO catheter. Patient was in a very stormy postoperative course over a period of time. With this hemodynamic assessment, we can see how much fluid the patient needs, how much de-escalation of the inotrope is required. So after a stormy course of 4 by 5 days, patient was successfully extubated with the ejection fraction improved from 35% to 50%. So that is the beauty. With the help of shock team and heart failure team, you can salvage this patient, and early IVP insertion is probably the cornerstone for this patient when the patient is severely acidotic and hypotensive in cath. So to conclude my last slide, IVP remains the easiest and fastest mechanical circulatory support device with the lowest rate of complications and the lowest complexity in post-implantation management. And it doesn't require any expertise or any other associate to do in cath lab. This still makes IVP irreplaceable in all those contexts in which drug therapy alone is not sufficient to support and stabilize hemodynamics, and at the same time, the use of more invasive device is not feasible because of the cost and availability. A small additional IVP balloon volume is a promising option to provide a simple, cheap, and effective increase in hemodynamic support that deserves confirmation in larger prospective studies. But I don't think the IVP trial will be there in future because we have many other mechanical circulatory devices in our hand. Thank you.
Well, thank you, Dr. Kuntal. We know that the IIB is the cheapest mode of support system among all. Impella and all, they are pretty costly. So it's a good bridge for patients with severely jeopardized hemodynamic status. So thank you for your elaborative talk
Thank you, ma'am.
and thank you so much.
Thank you.
Thank you so much. Open session. So any more questions, anything? Any questions? Okay, so thank you so much, Dr. Bhattacharya, for your contribution to EIICon 2023. Now we move on to the next topic, that is ECMO, when, how, and where, by Dr. Arpan Chakraborty. So can we have the presence of Sir here? I will request ma'am to please be in the chairperson panel, because this is the last topic that we have, and post that we will be having a live session again. So requesting Sir, welcome. We have the presence of Dr. Arpan Chakraborty, the topic being ECMO, when, how, and where.
Thank you, organizers, for inviting me. As you know, IABP is a cheaper choice than ECMO. So probably the audience will ask the question of cost instead of how we are using it. But you know, when the IABP fails, the chance of ECMO and the use of ECMO starts. So with that thing, we are just the SKY classification where which we are regularly following in patients, and you know, till it the classic shock, the hemodynamic shock, not leading to hemometabolic shock. Then all the MCS comes into play, and we have to use MCS in that early stage so that they don't go to the deteriorating and the extreme phase. And you know, this is a flow chart which Dr. Kuntal was demonstrating, that where we are using, how we are using this MCS device. Only one thing I want to differ with him, that most of the time we receive patients or they are in biventricular failure or by a severe cardiogenic shock. So probably at that point of time, with some kind of arrhythmias or some kind of peri-arrest scenarios, IABP doesn't do well with those kind of patients, and hence the SHOCK 2 trial shows the IABP was not that helpful. Here you are getting the role of ECMO into the play. And another thing, many patients, when we get them in the emergency, they are hypoxic, their LVF happens, a lot of water in the lungs, and you have no a choice to oxygenate them by IABP or Impella. Only you have to give some kind of support which gives the oxygenation also with cardiac support. So with that thing, what we do nowadays, we just calculate the CPO, that is the cardiac power output, and the PAPI, which cardiac power output is for the LV function and the PAPI is for the RV function. If the LV is fine, you can still go for the IABP. But if you have a biventricular failure, PAPI is down and your RV is not functioning well, what we see very common MI after some duration, the typical cardiogenic shock, probably ECMO scores over the intra-aortic balloon pump. And you know, we have this kind of support devices where ECMO is the thing where I'm going to speak on. And these are the spectrum of other MCS devices, the Impella CP with that tandem heart. But out of that, the probably VA ECMO comes the quickest access after IABP rather than this kind of other therapies of MCS. And we know this can be used in acute heart failure, in cheap, whatever procedures you do, and it can be used as a chronic heart failure also to tide over the crisis and for the some kind of organ donation requiring the heart donation requiring some time. Now, whenever we use the MCS, we forget that we are actually supplying the other organs, not the heart. So that is the important thing. But only problem with the peripheral ECMO, what we have seen, that they supply the coronaries, they supply the cerebrals, and they supply the systemic. But sometimes they cause the effective, they are not very good device for the effective LV decompression, which takes the toll on the patient. Now, coming to the prior to initiation of ECMO, obviously you need to know the horoscope of the patient, that whether this is a likelihood of organ recovery or not, and other problems like advanced malignancy is there, or multi-organ dysfunction has already set in for some times, or a case of known brain injury is there or not. Those are all kind of relative contraindications, because in acute scenario, it is very difficult to differentiate all these things. Now, coming to the advantages of peripheral VA, which is the easiest and quickest. We can put it, if somebody can put IBP in 5 minutes, we can put VA ECMO probably in the cath lab within 20 minutes. That the quick and easy implantation. Oxygen supply is an added advantage. If the patient is in severe heart failure, cardiac failure, his lung is not oxygenating, you can put it that. You will get a biventricular assistance. Here, the Impella and the IBP always fails. Good systemic blood flow used in various etiologies. You can use in chronic situation, you can use in CHIP, you can use in acute situations, and seems to be appropriate for persistent cardiac arrest situation. That is the one thing you have to keep in mind. You need not to have a rhythm to get that VA ECMO to work. You can put them on even on after doing CPR as an eCPR technique. You can put the patient on ECMO and patient can revive after that. So these are the advantages of your peripheral VA ECMO over other MCS. Now coming some cases which is important is Mr. Chakraborty was 46-year-old male with an anterior MI and underwent a primary PTCA with stenting. LED territory was a kinetic, EF was 40%. Next 48 hours, he was more or less okay, but started gradually, BP was going down. This is a typical post cardiogenic shock, post PCI, required some time, inotropic support increased, and we have put the balloon. But even with that, we could not maintain the pressure after 48 hours of PTCA. And on the third day of PTCA, we have to put him on VA ECMO with the femoral root, and the way we are putting just to put 2 cannulas in the femorals and the distal perfusion cannula in the same femoral artery. And we just waited for 8 days till your heart starts stabilizing, and we did that ECMO decannulation on 11th POD, and IBP removed after that. This is a classical example of your ECMO with IBP. IBP took part in the venting of the LV, and ECMO supported the systemic circulation for these patients who actually required a post-PTCA support. Now, coming to the second case, which is again a post-surgical case, but the patient with a LV with a recent MI underwent a triple vessel CABG. Second post-op day, she was fine, but 5th post-op they suddenly developed a VT and VF. Patient was read with a classical scar arrhythmia, or the reperfusion arrhythmia happened, or some kind of this early graft occlusion might have happened. He had a multiple episodes of DC shock given with the CPR. And because we could not maintain her hemodynamic, this is the thing you can see, continuous AF with no ejection. So we have to put her on veno-arterial ECMO, rescue VA ECMO on 5th POD. She was on ECMO for 5 days. The arrhythmia got settled on its own, and we did a check angiogram which shows not much of early graft occlusion, and we could win the patient on from ECMO on 10th POD, and we could extubate it on 12th POD. So these are the indications. Now this is another patient where we found a 65-year-old male in present with the emergency itself with the SOB and chest pain, had a diagnostic of AMI with cardiogenic shock, with arrhythmia, with poor LV function. His BP was low and raised lactate and low urine. We put him on ECMO before taking him for angiogram to stabilize him, and we did the angiogram, and because the vessels are not plastable, so the CABG was done on ECMO after stabilizing him for 2 days, and the ECMO was taken out on day 4th and got extubated on 7th. So you can tide over the perioperative and the peri-procedural crisis in a very smoother way on ECMO, because it takes care of your both ventricle and the lungs also. And this is another case where this is a type 2 DM 52-year-old male. He had an acute MI in another hospital, where they have attempted the primary angioplasty within an hour, but RCA origin could not be engaged. So meanwhile, he became hypotensive and started on vasopressors. pH was 7.11 with cold peripheries. He shifted to us, and after 18 hours of AMI, in the emergency, he had bradycardian hypotension, intubated, ventilated, again hypotensive, not pressure, not maintainable. The lactates went up to more than 10. And there's a classical case of RV infarct we diagnosed. And if you see the echo finding, I think it's not moving. The RV is typically ballooned out with some apical segment, which is probably moving. And see, this is the TAPSE, and it is almost less than 8, which shows the RV dysfunction, very much prudent. And so we we rescued him on femoral VA ECMO, and give some good flow with a good distal perfusion. And day 3, he started moving his RV without any intervention, and we could take him out, just supporting him on ECMO. Now, coming to that thing, another case where we have done he was a 72-year-old left main disease with end-stage ILD. The relative was not very keen to intubate him during that peri-procedural thing, but it was left main was very bad, and he was not the CABG candidate because of the end-stage ILD. So we decided to put him on high-risk PCI. We put the patient on ECMO, and we did the PTCA on ECMO and kept the ECMO for next 24 hours without intubating. This is an awake ECMO, and we actually he recovered after that. So these are the ways the ECMO helps in your cheap or whatever the acute heart failure situations, and it's a cost effective compared to other, like if you ask the cost, it is only 3 lakhs. If you compare with the Impella, it's almost 15 lakhs till now. It's available at the time of emergency. You can jollibly put the thing in the cath lab, provides biventricular support. That is most important. Only problem is sometimes it causes increase the afterload because of the peripheral V ECMO, and it is safe and effective if managed properly. So thank you. This is my take on this.
Thank you. Very nice thought process, encouraging and stimulating rather. Many people still have a lot of negativity about the size of the cannula, the fear of having a lot of blood loss during initial run. Now, my first question is, how do you manage the exit? I mean, when you take out the cannula from the body, is it manual compression? Is it ProGlide initially? Or how do you close the arterial?
So initially, we used to use larger cannulas for the arteries. Now this 15 French has become available, and we have taken out by and pushing it manually. It is very much well.
So 15 French you close by manual compression.
Manual compression.
So that is again
That's a
very,
very
very encouraging thoughts. Like it's not always necessary that post TAVR you have to use ProGlide, 2, 3 ProGlide, sometimes 1 ProGlide. If a ProGlide fails, just manual compressions, it works.
Yes.
So how long you tell them to immobilize their limb?
So we used to immobilize the limb, but the problem is sometimes even with the compression, if the bleeding stops, we check for an Doppler always, because sometimes when you press over there is always a chance of clot formation. So many a times we have to go for a embolectomy. Sometimes we have to keep in that. So that is another problem we have to keep in mind.
So pre-PCI ECMO, pre-PCI Impella, pre-PCI IBP, that should be the message to the audience that it should put it before. Indrani, last question, then we'll go to the live session. Can you connect to AMRI?
Prakash, while this is going.
ProGlide
Yeah,
going.
Subra,
went
yeah,
to
please,
start
please,
some of
please.
this hemorrhage, clot formation and all, bleeding, chance of bleeding and all. These are bit risky things. Have you not used ProGlide or something like
We
that?
have used ProGlide, but it has not given that kind of support. Even with the ProGlide, we got a clot over there, and the embolectomy has been required after this. So ProGlide is not a very smooth technique where we have used, but sometimes many a times we have used the surgical technique of taking out also. But that can be done very well because you just infiltrate locally and take out the surgical and take a stitch over there. You can take this.
Just a quick question, because before we start, it's very important actually once the cardiogenic shock is well established, it's too late. So what would be your message like to identify those patients where we have to, we shouldn't delay anymore and we should go ahead with and put in any sort of MCS?
So to me, I believe in DOT2 ECMO first, then DOT2 balloon, as the evidences are coming. So whenever the patient is having a thready pulse, is cold, and he's not being able to maintain his blood pressures with inotropes with moderate dosage, we should start thinking of that thing, because getting an arrest and putting the patient on ECMO is not a soothing process at all. So put it, do it as you want, whatever you want in the cath lab, give it to me. I will take this out after 24 hours and he will be fine.
Right. So we conclude here. Thank you very much for coming. Hand over the session to you.
Thank you so much, Dr. Chakraborty, for your contribution to EIIC Con 2023. Now we have the live session going
Yes,
on.
Pratik, you're audible, visible, both Dr. Roy Chaudhary, both the centers are nicely audible and visible. So first we'll go to Dhakuria. Please call the session chairs.
Yes, so we have two live session, Amri Dhakuria and Amri Salt Lake, and the session will be on a live case, OCT guided complex LAD PCI, and the operators are Dr. Shubhradeep Kundu and Dr. Kundal Bhattacharya. Chairperson panel, I will request the following dignitaries to please come up on stage: Dr. D.P. Sinha, Dr. P.C. Mondol, Dr. S.S. Das, Dr. Deepak Gupta, to please come up on stage and to panel this conversation and the session. I will request Dr. Shrotajit Shamunto to please come up on stage. So we move on to the live session, and
Dr.
we.
Mondal? Anyway, in that you could stay back. Arupda, you can join us. Arupda, you can join us. And okay, so Arupda will be the expert commentator. Over to you, Supratik. We can see Professor Soumitra Roy, Munir, Supratik, Dr. Bhaumik. So welcome to MRI, my alma.
Hi, good afternoon. Am I audible?
Yes.
Yes. Good afternoon. And the nursing team is moving just here and the cat lab technician Nakma. So the usual opportunities are the beginning of life, which is supposed to be but there was a long segment, very important. So RTA was stated 4 days ago, with a long segment around 48.5. 48 say, within the several second stage from now we have to stay for the estimate to LED. We want to be guided because it's long definition and very regular angular of the business. So can you show the idea, please?
Soumitra, what is the reason of staging the procedure? What is the creatinine level, serum creatinine and LV function? Okay, okay, thank you.
While we plan the disability to have because it was around 2.5 millimeter, we have planned on 2 states, one in the proximality and one extending from that to left leg. But what happened during the menu calibration, we went to 215 menu. With the distal, whether the proximal segment had dissection, distal one is a bit small and proximal one is a bit long dissection. So we are perhaps planning to stay the strategy when the distal should have stayed because we have got insufficient data of driving to value in dissected segment. What is the opinion of the panel and chair?
Yes. Yeah, show us the So it's a nasty coronary, and you have to treat them very gently. And if you produce dissection, definitely if it is flow limiting, you have to fix it with stent. But the drug-eluting balloon also works through dissection. So it has to be controlled dissections. But if it is nasty dissection with limitation of the flow, Indrani, so what's your thought on this case?
So should we go ahead with DB distal or should we change to DS?
DB is a, I mean, like distally, it's a long segment. So
Kangaroo, yeah, if you're, oh, if he's already on ticagrelor, there is no role. But if he was on clopidogrel, definitely is a case for cangrelor on board. That, yeah. So we know you have to image. You have to image. Yeah, image. Yeah. Describe it. So we are seeing the OCT, beautiful OCT picture. Kuntal is the expert, so Kuntal will be the commentator on OCT. Kuntal.
The portion is not very useful because there is already there is enough left to decrease the distal flow. But from each segment onwards, we can see, and we see that around 1340, you can see there is a dissection involving almost more than 3/4. So that is the absolute contraindication for using triangle as well as DPT from media. So whatever you can distal have, we have to teach that. Because proximately you have a plan to put a long state, and if there is adequate distal runoff is not there, there is high chance of thrombosis. So you have to teach the distal, and proximally you can see in the yellow border there is some net pain involvement. But after OCT, you see at around 70, there is just at the ostium, there is another dissection.
Yeah.
Net pain is adequately moving, and we can reach the net pain. This part because actually becoming already high, let's say, burden both in ASEAN and everything. So the comment from the expert.
Yeah, it's a beautiful commentary from Dr. Yeah, beautiful commentary. Thank you, Kuntal. So we can see a lot of dissections there. And now on this view, there is a dissection tongue from 11 o'clock, maybe more than 5 millimeter in length. And these are the dissections. Is there any calcification, Kuntal? I could see some. Yeah. Medial calcification. Yeah.
More than almost 0.8 kilometers.
Yeah.
So, but they have room to expand the stream in the other part.
Yeah.
So I don't think this has some big fun. Because the already produce the section
Yeah.
then going to higher direction. We could kind of see.
Hello, Kuntal, can you hear me? Yeah, actually, what's the exact situation of the left main bifurcation point? Because that will,
You can see each or any error sheet or last sheet in the case of them. So you can see the angiogram. And my comment is whether we can just piece and really ostium or we have to come to the rate.
yeah, that is the issue. That's why I'm asking about it. And what is the angle of origin of the circumflex? Angle of origin of the circumflex.
So he wants to know whether. Yeah. So, yeah, Kuntal, Arubda wants to know whether you have a risk for circumflex closure. You need to put a wire there. So definitely put a wire there if you're. Yeah. Yeah. So crossing is not an issue, but keeping the wire is the safety point. Yeah. So, Supratik, what strategy, or Soumitra, what strategy, Dr. Bhaumik, one by one? So I let us hear from Dr. Bhaumik first, Pradeep. What strategy, what stain, till what up to which segment proximal you will come for the left main, and what size of the stain you take out for the proximal. Distal is not a very difficult thing to choose. Yeah, Pradeep first, then Supratik, then Sumitra. Yeah, yeah. So, Supratik, would you nail the ostium of the LED? No. No, would you come up to the left main or not? Left main or not? So go to the iliocaudal, there is definite ostial lesion, tight ostial lesion. So you have to bring the stent.
But I am afraid, Prakash, that while attempting to stent the LED ostium precisely, there may be some age overlap. I mean, stent age on the plaque, and plaque may dissect again. I'm just afraid. I'm not sharing that this will happen.
I think you cannot avoid doing left over here. From all I've said, LED size is widely varied for us to give two stents. Number two, you cannot really put the stent at the origin of without compromising the background. There will be no chance of psychiatric compromise if you try to avoid it.
And
Yeah, I think I agree with Soumitra that left main cannot be avoided here. It's an ominous sign that the left main may get, I mean, if you really want to nail the ostia, you will miss some segment of the very important, yeah.
distal left main, there is a plaque out there. So
Yeah.
you really can't just put in LED ostium. You have to cover from most probably from the left main to LED, and keeping in mind you have to save the circumflex.
Yeah, right. So you keep on working here, then we'll go to Salt Lake with Subhasis. Can you connect to Salt Lake? Yeah, Subhasis, please tell your story. You're nicely audible. Welcome, Arijit and Subhasis. Yeah. Good afternoon. Yes, yes, you're audible, visible, palpable.
If feedback to industry is everybody, and that is why we have decided to go for angiography of anything to bypass. So this is angiography right, is okay. Minor class non-theoretic are given there, and today's their system shows so as if my calcium before going for the diet, there is a parametric classification and it is even without motion. So we probably would have any doubt that it is a linear calcium and it has to undergo some form of ablation rather than ablation. So what we did is please go to the next slide. So before the 1.1 on which we could take an IVUS but would not cross the tightest part of the artery. But the IVUS looks like they still the portion of the artery that would look up. Can you put the IVUS? We go to IVUS run. It's not unfortunately there is a noise. So this is the free IVUS. We go to IVUS run.
Mainak, are you there with them? Yeah. So this is Boston IVUS again, 360-degree calcium. You keep on describing the calcium. Yeah.
And exchange wire with spine block to send that come to our meeting. But the market is not for the scientific. So we take the microstructure and the mouth of the scientific and from there on we decided to we exchange the molecule wire with the Rukamaki wire. We show the so this is the 1.5 voltage circuit in bar. Now this was Rukamaki. So Rukamaki has made life more easier for us because everything is highly accommodated and so we don't have to use our legs. So this is the initial part. And it was difficult for us to cross the scientific there was a voltage gain around 1,000 RPM. But
Yeah.
And we could
Yeah.
and
Stop for a while. Subodha, don't you think the rota is too fast? Yeah. So Professor Datta said that the rota, what you are advancing, maybe because of the tension and panic, you are moving it very fast. In real life, would have done it little slower. Anyway, so it's not like a balloon, like you go all through the coronary in one go. Yeah. So is it one thing? Giving time. So did you give any pause in between two runs? That's what Dr. Datta has mentioned. And you are also reaching almost to the last break point of the where, yeah. So very careful, yeah. Okay. You are beautiful. Yeah, your voice is beautiful. Your presentation is very beautiful. Carry on. Yeah. Yeah. So he's following all the details step by step, academic, scientifically. So there is a cut in the calcium. Yeah, there's a cut in the calcium. Rota cut. So reverberation at which clock? What clock positions? Clock position of the reverberation so that people can understand. Yeah,
It
6
is
o'clock to
actually
9.
covering the whole circumference. Circumference of the artery. I think the whole circumference is covered. Another question to Subhashish and Arijit, it is the interest of the audience. Can you hear me?
Yes, they can hear.
Yeah, is there any role of lithotripsy in this case?
It is a really non-crossable lesion. Non-crossable lesion doesn't mean that you are not able to cross with the balloon after passing the wire. If you cannot pass the microcatheter, also non-crossable lesion. So really it is a non-crossable lesion, so IVL won't go. Yeah. Okay. So you have a long length to cover.
So this is our plan for today. So after Luta takes the made for the alphas done, the alphas will show the distal engineering diameter of the up to the diagram from the distal engineering we have already calculated the vessel with the speed of balloon. So this is the speed of balloon which is showing
We have been grown up to 60 atmospheric pressure and this shows good expansion on various possible on the we have taken a 1.5 the diagonal and first we have dilated this cyclone of the cyclone is 2.5 minutes below.
By your imaging, what has been the assessment about the length required for the stent?
Right. So would you interrogate the diagonal? If you have a calcium, don't you expect calcium in the neighborhood? Right, right. Maybe in live case you should have you cannot do it in because the time constraint. But if you have the time luxury, you can still go for diagonal imaging also. Go ahead. Yeah, I think you can go for just tap or you can go for DK cross here. So these are the two techniques one must know in 2023. These are more than enough. But keeping in aware, definitely I should do is a large diagonal, single diagonal, and a segment of disease is more than 15 millimeter, 20 millimeter. So it needs to be treated. There's no doubt about that. Yeah, that is all nano cross or mini cross, reverse cross, everything is okay. So friends, those who are watching on virtual platform, you can put up your question in the chat box. Otherwise, you can have question from the floor. Yeah, Jada.
One note of caution to the operators that the guide wire in the diagonal is sitting on a very small vessel. So take care that no perforation happens.
So, Arupda is suggesting keep the wire in the main vessel of the diagonal. Yeah, yeah. Right. So can you go to AMR Dhakuria? Arijit, keep on working. We'll come back to you very soon. I mean, immediately after. Yeah. Can you go to Dhakuria, Amri Dhakuria to Takundu? So friends, this is the 6th live case from. Okay. So he's throwing a wire in the circumflex. Supradeep and Dr. Roy, Sumitra Roy and Dr. Vamik. Can you hear us? Supradeep. Yeah.
Yes, actually, the patient is stable. That is okay. Now, as for your suggestion, the circumference is wide, and the distance change has been done. We take 2.25 kh, 2.25 kh, and synergy. Synergy has been done and nominal pressure, good flow. Now we are planning the mean and proximal LAD. This way. Result after the first stage in the research and the research section.
The
Next. I was thinking if you can do a pot a little bit more. Have you done it? Okay.
Now we are going for a balloon anchor technique. Okay, it has crossed. This is the balloon anchor technique. It has crossed. Wow. We are dilating the strut. So take a 2.5 balloon. Okay, now we are planning to take out the strut dilating balloon. Now we are going to the side branch with a 2.5 NC balloon, and the 3 balloon is already there in the main vessel. We are planning for a SKBI with these 2 balloons. So we are preparing for the FKBI. Our plan is to go to the side branch with a 2.5 into 10 millimeter NC balloon and blowing it up to high pressure of 16 atmospheric pressure. So we have managed to cross. We are preparing for our FKBI. We are preparing for an FKBI. A little bit down, a little bit down, a little bit down. Side branch will a little bit down. Okay. Okay, take the main vessel branch here. Okay. Okay. So here we have positioned the 2 balloons. Now we are going for the side branch dilatation first at 16 atmospheric pressure.
Somebody's head is coming repetitively, who is obstructing the camera. Please stay away.
Interface available, interface visible. Now we are going for a high pressure side branch dilatation.
Yeah, we are getting it very clearly.
8, 10, 12, 13, 14, 16. 16. Okay, now high pressure dilatation with a 3 balloon in the main vessel. 16. 16. Okay, because now we will be going for simultaneous FKBI. Stay there for 10 to 20 seconds. Now deploying it simultaneous. We are going for a simultaneous deployment. We are again going for a repeat inflation and simultaneous deflation. So we have successfully done the FKBI. Please go for the stain boost so that if there is the undilated segment of the LED at the diagonal also, you can go for even high pressure and do an FKBI again.
My advice is to take a orthogonal stain boost also.
Stain boost. Just take the balloon side vessel balloon down. Side branch balloon little bit down. So do you want us to repeat the FKBI?
Yeah, I think that FKVI or you do a high pressure dilatation in the side branch more in the that's important thing. Keeping the 16 fine. Can you take a elocranial view just because it's a not the epic cranial?
Actually, inadvertently, the side branch balloon was pulled a bit more back. That is has caused the problem. So redilatation will be necessary with higher pressure. And neocarina looks to be good.
Yeah, good. Absolutely.
Now we realize that the side branch chain might have been pulled a little bit more into the left knee, and that was creating the problem.
Yeah, those are the limitations. But ultimately, if you have done a good FKBI and finish with a report, the long-term result is not bad.
4, 3, 0. Simultaneous deflation. So we are coming out with both the balloons now to assess the bifurcation. So I think we are running out of time. Our next plan is to go for placing and optimizing it and looking for an IBUS run after the procedure is complete.
So, Arijit and Subhasis, we congratulate you from the audience. It has become sparse now. Many have gone good to the lunch. But whatever you have done so far is commendable. And you deserve a big clap of hands from us. With these words, we have to leave. In the evening, we'll be learning from you about the IBUS result. So it's over. Thank you. Thank you so much. Congrats to the whole team.
Thank you. Thank you so much, sir. So with that, we conclude this live session. 4 wonderful, amazing sessions that we have witnessed today. Now we move on to the Cath Lab technician quiz. And for that, I will request everyone to please come inside so that we can start off. We are right on time. So requesting all the participants to please gather around in the Victoria Hall so that we can start off with the Cath Lab technician quiz. For that, I will request the doors to be opened so that the voice reaches out so that everyone can listen. So requesting all the participants to please be inside. We are about to start off with the Cath Lab technician quiz. We are all set. So I will request Neeta to please come forward and set the score table. And I will request Neeta, I will request you to please come forward. We are starting off with the quiz. I will request each and everyone to please come down to the Victoria Hall so that we can start off with the quiz. And I will request Shapnolina to please get a hold of a mic so that you can just go around and give the mic whoever is able to answer. And can I just have a raise of hands who are participating in the Cath Lab technician quiz? আচ্ছা তোমাদের সাথে আরো কিছু জন এসেছেন রাইট ওদেরকে একটু ফোন করে প্লিজ ডেকে নেবে we are all set because নালে না বেকার আমরা we will be delaying on time এইখান সামনেটা so that they can have a look তাদেরও একটা ইয়ে থাকবে তোমরা কি একা এসছো না there are people with you right Bengali is okay or other language Hindi English Bengali is okay, right? তো তোমাদের সাথে যারা এসেছে তাদেরকে একটু প্লিজ কাইন্ডলি ডেকে নাও কারণ কি আমরা অলরেডি 2 minutes late. And to conduct the Cath Lab technicians quiz, we have the gracious presence of Dr. Debapriya Mondal, who will be the quiz master of this particular segment. Along with him, we will be guiding you everyone that কি কি প্রশ্ন মানে প্রশ্ন গুলো তো স্যারই করবেন কিরম ভাবে উত্তর দিলে প্রাইজ জেতা যাবে এবং what will be the scoring capacity of this. So I will request you everyone to please call your fellow colleagues so that they can come down for the quiz session. We are all set for the Cath Lab technician quiz. সবাইকে ফোন করে দিয়েছো? সামনে চলে এসো। হ্যাঁ, একদম সামনে চলে এসো, বিকজ either ways you have to answer the quiz to win. So পিছনে বসে লাভ নেই. There are good chances of winning if you are in the front row. We are expecting how many of you? No, 4 are here and আরো 4 জন আসছে। তোমাদের কমপ্লিট হয়ে গেছে, তোমাদের সেশন কমপ্লিট হয়ে গেছে, and you are also participating, right? Yes, okay, okay. Just লাঞ্চের ওখানে একবার জাস্ট বলে দে যে আছে, কুইজটা স্টার্ট করছি, পিপল আর দেয়ার, ওখানে ভর্তি ছিল। না না, স্টার্ট করতে বলছি সেটা। না না, কর্ডলেস, সার্কেল কর্ডলেস। To speed up the কিছুই না। সো রিকোয়েস্টিং যারা যারা আমার আওয়াজ শুনতে পাচ্ছেন বাইরে, সবাইকে রিকোয়েস্ট করব, আমরা কিন্তু ক্যাথ ল্যাব টেকনিশিয়ান কুইজের জন্য রেডি। উইদিন 2 to 3 minutes we start off the quiz, and কুইজে কিন্তু আমি বেসিক গাইডলাইন্স গুলো বলে দিচ্ছি। দ্য ফার্স্ট হচ্ছে যে সব থেকে বেশি উত্তর দেবে সেই কিন্তু উইনার হবে। দেয়ার উইল বি অনলি ওয়ান উইনার। সো ট্রাই টু অ্যান্সার অ্যাজ মাচ অ্যাজ questions you can, attempt all the questions if you can, and each question will carry 10 marks. Scoreboard সামনেই থাকবে, so you just need to raise your hands. চিৎকার করে যে উত্তর দেবে তার উত্তরটা আমরা জাস্ট কোয়ালিফাই করব না, যে হাত তুলে পেশেন্টলি ওয়েট করবে তাকেই প্রাইজ দেবো। হ্যাঁ, we do not have a buzzer, but yes, fastest hands up will be like asked the question. So we will have spotters. We do have 2 spotters here along with sir. Sir will be the ultimate decision taker that who will be giving the answers. But as of now, we will be starting off with the Cath Lab technician quiz. We will be starting in 2-3 minutes, requesting all the candidates who are here for the quiz to please come down to the Victoria Hall so that we can start off. Otherwise, we will be starting off with the candidates that we already have with us. ওদের কাছে এটা তো ছিল অলরেডি। Yes, sir. We are about to start off with the Cath Lab technician quiz, requesting all who are here for the quiz to please come down. We will be starting off in with the quiz in 1-2 minutes. So it will be definitely a very exciting session that we have. We have the long run that we are having here. This is ultimately a place where we will be getting rewarded with all the knowledge that we have acquired as of now. But requesting, I have seen so many people coming up for the quiz, but যারা যারা আওয়াজ শুনতে পাচ্ছেন, I will request each and everyone to please come down to the Victoria Hall so that we are about to start off with the Cath Lab technician quiz. Ladies and gentlemen, we are about to start off with the Cath Lab technician quiz, requesting all the colleagues who have been here for the quiz to please report to Victoria Hall. We are all set to start off with the quiz. So it will be an exciting run. But before we start, let me just say, once we start, there will be a very good chance that you miss out on the opportunity that we are giving here. But requesting so that we are waiting for 1-2 minutes so that you can cordially join us in the quiz segment. So requesting each and every one, those who can hear my voice, to please come down to the Victoria Hall so that we can start off with the Cath Lab technician quiz. So we are all set to start off. We're about to start off with the Cath Lab technician quiz, requesting each and everyone to please report to Victoria Hall so that we can start off. Requesting everyone at the beginning, because once we start off with the quiz, it is like you will miss out on points. If you're, I will request both of you are for the quiz. Yes, please do come forward and have your seat here. We are starting off with the quiz. So, ladies and gentlemen, are there any other colleagues of you who are participating here? 2:30 we start. 2:30 we start. Dot sharp at 2:30 we start. We have 5 minutes in hand. Dot at 2:30 we start off. So do give a call, a buzz, whatever is convenient for you, to all your colleagues, so that they can come up and participate in the quiz, because participating from the start, it's very important. Reason being the rules and regulations that we have for the quiz. So I will request all the colleagues, all the friends who are here. We start. Okay, ladies and gentlemen, we are about to start off with the Cath Lab technician quiz. And can we have a huge round of applause for our quiz master, Dr. Debapriya Mondol. And now, let me just give you a guideline about the quiz. No one will shout out the answer. The one who shouts out the answer will definitely not get the point. But the one who raises their hand first will be getting the opportunity to answer. Again, we have spotters here, but the ultimate authority will be with Dr. Mondal. And again, the scorecard is here. With right answers, you will be getting 10 points. And one of our helper will be writing down and jotting down the numbers that you have acquired. At the end of the quiz, the one who has collected the maximum number of points gets the prize. And now, Tata goodbye, taking a short break, because this session will be handled by none other than Dr. Debapriya Mondol, the quiz master of this segment.
So good afternoon, everyone. Good afternoon, sir. We are here to conduct a quiz for our Cath Lab technician students. And thank you, sir, for providing me this opportunity to conduct a quiz here. So for the first time, please sit in front so I can see the participants. Do not mix and match. Please sit in the front rows. Whosoever is participating, please sit in the front rows only. So yes, sir. So this will be a quiz which the plan will be so. There will be 20 questions, 20 one-liner questions, maybe a little descriptive type also, where you'll have to answer correctly the question. If let's say for an example, if I ask you, what is the side effect of so and so drug and where is it being used. So you'll have to answer both parts correctly to get full marks. Got it? So if the question is demanding, let's say, an explanatory type answer, you will have to answer the full question, then only you get marks. So these questions will be 20 questions and the answer should be in totality correct. Partial correct answers will not be taken into consideration. There are no teams here. So everybody is playing solo, everybody is playing independently on their own. So do not discuss with anyone, please say individually. There are no teams here. And once the question is being asked, please raise your hand. If the hand is being raised first, that person will be asked the question. No negative marks. No negative marks. And please, for the sake of time, if you know the answer, then only raise your hand. If you don't know the answer, please do not raise the hand. It will waste time because we have to finish up by 3 p.m. And then after 20 questions are being asked, there will be a set of 9 to 10 image-based questions where again you will have to identify the image and then describe what is it and then the whole part. Not only that this is this image, that's all. You'll have to answer everything. Whatever, I'll show the image, I'll ask the question also and you'll have to answer accordingly. So shall we start? Okay, so can I have the first question, please? Okay, so the first question is this. Please take time to answer. What is hepatoclavicular view? What is the exact angulation? What is the usage of a hepatoclavicular view? Your name, please. Please note his name down.
Shilaito. My name is Shilaito Hazra.
Okay.
Hepatoclavicular is deep aleocranial, 45-degree aleo and 45-degree cranial. It uses for see the view, see the 4-chamber view, and it's also show the cracks of the heart. If you want to see the anterior-interventricular group and posterior-interventricular group, sir.
All of them. Please sit down.
Hepatoclavicular view, exactly, it's a aleo 45 and cranial 45. This is the angle of angiography, and the usage is best to see the VSD. In case of sciatic and inlet VSD, it's best visualized.
That is the correct answer. So please remember, you are partially correct. Hepatoclavicular view is aleo 45, cranial 45, but the usage is specifically inlet VSD, not other VSDs. Specific VSDs have specific views. For an inlet VSD, you use a hepatoclavicular view. So you're not getting any points, as I mentioned. Okay, good answer though. Second one, very important question. Unit of absorbed dose of radiation in cath lab.
Yeah, I'm Anik from SSKM. SI unit of absorbed dose radiation is Sievert.
Second. Don't know. Third. Gray.
Radiation dosage, there are three things. One is absorbed dose, which I have asked in this question. One is effective absorbed dose. Millisievert is the effective absorbed dose of radiation, which is effective for effects. And what I have asked is gray, which is a SI unit.
He was the fifth person.
MSP.
Yeah. So
MSP.
tell me the answer.
MSP, millisievert volt.
No. The answer is gray here. Gray is the absorbed dose. Millisievert is the effective absorbed dose. I have asked only the absorbed dose. So SI unit of absorbed dose is
All are
gray.
wrong. All are wrong. Okay, no chocolate then. Okay.
So please be precise. Define a high puncture while accessing femoral artery. How do you define a high puncture?
Yes.
High puncture means you have the inferior epigastric
Correct. Please give us
artery
the
is
marks.
one point.
So if you puncture above the inferior epigastric artery, that is defined as the high puncture. Correct answer. Which part of the subclavian artery is punctured in a subclavian axis? If you're able to answer how many parts are there and specifically which part will you access the subclavian artery while doing a subclavian procedure. Have you seen a subclavian access being done? Anyone? Answer.
Yeah, I have seen a subclavian puncture. First point is, and second is that which part of the subclavian artery is punctured. So it is just above the aortic knuckle.
No, see, there are anatomically there are 4 parts of the subclavian artery, and you cannot access 3 divisions. You have to access only the specific part. Which is that part?
Scapula and no, I'm
Okay, anyone else? No. So the answer is second part, the subclavian artery. Okay. If you have to access the subclavian artery, there are 4 divisions of the subclavian artery. You have to avoid the subclavicular and the pectoral branches, and then the safest part is the second part of the subclavian artery.
So no chocolate.
No chocolates.
Okay.
Best view to diagnose coarctation of aorta in echocardiography.
Echo to, there is no echo technician here.
Suprasternal view.
Suprasternal.
Okay, then what's your?
Suprasternal. ठीक है, you'll get
Oh,
that.
आगे बोलिस ना, ताले वो तो he was half.
Acha, you
half
green
raised.
shirt. What is the angiographic view for a coarctation aorta stenting? Green shirt.
Coarctation of aorta stenting, sir.
Hmm.
We can isolate that view in LAO, sir, and also we can optimize this ampulocyte in lateral, sir.
Lateral.
Yes, sir.
I think you should get.
Thank you.
Good.
So difference between VZ-Pak and OmniPak, please be descriptive. VZ-Pak and OmniPak.
First, second, third.
VZ-Pak is the isohexol 320 mg per DL, mg per L, or this OmniPak is the iodohexanol, this is the 350 mg per L.
And what is the difference between the usage of VZ-Pak and OmniPak?
Actually, in OmniPak, creatinine in all gender and race respective, when EGF are not less than 18 mg in
Okay.
MT ml per
Okay,
minute.
correct,
sir.
sir.
Okay, good. So you got
Thank you.
one. Thank you. Or
Which drug is used in the calculation of FFR? Please mention route and dose.
first, second, third. First, second, third.
The adenosine.
Hmm.
And for the left system, it is 100 mg per 100 mics, and for the right system, it's 50.
Route. How do you give?
Intercoronary.
Green shirt.
Intracoronary is, sir, 150 micro mg, but per 2 minutes, over 2 minutes, sir, and for right system, 100 micro mg per minute.
Is that the only route of giving intravenous?
No, sir, even IV also.
IV
Intravenous.
also.
Yes, sir.
Your dose was wrong.
Ah.
Your dose was
200 and
Yes, sir.
100 and routes are. And what is the
100.
200, 100, sir?
No, 100, sir.
100.
Right to 100.
And what is the dose for intravenous adenosine?
Intravenous, sir.
Hmm.
Sir, 120 mcg per.
Or no?
Both can be used for intracoronary and intravenous adenosine. Intracoronary, it will be 100, and maximum we can go up to 180. And for IV, it is divided into 3 doses: 140 micrograms per kg of body weight
Per minute.
per minute, and then 160 microgram per kg, and also the 180. If the results come in the gray zone, the FFR value, then we go to 180.
Yes, correct. One of them.
2 chocolates.
2 chocolates. Or no.
So again, a descriptive answer, please be precise. 5 measures to reduce radiation in cath lab. If you don't know 5, don't raise your hand. 5 measures to reduce radiation in cath lab.
5 measures. Start at least one. Yeah, he's the one first.
So first is time, distance, and shielding. So reduce the time and make distance from the X-ray tube source, and shielding is for prevent. So shielding then where the lead apron and every accessory area to prevent as much as you can from the source. And is also another thing is inverse square. So you can do the I1 square. We can reduce the scatter radiation zone by reducing the and optimize the accessory radiation shield zone, like operator shield zone and our protective shield zone, like.
Okay, so what will you avoid? If I ask you specifically, yes, the first hand is the answer. What will you avoid? What specific thing will you avoid? Or you will tell the operator, sir, please don't do this.
Minimize the radiation.
How? That is the question.
So minimize-
Which view? Which view will you avoid? What will you
So
tell?
spider is also is more prone to scatter radiation.
So aleocaudal view is to
Aleocaudal
be
is most
avoided
concerned.
and multiple
Multiple
stent boosts
Stent boosts, sir,
should
yes,
not
sir.
be given.
Yeah.
Prolonged
Let's
stent.
see.
Prolonged
Let's
stent
see.
boost, sir.
Let's see.
Thank you.
What a page is.
So how long do you need to press after removal of a femoral sheath? What is the formula? What is the formula for removal of femoral sheath? It's a formula for sheath removal after a femoral access. How will you decide? 15 minutes, 20 minutes, how will you decide?
First and second.
I think he is answered first.
Okay. First
First
row.
Hmm.
Second.
Actually, it depends on the.
Bushable.
Okay, actually, your question, how long you need to press the after sheath removal of femoral sheath, that depends on the heparin dose first. And after doing SAT, if SAT after some PCI, if for an example, SAT is 320.
Sorry. Next.
No. Right. Partially correct, but let's see the. Suppose I'll give you 6 French sheath, 100 units per kg.
Yeah, so.
How
for
many hours?
4 to 6 hours.
So,
Why?
so the formula is the number of French used multiplied by 3 is the minimum time which you'll have to press, and that too when the ACT is less than 170 milliseconds. That is a standard protocol which is practiced. So please remember, it is number of times of the sheath multiplied by 3.
So 6 means 6 into
18
3.
minutes. So
18?
18 minutes. 6 into 3, 18 minutes.
18 minutes of what?
Compression, sir. Femoral compression.
So for
No,
artery,
no.
artery or vein?
Sorry?
For artery and vein, both are same.
No. It is for the artery only.
So
Venous.
there is a caveat. He's saying your ACT must be less than 180. Then if it is 10 French sheath, like yesterday, I put 10 French sheath for penumbra. So it has to be 10 into
3.
30 minutes.
30 minutes,
Half.
minimum 30 minutes.
Okay.
So,
So that is the cutoff.
so does he get a chocolate or not?
Yes, sir.
Yeah.
And I think he's thinking it's a chocolate.
Not fair, no? Difficult question. That's how we grow. So the next year you come prepared with more
So,
knowledge. Yeah.
sir, this is an interesting question, I think. ST elevation in lead 1, V2 and V3 is suggestive of which artery occlusion?
That gentleman first. That gentleman first.
Sikanto from SSKM, proximal LAD.
Anyone else? Gaji.
LED proximal, mid, distal.
Battery occluded.
See, in normal ECGs, have you seen 1, V2, V3 being elevated? There is a specific
V2,
answer.
V3. The only one.
And what is the sign called? What is the sign called?
Medially occluded.
Huh?
Medially.
Well, say proximality.
So the answer is, see, if you notice 1, V2 and V3, it
Yes,
is
last one. Yeah, you have an
Yes,
answer.
sir. It's probably, sir, highlighted diagonal.
okay.
Is
And the sign is called
a sign.
Difficult.
difficult. So, but
Anyway,
the answer is correct. It is diagonal. It is a major diagonal, 1, V2 and
Yes,
V3.
so you collected 3. Yeah,
This is called a Brazilian flag sign, like this.
right.
Okay, easy question. Diameter of a rotablator guide wire.
First, second, third. First, second, third.
0.09. 0.009, sorry. Inch.
So very careful. I would have not given you.
No, sir. No,
Okay.
sir. I am not completed my answer.
0.09 inch, definitely.
0.009.
0.009.
Take time and answer.
So, you collected so much.
Yes. Goodell-Lubin catheter is made of what material? What is Goodell-Lubin catheter used for? Have you seen GL catheter? And what is the material it is made of?
We haven't seen. I haven't seen.
Gudelevin catheter is used in pediatric studies for right heart study, and it is made of woven dacron. Woven dacron.
Pass.
Which view visualizes the posterior mitral leaflet in an angiogram?
Yes.
Sir, RO,
Degree.
30 degrees, sir.
Close. RO
Close.
45
I think
degrees.
RO caudal.
RO 45 and slightly caudal will give you a good PML.
Yeah,
Please,
very good.
Correct
Keep
answer.
going.
Good. Very good.
Very good.
Maggie gets the marks. Full form of ALA-RA.
That one.
Fully correct.
As low as reasonably accepted.
Arnabda.
Achievable.
No,
Arnabda is correct.
No, the Arnab gets.
Arnabda.
Say it again, Arnab, then, for everybody, clearly.
Arnabda.
As low as reasonably
Achievable. So there are two terminology written here, Crista terminalis and Coumadin ridge. Where are these two structures found?
This one.
Sir, in RA, in sinus venosus right atrium proper, sinus venosus region, sir, posterior right atrium part, in Crista terminalis in the lower part of the limbus fossa orbilis.
Correct. Very good. And the Coumadin ridge?
Coumadin ridge, sir, is probably into the CTI zone, sir. Cavotacrum isthmus zone, sir. Into the
Anyone else?
IVC zone.
What in which chamber? Left, right, atrium, ventricle?
Sir, right. Coumadin
So you're
ridge-
partially correct. Crista terminalis is a structure of the right atrium, whereas Coumadin ridge is a structure which is a marker of the left atrium. When you do, sir will tell us.
When do LA closer?
Yes.
Put this, even then you get a prize.
Thank you.
Wow.
Easy question. Name. Hey, Arnav Dhawan. Name two stents with the everolimus drug.
First, second, and third.
Bolo.
First. Two everolimus.
Synergy stent and tetrilimus.
Very good. Full marks. Sir will give the big prize. What is the full form of Timmy?
Without Timmy, you are.
Thrombolyzed in myocardial infarction.
Okay, so since you're senior, please define a Timmy 3 flow. Define a Timmy 3 flow. Then you'll get an answer. The question is full form, and next part is this. The next part is this.
Okay.
Thank you.
Okay, no marks. How do you take a dual injection before performing a CTO? Please give complete answer. How do you take a dual injection before performing a CTO? So what are the 4 points which you think and you discuss with the operator? Sir, I'm going to take this view, or the operator tells you that I'm going to take the view in this projection. Be precise, answer. Green shirt.
Dual injections.
Dual injection is, sir, actually means, sir, is a intercontinental puncture, sir.
That is all taken. See, everything is done. Now you're the technician. You have to tell, sir, this is the view, or this is the way you should take a dual injection. Which one to be injected first? Should you do what? Should you not do what? How long do you take the first injection? Tell me the procedure. You have seen a CTO, right?
Yes, sir. Yes, sir.
Tell me how to take a dual
First,
injection.
we have to
Because
go
you understand that is the first most important step to do a CTO process, to take a good dual injection. How do you take a dual injection?
So first we have to go through which is the CTO artery, which is been target artery. We have to inject this first, which is the main antegately channel, flowing artery. Then you have to go for the retrograde, whichever the artery is supplying artery. Then you have to inject this left.
Orange shirt.
A partial answer, you are okay, but let's see a better answer.
The antegrade artery should be injected afterwards. The artery which is giving the collaterals, that has to be injected first.
So that is one point. So donor artery should be injected first, and then till what time would you inject, or would you pan?
When you see
Would you
this-
pan?
No,
Why?
I would not pan. I'd only show the segment which is meeting the antegrade and the retrograde.
Yes.
Let's hear from Arnab, then we'll give the prize.
One of the should tell the full answer.
First, we have to analyze the angiography, whether it is at the proximal part or the distal part, and whether the donor artery is predominantly filling the major part of the CTO, that we have to see, and then we have to decide to go. Suppose artery is a medially occluded, and we are seeing from RCA we are getting a retrograde flow. So preferably it will be from septal branch. So PDA through septal branch is getting filled. So then we have to first inject the donor artery till it get fills up to the main artery. Then we will inject the proximal artery, and preferably we will not pan. We will concentrate it only the CTO segment. And if at all, and then we have to go in a precise view. Like if you are doing a LED CTO, then preferably arteriocaudal view, and the other view is the arteriocranial. And specifically, you have to concentrate on the CTO. First, we have to fill the donor artery. Then we have to.
Sir.
I think both should get prize.
Okay. So these questions are being asked because if there is no precision, then the angiograms won't be good. If there is not a good angiogram, you won't be able to do the case. That is why. Cangrelor, sir, I think sir's favorite molecule. Mechanism and usage. Cangrelor. Hey, Gaji, bolo.
What is Cangrelor? No. Right, guys, or no?
Cangrelor, you have seen Cangrelor, right? You have seen used Cangrelor. Who has used or has seen Cangrelor? All of them have seen. We have seen.
You know the answer. Please, you first.
What is Cangrelor? Tell me what is Cangrelor?
Sir, it's probably, sir, ADP synthesis drug, sir.
So what is an antiplatelet drug?
Antiplatelet is
It is an
antiplatelet drug,
So
sir. The
what is
mechanism
it?
of action is, sir,
That's okay. Mechanism of action is okay. So it is an antiplatelet.
P2H will be
Can it be given IV?
Sir, it can be, but mainly, sir, seen in
Antiplatelet?
Antiplatelet, sir.
But IV or oral?
I've seen oral.
Huh?
Sir, it's IV or oral, sir.
So see, this is the only antiplatelet which is available, which can be given intravenous.
That's
It has a rapid
Still you
onset
get a
and
prize.
onset of action. Yes.
Because you're not supposed to.
to.
Yeah, good one.
Name 4 drugs used in the management of slow flow in cath lab. Pushpandu?
Second general.
Picorandil.
Correct. Dosage.
No, absolutely.
Next.
Sister, give me.
Adenosine.
Huh?
Adenosine.
Adenosine.
Sodium nitroprusside.
Good.
Verapamil.
And
Yes.
sometimes you also give adrenaline. In a
Verapamil
very
is also
diluted dose, sir. Okay. Marks to Pushpandu.
good. Adrenaline also. Done.
Okay, so quickly some images. We'll have 9-10 images. Please diagnose properly and give the full answer. Your timer starts now. You'll get 10 seconds.
So, this gentleman.
Inferior MI with heart block, complete heart block.
Any other options? Please sit down.
No, that gentleman, yeah. Blue t-shirt. Yeah, you.
Inferior MI, reciprocal changes in anterior wall.
Okay, so house is closed. Inferior posterior wall MI with CHB. No marks. That is the importance of giving this ECG. This is inferior posterior wall.
You raised your hand too.
No, I was just mentioning, sir, that 3 is greater than 2. So
The only reason why this ECG is be giving is posterior wall. So inferior posterior wall with MI with
So let's
CHB.
hear why lead 3 is greater than 2. Then
It's actually a surgical procedure in case of TOF, less than 2 years of age. When the child comes, then for increasing.
So in any
pulmonary
reduced
blood
pulmonary blood flow.
You have to increase.
And it is a central shunt
connection
from aorta to PA.
subclavian artery to
Yeah, aorta, left subclavian artery to PA. Okay. One of the gets marks.
You want to give some answer? Better answer? Huh?
I think it's modified, sir. It's modified BTC.
Yeah, this is
Modified.
RMBTS.
This is modified BTC.
This is modified BTS.
Modified.
Okay, next question. I'll go to the next question. Identify the complication and the treatment of this. Quickly, this is a something which you have to identify. What is this?
Common femoral artery. Yeah.
This is a perforation.
Why do you say it is a perforation? It is a well-contained thing, no?
It's a maybe a compartmental syndrome.
Okay, next person beside you.
Next.
Aneurysm of the, correct. So this is a femoral artery pseudoaneurysm. Correct, very good.
Oi, oi, oi.
How do you manage this case? How do you manage?
Copper stent.
I'll take
No,
back
no,
the chocolate.
that is not going to fetch you another chocolate. Yeah. Ultrasound compression.
Yes,
Okay.
correct, yes.
Okay, next.
Yes.
Covered stent surgery last.
What is this? Please identify, mention 2 uses of this. You can mention the trade name also if you know. Pushpendu.
This is the dual element microcatheter.
Very good.
Very good.
Very good. The dual element microcatheter.
Thank you.
Usage. Correct. One more usage. You have got the marks. One more usage. So in complex bifurcation anatomy
Bifurcation,
where you
stenting
cannot
and so on.
access. Correct. Pushpendu gets marks. Please identify this condition. This is an echocardiographic image. The first one, I mean, every arrow is being shown, and that is a Doppler imaging. There are subtle points here. Please
Sir,
identify.
stenosis, mitral stenosis. Sir, mitral stenosis.
VSD.
Excellent answer.
Right.
Hypertrophic cardiomyopathy.
Wow.
Excellent.
Excellent.
Excellent answer. So the first image, you see the asymmetric hypertrophy of the interventricular septum. The second image is where there is a systolic anterior motion of the anterior mitral leaflet. The third one shows the same in M mode image, and that is known as a dagger sign. The LVOT gradient shows a dagger sign. So this is a classic image of a hypertrophic obstructive cardiomyopathy. The answer is hypertrophic obstructive cardiomyopathy. This is an image where this is a definite obstruction. What is this?
Oh, first, second, third. First, second.
Mitral clip.
Wow.
So mitral.
So incorrect. बैठ जाओ बोलो.
Plastic ring or something.
Incorrect. Mitral clip.
Take your time. You have 15 seconds. Please identify what is happening, what is the modality, and what has been done. So the first 3 images shows an angiogram. The arrow indicates something. These are certain imaging guidance, and some procedure has been done. What
Sir.
is that?
Difficult. Even I cannot understand. First of all, what kind of
Discuss this. See, please stand up. What is the angiogram showing? What is the arrow showing? Discuss the angiogram.
So arrow showing there is an indentation over there, sir, before diagonal.
So what could be the differential diagnosis of a hazy lesion in an angiogram?
Easily it was spontaneous dissection.
Can you see any dissection coming down? No. So
Coming
this is a specific hazy lesion in a very specific area. What is your
Intramural,
differential
Sir,
diagnosis?
it could be, sir, could be there is a spontaneous plaque rupture over there due to intramural hematoma, sir.
Okay, next.
It may be an eccentric plaque.
Sorry?
Maybe an eccentric plaque.
Correct.
Eccentric
So that
plaque.
is one of the differential diagnoses. What are the other differential
It
diagnoses?
may be a thrombus.
Correct. One more. Very one of the. More importantly, what are we? You can see the image here downstairs. This is a OCT image, and the star marks are denoting something. The OCT image shows there is a
Calcium.
no. See,
Uh,
is anyone willing to answer? Shall I answer this?
May I try some
Yeah? You want to try?
spot of calcium?
So you describe what is it? What is seen in the image? This is a calcium. Why do you say so? What is this image? This is an IVERS image or a OCT image?
OCT.
This is a OCT image. So OCT image shows that there is definite indication of shadowing behind this. These are blocks of calcium. This is shadowing behind this. And this is a well circumscribed nodule. So that is probably a well circumscribed chunk of calcium. And when you image that, you see that there is circumferential calcium with nodules with specific shadowing beneath. And the second image, you see cuts happened. So what has been done there? Do you think a cutting balloon would do that? So an IVL has been done. An IVL has given cuts and finally a stenting result with good apposition. So that is the whole
Take a-
answer.
Both of you and or no.
Please calculate the cardiac output. You have 30
Ah.
seconds.
It's difficult.
Simple formula. What is the formula for cardiac output? How do you do this? Just tell me the formula. I don't need the answer also. Tell me what is the numerator and denominator of the cardiac output. Here, what will be in the numerator?
Basically, it will be a one. If I assume the oxygen consumption is 1, then 1 divided by 2 minus 3. PV
Okay.
content minus PA content.
So this is a fixed principle. The formula is cardiac output is equal to VO2 divided by CVO2 minus CaO2. So in this calculation, 200 divided by 0.15 minus 0.1. Acha, acha. Okay.
I think
That is correct.
if somebody says fixed principle, I'm happy.
Yes, so he gets the answer. Green.
Both Arnab and you.
So probably the last question. Please take time and answer what is happening. This is a very rare congenital anomaly. This is a CT scan which has been reconstructed, and that is an actual CT image. Please tell me what is wrong with this person. This person has presented to cath lab with history of atypical angina. You have done a coronary angiogram. Something was not very right. You also sent the patient for a CT coronary angiogram. Gaji.
From RC.
Okay. Any other comments?
Well. Chalo, chalo, Batraj.
So what is the structure here?
See, the left main is arising from the left sinus. The right coronary artery is arising from the right sinus. But what is being shown in the arrow? What is that? That is a very
Artery of Wilson's.
clue is it is the
Coronary
extremely
crossover.
rare coronary congenital anomaly.
Crossover of
Sorry? No, this is congenital atresia of the right coronary artery. See, the coronary ostium is not well profiled. So right coronary artery ostium is atretic and left system is giving collaterals to the right also. Okay, so this is atretic right coronary artery ostium with collaterals from the left system.
So that's no
Thank
prize.
you, sir.
No prize for this. I think.
Thank you. Thank you.
Clap for everybody. I hope the next year, if I'm there, if I'm alive and then we'll have such kind of quiz and go back and study. I think you're not just technician, you're also helping the patients, saving patients in crisis time. So knowing the complications, helping your fellow colleague, good knowledge of intervention is very important nowadays. My technicians should not record in my statement. They are doing all angiographies nowadays in my hospitals. So it's a matter of training that anybody can do anything. So continuously learn, and radial puncture I don't do. radial angiography, most of the time, just stand by the patient, and most of the time they do. So it needs a lot of support from the cardiologist to share the radiation. Now, if the technician can start doing angiography, basically you are standing there and holding his hand. He's the first operator. So he's getting the most of the radiations. And thank you very much. I think time is running out, and we have, how many chocolates you have got in your hand? Don't lose any one of them. It's precious. If you have 7, so we have announced one prize only. And what do you say? Should you share, or should one prize should go to the winner? If there is a tie, it will be divided. I think this time, since we have announced 15,000 stat, we'll get a check right now. So show me your number. Yeah, chocolate number. 4.
4 chocolates.
8. 3. So
Anyone above 8?
He's the master. He's the master. Please
Okay.
stand up. Give a big hand for him.
Okay. Sheila Jeet, right?
He's coming.
Sheila Ditto. Okay. Sheila
Sheila
Ditto
Ditto.
Hajra.
So thank you very much. And check. So you'll get your check. Please take your position. I'll just sign and
আচ্ছা হাততালির মধ্যে জিএসটি লেগে গেছে, একটু জোরে হাততালি দিন না।
rupees 15,000 cash. I mean on check. You can encash it today or tomorrow. Congratulations. See you again. Thank you.
आज खुश तो बहुत होगे तुम। So basically এই বছরের he has bagged the quiz. আশা করছি next year everyone will be very well prepared with the quiz segment. So I will request এটাকে সরিয়ে দেওয়া হোক. Yes, no doubt the winner 10-এর বাহার, মানে হোলসেলে 10 পেয়ে গেছে। Okay, so now we move forward with the next session, ladies
Alright.
and gentlemen. I will request each and
I can
everyone to
follow
please take your seats so that we can start off with the next session. Requesting each and everyone to please take your seats. And the next session is ECG. For this particular segment, we have the presence of the elite chairperson on the panel. May I request the presence of Dr. M.K. Dash, Dr. Shunanda Odhikari, Dr. Shantanu Nondi, Dr. Plabon Mukherjee to please be on the Okay, so we have the presence of the following dignitaries on the chairperson panel. May I just take a few moments to rename them again? The chairperson panel consists of Dr. M.K. Dash, Dr. Shunanda Odhikari, Dr. Shantanu Nondi, Dr. Plabon Mukherjee. And now to moderate this particular session on ECG, we have the presence of Dr. Devabroto Bera, Dr. Bapaditya Kumar, Dr. Uday Shankar Dash, Dr. Rajat Kaur. And we have the presence of few dignitaries online. We start off with the first session, that is, can LBB pacing replace the conventional pacing outcome-based real-world case discussion? And to discuss this particular topic, we have with us online Dr. Ulhash Pandurangi and Dr. Anindo Ghosh.
Yeah, Ullas, can you hear us?
Dr. Azra, it is such a privilege. Of course, I hear you. You're the most charming guy on the dais
Hear
today. Yeah, can you hear me?
So the audio.
All
Can you
yours.
hear me?
Yeah, all yours. Yeah.
All right, great. So wonderful. I have been watching the show. I know the last time was the quiz program, I think, Hazra. I think there was a very enthusiastic participation. Were there cardiac technologists, somebody?
It's echoing, but you can go ahead, no problem. Huh? Oh, this was meant for the cardiac technicians, cath lab technicians people.
That's great.
Okay, go ahead.
So your presentation, as you said, that it will be taking some time from your side. So I just play the presentation and you can comment accordingly because your network is poor, I guess.
Yes.
Yeah.
And India, how are you doing? At home?
I'm okay. Sir.
It was
I think they're taking some time to run the recorded presentation. We'll wait for it.
How is our friend Uday doing? Uday is a charming fellow on the dais.
Fine, sir. Fine. So looking forward to your presentation, sir.
Yeah, and India, I'm sure is going to present real great.
This is the video, no?
Debabrata is around?
Yeah, I'm on, sir. You're just trying to. This is the video. Yeah, this is the video. No, not this one.
This one is a 0 KB, 2 KB file.
Where you have downloaded.
Uday, Debabrata is around?
Yeah, I can hear you, sir. Just give us some seconds because it's a little bit of glitches. You can open in your own if it is playing. Sound. Just for a second, sir.
Hey, take your time.
No, it's fine, sir. Just give us some seconds. Because of some glitches, they have stuck up. So they're trying to open it.
So Anindya, where are you presently?
Yeah, Dr. Anindo will be presenting in a second, sir. We are just trying to solve the glitch. Yeah, I think you can see it now. Dr. Anindo, can you see your presentation? If you can please confirm.
Wait.
I am seeing Dr. Uday on screen only. Hello, everyone.
Yeah.
Good afternoon.
Sound.
Can you see now?
Uday sir is on. Good afternoon. At the outset, I would like to express my sincere thanks to the organizers for giving me this opportunity to present on this topic, which is, can left bundle area pacing replace conventional pacing? It's a philosophical question, the answer to which can be discussed the entire day, but we have, due to constraint of time, we'll keep it short. Just in brief, the different modes of endocardial pacing currently in use. RV endocardial pacing we all are familiar with, we are comfortable with, and the outcomes have been shown to be very favorable. But as we know, as we grow more and more, we have come to realize that even RV apical pacing is marked with some long-term complications, which can be overcome with conduction system pacing, namely his bundle pacing and left bundle area pacing. How actually it helps compared to RV apical pacing is depicted in the schematic diagram. We can see the normal activation to the his bundle, then through the right and left bundle simultaneously into the myocardium, resulting in a narrow QRS. Compare this to RV apical pacing, where there is a ventricular-ventricular dysynchrony, starts with myocardium to myocardium conduction, crosses the septum to activate the left ventricle, hence too much of ventricular-ventricular dysynchrony, which is overcome by his bundle pacing, mimicking normal conduction, and then left bundle area pacing, which is a little bit down the line compared to his bundle pacing, but gives similar results. You can see the ECG of the three different phase morphologies, strikingly different, wide and narrow, and LB left bundle area pacing with a complete right bundle branch block. So in short, as we start, just to an introduction, it's a paradigm shift in the pacemaker therapy from RV pacing, RV endocardial pacing. It is the most physiological form of pacing, even more than the conventional. IV capture thresholds are higher, and sensing is a problem. His bundle pacing, which is overcome with left bundle area, and hence it is a very attractive option for implanters everywhere. So to begin with, the question, can it replace conventional pacing? The first thing which comes to mind is, why not RV apical pacing? It has been done for such a long time. We know now that from extensive literature and in a recent review written by Dr. Shanmugasundaram, clearly mentions up to 1 in 5 patients with an RV apical pacing requiring a pacing percentage of more than 20% will develop pacing-induced cardiomyopathy over a long term. The effect can start as early as 3 months the mechanisms are depicted in this diagram. We already know atrial fibrillation, valvular regurgitation, systolic dysfunction, and ultimately requiring upgrade to a 5V His-Bond area pacing. Now, before dwelling into the question, we can left-band area pacing replace, or can the conduction system pacing replace conventional therapy? We should keep in mind that this question is basically on two levels, on a personal level and on a generalized level. So if you ask someone, can this happen? So they will say, the first question comes to mind: should it happen? Should it replace conventional pacing? And on personal level, can it? And actually, has it actually replaced already the conventional pacing? So the question can be divided into should it, which is a more generalized question: should the conduction system pacing replace RV apical pacing? And on a more personal note, can it replace? Is based on a personal perspective. And for me, personally, if you ask me on these three questions, it has replaced conventional pacing. So we'll look into it, and by the end of this presentation, we should be able to find the answers to this question. So there are some real world obstacles to adopting conduction system pacing. It's the mindset to begin with. The learning curve, people have assumed that the learning curve for left bundle area pacing will be as long as for a His-Bond pacing, which is not the case. It's as short as 10 cases, and then it becomes you are as good as any experienced operator. There is a myth that only EP electrophysiologists can do it. That's wrong. There are the most important thing which I feel talking to my peers is that there is a time constraint in the lab. The turnover time has to be fast to get the turnover. So RV apical pacing is an attractive opportunity. One of my seniors can actually do an RV apical pacing in 15 minutes, if you believe it, incision, skin to skin incision. However, the left bundle area conduction system pacing takes a little more time. There is ample data, but still randomized data is lacking, and some can cite that as an excuse to delay in their option of conduction system pacing. Also, the resource constraints. If one feels that an AP system is absolutely essential for His-Bond area pacing, and if they don't have it, so that becomes a resource constraint. So we come to the first case. We'll go case by case, and we'll find out whether His-Bond area or left bundle area pacing is actually important. A 68-year-old male, a dual chamber RV apical pacing for CHB initially had a normal EF, now presented with heart failure symptoms. You can see the phase morphology RV apical wide. So in this case, we upgraded the system to a left bundle area pacing. We can see the result. It's not exactly a conduction system capture as seen with this. It's more like a septal capture. But this is in bipole, and hence, because our lead is deeply inside the septum, both sides of the septum are captured equally, and hence the QRS is approximating a near normal QRS. So we can see in this fluoro, the IS1 pin of the RV apical lead has been capped, and the final results are actually quite good, and we are awaiting the follow-ups. And however, the hospitalizations have come down. So seeing this, should CSP be the default pacing strategy? The evidence is building. We already know His-Bond pacing versus conventional RV apical pacing, that freedom from death, heart failure, hospitalization, or upgrade to a 5V are significantly different over a period of 4 years when you compare His-Bond to conventional RV apical pacing. When you compare left bundle area pacing to RV apical pacing, they are still divergent throughout the duration of follow-up, which is around 3 years, where left bundle area pacing is significantly better when you compare freedom from death, heart failure, hospitalization, and upgrade to 5V. When we consider non-selective versus selective, there's not much difference in the two modalities in patients who require more than 20% pacing. And the most important question, which is clinically more better? We know His-Bond pacing gets in a better looking QRS, even better than the left bundle area pacing. But there's in terms of clinical outcomes, there is not much difference. The p-values for death or heart failure, hospitalization, event-free rate are actually seen throughout the follow-up. So there are some pros and cons with His-Bond area study. His-Bond and left bundle extractability has been demonstrated with His-Bond. However, the target area is bigger with left bundle area. The capture thresholds and less sensing is good. The target area is small. His-Bond, it requires a longer learning curve. Thresholds are high, sensing issues are there. in left bundle area. The definition is constantly evolving, and it's just a theoretical, an intellectual point of view used to define the left bundle area basin, which seems to be an obstacle, which is actually non-existent. And we'll see later that EP recording system is not at all essential for left bundle area basin. Just to bring in a new concept, the bundle branch blocks, we can use conduction system in and out in bundle branch blocks also, because contrary to the belief that the bundle branch block will be distal in the conduction system, and actually 2/3 of patients in such bundle branch blocks have the level of lesion at the His, so that can be corrected with His bundle area basin or left bundle area basin. This is a demonstration of a case where who had a left bundle area, who had a left bundle branch block with intermittent CHB. We implanted His bundle area basin just to show the importance of His bundle and not leaving left bundle area apart. You can see at higher output there is a non-selective His bundle capture. Let's see the narrowness of the QRS. As we bring down the output, you can see the left bundle it's a non-selective His bundle basin without bundle branch correction, and then it goes to loss of capture. A second case, a patient with 70-year-old male, intermittent CHB, EF is 40%, non-ischemic cardiomyopathy. Patient had an RBBV at baseline. We used, again, I'm showing his one case again. We used DABA lead, and at the his one data, we got a good signal in the tendon, and at a lower output, it was selective capture of RBBV cap, right bundle branch block in correction, but at a higher output, we could achieve correction and see the narrowness of the QRS and the axis, which is absolutely normal. So still, we know the left bundle area basin fares much better compared to the His bundle in terms of success rates. The dislodgements are also more frequent with His bundle basin. Now, we've already seen we've discussed so much, and in recent meta-analysis also, left bundle area basin significantly better than His bundle basin in terms of success rates, capture thresholds, since the R waves. So the report will see left bundle area basin. Left bundle area basin involves capturing the left bundle or even the fascicles, resulting in an RBBV morphology, lead V1. And if you go deep inside the septum, when the helix actually captures the left bundle, and this ring captures the RV endocardium, we can also get in a bipole configuration, a QS morphology similar to the bundle basin. We start with some case examples. 70-year-old male, 50% ejection fraction, sinus rhythm, LBBV, a little wider QRS, had intermittent CHB. QRS is typical LBBV. We did His bundle, left bundle area basin with the Medtronic lead. You see the depth of the lead in the septum. It's quite deep in the septum. It resulted in the narrow QRS, the incomplete RBBV morphology. This is the case which we could have done well with an RV package basin, but we see here the QRS is already broad. The patient is post-CABG, has structural heart disease, has a high chance of getting into a pulsing-induced cardiomyopathy in the future. So, and this doesn't take any time, as we see later in the presentation. So, left bundle area pacing with newer tools, that is the main question. It's still a stigma in many of the operators who use among the general cardiologists how to use the newer tools. And this is just the Biotronic tool. We map in RAO. We look for the characteristic W configuration, V1. The axis has to be good enough. V5-V6 has to be positive. 2, 3 are positive here. 2 should be more positive than 3. AVL, AVR should be discordant. We check the dye in LEO view, perpendicular orientation, and then we extrude the helix first using the rotation. So the IS1 well. When the helix is out, we use something called the stilt introducer tool. We are not going to go into the details of the implantation, but as we go in slowly, slow rotations and a fluoroscopy, we can see it going into the septum. See it has moved in, and ultimately we confirm the depth by a septogram and then the procedure. The result as we go in a Biotronic lead or any stimulative lead, which is an advantage that the pacing morphology can be tested throughout the penetration as we go from the RV endocardium, mid septum, and ultimately the the left bundle. You can see the morphology. We started with the W configuration. As you go in, the north moves up, 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 and it goes away. We do the QR, and eventually in R, we actually reach the extreme LV segment of hardening. And this is possible because continuous monitoring is feasible with this limit. And you can confirm, as we already showed, we were quite deep with the septum. You can confirm the ring capture and the tip capture. We can see in the ring, V1 showing the QR, and in the tip, at the tip, we had a QR, and at the ring, we have a W morphology, which showed the point where you actually went in. And also, we can show decremental output tracing, showing QRS morphology change from QR to R. So these are the different criteria for left bundle area pacing, which is beyond the scope of this. Now, another tool, which is the Abbott tool, which is a deflectable mapping catheter. The use is it has only a primary curve. The problem, which is on many operators, it can be corrected with a simple reshaping before the procedure, and the results can be as good as the other two vendors, Medtronic and Biotronic. Here we can see it's going into the septum. The problem is without the curve, it reaches only the distal septum, and hence the access will be little in the superior axis because we are considering the distal septum. However, the results are good. There is some classical capture the tip to the QR. The intrinsic already was a narrow QRS, and the ring, you can see the point where we started going in CW pattern. At the baseline, we got a fascicular potential at the sleeve tip also. And as we go in, you can see the morphology changing from W and not moving rightwards again to a monophagic R. Now, what is the way forward with the conduction system pacing, specifically the left bundle area pacing, is rolling heart failure and beyond the EP system. In the rolling heart failure, conduction system pacing, left bundle area pacing can fortify. ICD therapy in terms of not ICD or not ICD, it can also fortify CRT therapy. It has been previously shown that his bundle and BIV pair equally in terms of the QRS shortening and changing and follow up. But recent evidence, absolutely recent evidence for Dr. Pugal in the recently conducted HRS shows compared to BIV left bundle area pacing, there's been significant reduction in QRS duration, QRS area, and mechanical disynchrony parameters, and also hemodynamics. So this is a new frontier. Only problem is this is a study which is still retrospective. It's not randomized, but nevertheless brings out important perspectives. Also, Dr. Shanmugasundaram from that Madurai study brought India into the international platform. This HRS. He showed the feasibility of left bundle area pacing in patients with non-ischemic cardiomyopathy and low star body with excellent results. So here we go. Before we end, we see some cases. Patients with CRT indications, syncope, CRTD indications, LVE at 30%, ischemic cardiomyopathy, LVDB and baseline. Options of conventional BIV, not ICD, not CRTD. What we did was we used a DF1 generator. We placed these in the CS. We placed these in the RVF Apex. We placed one in the left bundle and RA. And the conventional BIV was okay, but not so good. As we saw in the study by Dr. Pugal, the QRS duration with conventional BIV may be a little longer compared to left bundle area pacing, which we'll see just now. Conventional BIV resulting in this configuration, and that is possible because we have a 12 lead in the EP lab. Other one is left bundle area pacing plus RV apical pacing. We are comparing these two. The results may not be so okay because already the left bundle area pacing has been in the R morphology. So we can see the results are good, but not as good. So with left bundle area alone pacing, there is the QR in V1 looks narrow. It looks narrower than the previous two configurations. But when we compare the previous configuration also with this left bundle plus and LVV3S lead, the results are absolutely good. So in this case, we finally programmed left bundle plus CS configuration and the RVF pattern defibrillator lead pace sense was capped. There's another case with the CRTD indication, monomorphic VT post PTC initial cardiomyopathy. The intrinsic QRS is actually narrow, but you can see the PR interval is so long, it's non-physiological. Again, the options remain the same. We implanted, we tried a CS trajectory, but the anatomy was not suitable. We did his bundle pacing and see the result of it. It was an absolutely narrow QRS. So again, the generator used was a DF1. The pace sensor, the RV coil was capped, and the his bundle we went into the pace sense port. So we saw how it had been the conduction, it has been heart failure. Beyond the AP system is something which all cardiologists would strive into. It is possible, it is not actually required to have the AP system working by the side all the time. The 12 leads from the patient to go to the hemodynamic monitor, which we have in all our labs, and it can be directly connected to the PSC also. So even if you don't have the 12 leads, if you have limb leads and V1 without V6, you can still do it, because V6 in the which is used to measure the left ventricular activation time. The same measurements can be obtained from the lead 1 and AVL, which we have seen from our data retrospectively. And if the axis is rotated, the V6 LVAT on the RV peak time is almost as good as one in AVL. An acceptable angiogram also facilitates targeted exploration of a lesion. For the injury and potential tissue we previously used to see from the EP system and we realized from the PSA. We have an experience of around 15 patients now. This was a while back. So we have had procedural success in all the procedural time is good. We have done majority of patients in AV blocks. It was an uncomplicated implant. We have not used it in CRTDs or CRTD blocks, CRTDs and CDs. We have with both kinds of leads in patients, and you can see this is the hemodynamic screen print. I have limb leads. I have only V1. I see a notch in V1 where I'm about to go in. I just do a septal angiogram to see the orientation, and then as I go in, I'll see on the hemodynamic screen the morphology changes. And after I go into the septum, I can see from the PSA the injury, but in the tip injury more than the ring injury, which is required. There is an R developing in the V1 post group and post procedure day 1 when we do the ECG. It's like more of a conduction system capture with mid septal pacing capturing both the left and right bundle simultaneously. Here's another case with the previous case was the this is with a humanless lead. Again, there is notch which can be seen in V1. We don't need an AVL V6 for LVAD because we have lead 1 and AVL providing us with good RV peak times during the septal penetration. We could also get a RBV morphology template. So we stop there, and that's the penetration could be demonstrated both tip and ring capture. You can see in the tip there is a QR, in the ring shows a W pattern. This is the pre-screw septal angiogram. The result was absolutely fine, as good as with an EP system. So this is a short video. I'm actually exceeding time. You can see the morphology changing during screwing, investing of QR, and that is the beauty. Without the EP system, it's possible. But however, it's not always a bed of roses. It's not always a smooth path when we are implanting a left lead. Sometimes something like this can happen. You go on screwing, the lead buckles. There are no way going deep into the septum. You just push the lead. It ends up coming away from the sheath. There is too much buckling. The orientation, how much soever you change, simply doesn't go in. It is because of the entanglement effect. The fibrous capsule over the RV endocardium may entangle your lead helix, and you may rotate at a single place on and on and on. There will be a torque developing in your hand, and it will simply not go. At such instances, you need to change the implant site. And even after sometimes trying multiple cases, you may have to resort to a conventional pacing. As we discussed, the learning curve is too much for his bundle pacing as we thought, but with left bundle area pacing after 10 cases, it seems to reach a plateau. and that is a good, good news for general cardiologists. I personally took around 10 cases to get into the two. So as we started, the question was, can it replace conventional pacing? We divided into 3 questions. Now we know it should replace because of the complications associated with RV apathic pacing. Can it replace? Definitely it can replace, because we have shown that it can be done without the AP system. It can be done by anyone with within a short learning for 10 cases. And has it replaced? May not have replaced, because the stigma, this obstruction, this time constraint of the lab, pushing this back and not getting into the pool has actually created a big obstacle. So in the real world obstacles, if I may, there is only one obstacle. We don't have randomized data. All others are actually unexcused from our own side, not to go deep into this issue of conduction system pacing. So can local area pacing replace conventional pacing? Definitely it can. Thank you so much. And
Okay, so we have few questions. So, yes. Sir, yes, you can use this mic. Can we have doctor online?
Hi,
Yes.
Ullas.
Yeah, so it's a great presentation. Don't you agree, Dr. Azra? So he's an expert. So we can take up some questions.
Yeah, but before Yadav comes in, I was thinking, Sonip here. So we have not met for a long time. I was thinking of 2 issues. One is that definitely when we are putting a pacemaker, even in patient who no manifest heart failure, but a wide QRS, ultimately we wanted the QRS to be narrow. And last 6 years, I am not doing any apical pacing. I am giving a septal pacing. I found irrespective of age, we get a very good threshold. Okay, what you see online on the table that QRS is narrow, when they come in follow-up, it doesn't reflect into that. But probably it is better than a LV RV apical pacing. Now, the issue is my practical experience is I burned finger once. I got a progressively high threshold in another case, previous anteroseptal MI, but not a scar or basal septum, anything. I didn't get the appropriate areas where I got a very high threshold. Now, hope. These are all the matter of I cannot just conclude and I cannot get disappointed by your 2-3 cases. Probably it all depends upon the hardware and the experience. So just I thought that I am going to share with my experience. Still, I am not been able to pick up this new and marvelous technology, which is scientifically been proven. So is what the trial has shown, the way they have done, we are doing in a different way? Are we making some shortcut? That's why my outcome is not good. Or as I am not a dedicated EP person, that's why my shortcoming. Just these 2 questions. What is my shortcoming?
So Anindya, you think I can address this question?
yes, please, sir, please.
I think his observations are great. But if the question here is it something to do with the EP knowledge, which gets the success rates higher? I think Anindya drew home a point. It is not necessary. Any implanter, any cardiologist who had been implanting the pacemakers, he can do this. This is what Dr. Anindya had shown. You don't require an EP system here. It is just that you need to be, persevering for longer time. And there are certain things where you are actually going to be starting, screwing the lead is important. Anindya was trying to tell that the his bundle probably is going to be a little difficult for the beginner. But the left bundle, he was saying that could be easier. So he could start from the left bundle area, and then Anindya, I think you had shown the point where you should start screwing. It is that particular notch in the V1. So if you have just the V1 electrode, it's great enough to observe that. And you should be looking at the limb leads. And then you have, I think usually you will have 3 leads, lead 1, 2, 3 are the ones. And if you also have, say, for example, AVR, AVL, which could be seen on the hemodynamic monitor, it would be good enough. You will have to get some notch either on the left side of the QS pattern or at the nadir. You should not start screwing unless you have a notch in the V1, and the AVR, AVL should be having some discordance. And one of the inferior leads at least should have some positive R wave. So if you follow this, I think it should be okay to get a good result. As long as you are not having these things, you should not start screwing. I think Anindya also drew one more point home, and that was, don't go on persisting at the same side screwing, because he said there can be, kind of an entrapment into the tissue. And there are a couple of more mechanisms. If it is not proceeding, don't go on screwing there. You just take it out, clean the tip, and then restart. So EP guy alone is not authorized to do this. Any implanter can do it. And do not start screwing unless you have, this kind of morphology. These are the 2 things. If you follow, I think the success rates are going to be high.
Thank you. Thank you so much, sir, for your contribution. Now we move on to the next topic, and the topic being case of LV pseudoaneurysm closure by device by Dr. Ramdev Yadav from Delhi. So we have him on screen joining us online. So we start off with his session.
I have shared the screen. Are you able to hear me?
Yes, sir.
Yes, sir. Just I want to show it full screen. I don't know how to do it. Just a minute. Full screen. Are you able to see?
Yes, sir.
So this is post MI, left ventricular pseudoaneurysm closed with ASD device. This is one of the rare case where we have usually indicated is surgical closure by the surgeons, by opening the heart. But this time we have closed with the device. So this 56-year-old male having old inferior wall myocardial infarction in 2010. He underwent PTCA and stent of RCA and LAD. He developed dyspnea class 2 with angina class 2. Clinical examination showed systolic murmur at third left intercostal space and at apex. So echo showed large pseudoaneurysm of the LV on the lateral wall near the mitral valve, compressing the left atrium. CAG showed LAD before stent 90% stenosis. So sent to CTVS surgeon for CABG and closure of LV pseudoaneurysm. Cardiac surgeon opened the chest, put graft, but could not able to close the pseudoaneurysm due to lot of adhesion. They were afraid of opening the adhesion and causing the bleeding from the LV. So surgeon closed it and referred back to us for device closure. So this is the pseudoaneurysm. It will be seen better. This is RAO view. This is best seen in the LAO cranial view. Filling on the posteriorly, there's a huge pseudoaneurysm around 7 centimeter wide and 10 centimeter length, more than 10 centimeter length, and there is a hole in the posterior wall of the lateral wall of the LV. So what we did, we crossed with the right coronary artery and thermo wire into that pseudoaneurysm through retrogradely, and then exchanged it with the made a loop, Cook extra stiff wire, and made a loop inside the pseudoaneurysm, and then put 10 French delivery sheet, ASD delivery sheet from Amplarger, that is torque view sheet, across the pseudoaneurysm, inside the pseudoaneurysm, and then took 26 millimeter ASD device from LifeTech. First deployed the aneurysmal part, the distal disc, and then checked in the echo that it is closing, it is near, and then release the right this LV disc on the disc on the LV side, 2 LV side, and then checked with the LV angio that it's closed. And then there is a problem that whether the LV umbrella is impinging on the chordae of the mitral valve and causing some MR or not. So we checked in the echo, there was eccentric MR and left atrium is already closed. We'll show you after that. So this is angio in the RAO view, no flow into the pseudoaneurysm anymore. So we put your catheter, that is Swanson catheter, into the pulmonary artery to know the pulmonary capillary wedge pressure. And what we found, the pulmonary capillary wedge pressure was below 20. And so we released the device and then checked by the echo and everything. The flow through the pseudoaneurysm was closed without any complications. And then we checked in the, and we closed the femoral artery by using per closed device. Here, this is the echo. This is the LA, which is almost compressed. And this is the device. And mitral valve flow is okay. It was not any problem. And this is the device here. And this is the whole pseudoaneurysm compressing on the LA. This is another, this is pseudoaneurysm, and this is the device. This is the LV side. There is no significant, this is the mitral regurgitation flow, which is mild and eccentric, post-eccentric. Yeah. This is same echo showing the isolation. And yeah, this is the MR. You can see posteriorly directed MR. LA is already compressed, slit-like. But now the patient is doing fine. He's totally asymptomatic. He's having no symptoms and no any murmur on the chest. So this is the how we can close the pseudoaneurysm of the LV without surgery by device. Also, when the patient, when the surgeons fail to close it. So this is summary and conclusion of my topic is post-MI development of pseudoaneurysm is a dreaded complication, leads cardiac sudden death due to contained rupture in the pericardium, leading to cardiac tamponade and death. Those pseudoaneurysms which are contained rupture chronically get fibrosis around and patients survive. These pseudoaneurysm needs to be closed by open heart surgery, but in our case, surgeon could not able to close due to severe adhesion, returned back to us for device closure. Therefore, we close this large pseudoaneurysm with device with complete exclusion without any major complication except mild eccentric MR with pulmonary capillary wedge pressure 21 millimeter of mercury, which later decreased to around 15 millimeter of mercury due to mild MR and LA compression by the pseudoaneurysm, which LA compression with progress of time will depress, will go away and LA will expand again. Thank you.
Thank you so much, sir. Any questions? Can we have the sound, please?
Answer. Let me answer. Stop, sir.
Yeah.
Sir.
You're okay.
All well, sir.
Good afternoon. Thanks. Great presentation. So I have two, one question and one comment. First comment is you have been blessed by having a pseudoaneurysm with a good adhesion. So you could confidently manipulate your wear and all without any perioperative issues.
Yes.
The second thing is how you size the device. You go by the echo or you do CT or MRI. You did anything?
Here we did echo and we sized with the echo and echo showing 18 millimeter defect. So we choose 26, 8 millimeter more, 4 millimeter on either side because the LV disc LV disk is smaller as compared to a pseudoaneurysm disk, distal disk in ASD device. So we choose slightly higher size so that it impinges properly, because other people have tried it close with pseudoaneurysm from Dr. Jain from Hyderabad, and it device embolized into the pseudoaneurysm and ultimately underwent surgery. So to prevent that, we oversize more so that it impinges properly to the margin of the pseudoaneurysm and should not embolize, because if LV proper disc is bigger than the pseudoaneurysm disc, then it could have been easier, like which occurs in your PFO closure device, where RA disc is bigger than the LA disc. So here it is not like that. That's why we used oversize by 8 millimeters.
Thank you so much. Thank you, Dr. Yadav, for your contribution to EIICCon 2023. Thank you so much. It was lovely having you.
We'll join again at 5:30. Okay. Okay, madam.
Thank you. Now we move on to the next topic that we have, the next session we have. For that, I would request the presence of Dr. Sanjeev Mukherjee to please come up on stage, and the session that he will be covering is effective use of latest algorithms can improve patients' outcome. Case-based discussion on different algorithms. So we have the presence of Dr. Sanjeev Mukherjee here. Okay, so before we move forward, so we have similar topics that will be covered. So I will club with the permission from sir, we will club two topics together. So you being the speaker of this particular topic, I will call upon the following chairperson on the stage. May I request the presence of Dr. Shivananda Dotto, Dr. Jayant Raja, Dr. M.L. Bansali, Dr. Bhaskar Gupta to please come up on stage, and the moderator of this particular topic will be Dr. Mayank Agarwal, Dr. Ritarendranath Tolapatro, Dr. Shumanta Chatterjee, Dr. Shubhra Shankar Chakraborty. So I will request all the elite dignitaries to please come up on stage. Our topic of discussion is effective use of latest algorithm can improve patient outcome, case-based discussion on different algorithm, and presenter will be Dr. Sanjeev Mukherjee. Along with that, we will be this topic will be followed up by why AI cannot replace the cardiologist, and this particular topic will be covered by Dr. Debashish Ghosh. So we are clubbing two topics as they are very similar to each other. So now we start off with the topic session by Dr. Sanjeev Mukherjee.
Thank you. I thank ICON for giving me this opportunity. We are anyway running late, so I'll quickly go through this few algorithms. And I have selected CRT only, which is something that has got these newer algorithms which are going to help optimize the devices better. So I think time is less. We'll first discuss only the algorithms and not the case. So this is a very standard and a great paper, landmark paper from JACC, which clearly showed that the major reason why we have non-responder status is mainly because of optimization issues, right? This is what we have. Your optimization suboptimal AV timing is the main reason why we do not get, or we get non-responders in CRT, which comes to about 25 to 30%. And followed by that, you have got other etiologies like arrhythmia, anemia, right ventricular dysfunction, lead not in place. Those are the other things. But primarily, the problem that we have is suboptimal AV timing, and that is something that we need to kind of concentrate when we put a device. Now, quickly cite some amount of physiology before we get in, and so that we know how we optimize our devices. And this is what happens in a normal individual. Now, if you look at, I think all of us know very well that this is what an ECG and this is your mitral Doppler that looks like. You need to have an adequate diastolic filling for having a proper output. And diastolic filling, if you look at the mitral Doppler, is found by an E and an A. A is the atrial kick and E is the earlier filling. So this is what you need to have in a normal individual. What happens when the patient develops a left bundle branch block is there is a kind of fusion that happens between the E and A, and there is kind of shortening of LV filling in diastole, which is what is something that we need to correct. So that is what we do when we put a CRT. We try to kind of optimize this. And as you all will know that most of the time we'll put the device, we'll forget it. But if our patient is not responding, then this is something that we need to go in and sit in the echo lab to look at what is the mitral Doppler looking like. And we must try to get this kind of E and A wave. Now, you can play with a lot of things. You can play with the AV intervals. You can play with interventricular delays. But if it is important to have an optimal AV delay, because if you have got a very short AV delay, your A will get curtailed. If you have got a very long AV delay, you're going to have fusion. So you need to program in an individual an appropriate AV delay to get an appropriate LV filling. Now that will be different in different operators. So are we doing it? Now that's the question. Now, if you look at the data, answer is absolutely no. They found that only 13% of devices are being optimized with use of echo. And the reason why these devices are not optimized is either time or because there are no qualified individuals. And that is what I think the time when companies got into and thought that it's better to have algorithms than depending on the cardiologist, who usually will not have much of a time. So I think that is how these algorithms have come into play. Now, what happens in a conventional BiV? In a conventional BiV, this is what happens. You kind of take away your normal conduction by the leads that you have put in. You are going to paste from the LV lead and the RV lead, and you're going to fuse both. So your intrinsic conduction, and most of our patients who get a CRT will have preserved intrinsic conduction. There is a very small subset of patients who will not have intrinsic conduction. So what we do, we put a CRT and we take away that intrinsic conduction. So the algorithms that are coming are going to utilize that. What they are going to do is they are looking at how best we can utilize. If you have got an intrinsic conduction, utilize that and try to fuse with one of the leads that you have put in. Allow the intrinsic conduction, fuse with one of the leads. That is what is the whole idea. So the goals of optimization are, you need to have proper AV delays so that you can have a good EA relationship. And there is one last line, dynamic preferred. The reason is very clear. You have put a device, you have programmed the AV delays, but remember those AV delays are at rest. The moment the individual is going to walk, he's going to do his activities, AV delays will change and synchronization might change. So that is where these algorithms are doing better, because they are trying to make it more dynamic. So your aim of optimization is one, dynamic AV delays, and of course other things that you need to do. You make sure that intrinsic conduction is there, use it to fuse your BiV, and other causes like atrial fibrillation, PVCs, etc. Be taken care of when your patient comes to you. So the algorithms that are there, quickly going into, one is from St. Jude, and this is for Abbott. This is called Sync AV. And what they do in this algorithm is very interesting. What they have done is that the device is going to assess the intrinsic AV conduction every 256 beats. So every 256 beat, the device will look at whether the individual has got an intrinsic AV delay. And if it is an intrinsic AV delay is there, then as an operator, you have the choice to program something called as a delta. You program this delta that will be subtracted from the AV delay, and that is what the device will pace at for the next 256 beats. Now, why this? What is the use of this 256 beats? See, this makes the device very, very dynamic. Individual who is taking rest at 50, every 5 minutes AV delay will change. Whereas the individual is walking, doing activities, heart rate of 90, every 3-4 minutes, the AV delays will keep changing. So you have programmed the delta. There is an intrinsic AV conduction. It will subtract, and that will be the AV delay that will continue. So this is what this algorithm, Sync AV, is going to do in a very simple way. There are a lot of other things, but I think to make it very simple, this is what the device is going to do. Now, what about before finishing, that is one thing. Second is, if there is an intrinsic conduction, then the device will go into an LV mode. That is, it will allow the intrinsic conduction to conduct and pace the LV at the programmed VV delay, and they will fuse. So intrinsic conduction, that's called LV. So this is what this algorithm will do. What about Medtronic? They have got adapt CRT, and this is also kind of a similar algorithm. There are certain caveats to it, but suffice to understand that this is also going to do the same thing. What is it? It'll do if the patient has got an intrinsic conduction, which most of our patients will have. The device will allow the intrinsic conduction and pace and will go into an LV only pacing. That is, only the LV lead will pace, allow the intrinsic conduction, fuse it. That's called Medtronic. It's an adapt Medtronic algorithm, and only place if your AV delay is more than 250, if your heart rate is more than 100 beats per minute, or if the patient is not in sinus rhythm. Those are places where this algorithm will not work. It will jump to the BIV that you have programmed. So this is how this particular algorithm is going to work in patients where you have programmed an adaptive CRT. Now, is there any data to suggest? Yes, we have got data at this moment, and they showed that it is non-inferior if you do an echo-guided optimization. What about Boston devices? They call it a smart AV delay. Similar kind of algorithm. Good thing about Boston and Biotronic devices are that they can sense also both the LV lead and the RV lead. So this device, what it will do quickly, it will sense A to LV sense, A to RV sense, A pace to same LV, RV, and then it will find out an AV delay. And also about the VV delay. The VV delay, what you can do is you have got this kind of a chart. So you can measure the VV delay. Device will tell you this is the VV delay. Will tell you between the LV and the RV delay, and you can program the VV delay. So again, additional thing here is that because you can sense the LV lead, you can also program the VV delay or the interventricular delay in this algorithm. So the advantage is that, again, data-wise, they have also shown that definitely the LV volumes comes down if you program them on this particular algorithms. Biotronic, similar kind of algorithm. I'm not going deep into that. It's called an auto adapt. So essentially what they are doing is they're allowing the intrinsic conduction and fusing it, one, and two, they have made both the AV delay and to some extent the VV delay dynamic in patients whom you have put a device and you are not able to program. I think it is good if it is good for us if a patient comes as a non-responder to take them to Echo Lab. But if you cannot do it, I think these algorithms are doing good job and we should be, I think, accept them. So I think I'll end it here. Thank you.
Thank you so much, sir. Any questions?
Yeah.
Ventricular intrinsic preference of VIP,
yes.
AV SARS, AV hysteresis, everything are same or something different?
See, those intervals, if you're programmed, then they will go simultaneously with it. But again, those are not dynamic. Your AV hysteresis, if you program, hysteresis, if you program, it is not going to be dynamic. It is as, if you programmed it. Here, it is going to be dynamic. Every 250, in a sync AV, every 256 beats is going to change. So for some reason, if your AV delay changes, your programmed, that device, what you have programmed AV delay will change. So I think it is going to be more dynamic. Those things, if you're programmed, are going to stay. So I think simultaneously will work. Yes, yes.
Great, Sanjeev. There are a few situations where we have seen that these patients, despite a good dose of amiodarone, the common antiarrhythmic drug, they throw VPCs very frequently, and then you can't get a optimum biventricular pacing throughout the day. So you have done one cases where you have ablated those foci. So do you think you should try to do that rather than fiddling with the device more?
Yes, sir. So good question. So again, as I said, these are confounders where your BIV will not be adequate. And if I see that my BIV is less than 94% and a patient has got PVCs, then I'll look at the PVC burden. Of course, I'll try medications, beta blockers, if required, other agents, antiarrhythmics to get the PVC burden down. But if PVCs are not allowing me to achieve a BIV more than 94%, then definitely I'll plan for a PVC ablation if it is in an anatomical area where I can ablate. So I think that is the thing. Same with atrial fibrillation. If atrial fibrillation, you try to control with your both beta blockers, antiarrhythmics to get your AFib under control. But if you're not able to get a BIV, a percentage of your choice, then you are not left with choice, but either to ablate AFib or probably ablate the junction and get a proper BIV.
Thank
Thank
you. So I think this is the conclusion of this session. So thank you, Dr. Mukherjee, for your contribution to EIIC Con 2023. And now may I request the presence of Dr. Prakash Hajra to please be in the chairperson panel. And we move on to a very related topic to this. And for this, I will request Dr. Debashish Ghosh to please come up on the speaker podium so that we can cover the topic why AI cannot replace cardiologists. So very similar topic. And then we move on to the collage segment that we have. So as of now on stage, we have the presence of Dr. Debashish Ghosh covering why AI cannot replace the cardiologists.
Thank you. Actually, there was supposed to be a debate, Prakash, between you and me. And so I had prepared a debate. But I think let me put both of the sides to the picture first. So artificial intelligence is actually now is pervaded nearly all fields of life, and cardiology is not going to be an exception to that. So artificial intelligence will come in and will have a profound role in cardiology. However, it cannot replace the cardiologist. That is what I need to contend with. It is a tool to augment and extend the effectiveness of a cardiologist. Nothing more. You cannot give the controls to them. Now, see, we've had tools. We have had very intelligent tool, and this is Laennec who described the stethoscope. That was probably one of the most profound tools which a doctor had, and it was so successful. Now it's a representation symbol of our own entire medical community. So this is a tool, and this tool was intelligent, and it opened up a host of findings and made us able to treat patients much better. So what is the problem with artificial intelligence? Now, artificial intelligence, if you see, it has the immense usefulness. It collects huge amount of data, collates it, uses some algorithms to make sense of it, does some self-learning, which may be supervised or unsupervised, and there's something called a machine learning as well, and actually presents us a case. But you have to understand it lacks certain parts as well, which is not going to be replaced by a machine. The first thing which I find it has not any major creativity yet. It is emotionless and empathy. We know that medical practice is not about machine learning. It is not about didactic data management. It is about dealing with a patient who has emotions, who has expectations, ethics of that, and some amount of high cost. So let us say about creativity. The problem with artificial devices is that you need to program them with data set which is already available. It does not question like any other, like a basic scientist. So let me show you this. This is basically Alexander Fleming, probably one of the most profound medical research scientists, saved many more lives than actually in the history of all religions put together. And if he did not question why the bacteria was not growing on the petri dish where the molds were growing, he wouldn't have discovered penicillin, which went on to save. Now, that was not a logical question. That was just an intuitive question, an observational, and at the end of the day, a question. Now, artificial intelligence, unfortunately, has not yet learned to question intuitively. So, certain real sort of recent experiences, it's called the defeat of logic. Artificial intelligence will always follow a certain amount of logic which is being programmed onto. Say like the folic acid, which we also knew decreased homocysteine levels, and we all knew increased homocysteine levels is a marker of atherosclerosis. But when you put it into a very, very complex system in the HPS2 trial, folic acid was a failure. It did not decrease atherosclerotic events. So that is the problem, that logic, especially machine-led logic, does not often work in a living system, which not only is a system, it's a reactive system. So basically, supervised machine learning
is very, very important. It aids the cardiologist in many ways, like an ECG interpretation. It helps you to do, but ultimately you have to understand the quality and the magnitude will depend on the data set you have programmed it into. And that is done by a human being, and that has to be done by a human being. So what is the actual evidence? Is there some actual evidence? This is I'm quoting a paper from Frizzle, who tried artificial intelligence to predict the readmission rate of heart failure patients, a very common problem. And in spite of using very complicated algorithms, both statistical and with machine learning, it was no better than clinical predictions. And why was that? Because one of the major determinants of readmission is social determinants of health, which seems very hard to code in an artificial language. So if you do not include the social determination of health, you will not get it. So artificial intelligence is going to be a huge aid. I'm not saying that it should not be in cardiology, but it should not be the only future of cardiology. There has to be more than that. Let us see the other problem with artificial intelligence or statistics as well. It's called dichotomania, which means it's either yes or no. It's a binary system, 0, 1, yes, no. Now, disease processes are not dichotomous. They are a continuous sort of a waveform, which there is a continuous increase or decrease in risk or continuous increase or decrease in event rates. So let us argue that if you see the US Preventive Service Task Force, and they took 10% event rate as a high-risk case. So if someone had a 10% chance of an event rate, you put them onto a high dose of statin, you categorize that as high risk. But what about the patients on the borderline? So what would do who are sitting on the borderline, 9.5% event rate, you would classify them as relatively low risk, not give them statin, and 10.5% a high risk, and you would give them a statin. So is that small difference, is it important? Because that is the problem with any statistical machine, that it's very dichotomous, it's binary, yes and no. But unfortunately, disease process is continuous, risk profiling is continuous. And finally, I think basically this is very, very important. It's emotionless and empathy lack. That is important. We are actually medical personnel, and we have to actually deal with patients. So if you see, this is one of the most ancient pictures of a doctor's relationship to a patient. This is a dying child of rheumatic. It was painted by the father of the child, and this man cannot do much. This is very old. See, you had rheumatic fever. The doctor sits there waiting and holding the hands of the patient and the parents, seeing the patient out of the world. That is empathy. A machine will do this. AI response, 99.9% mortality. That's it. So that is the problem which we will not get from AI. So what will happen? Would you give all the controls to AI? In that case, you have to replace healing with treating, caring with managing, and listening by sort of imaging. All artificially done, but that is something which you should not do. So do you want to present a picture, a pensive, caring doctor, but knowledgeable, but versant with AI as a tool? Or you want something like a Star Trek movie hero, where you just have a probe standing distantly, treating patient as cohorts, not as individuals. So that is something you need to worry about. The other thing I will sort of tell you a case which I did, and an AI system cannot respond to new situation. So if you have not come across similar problems before, it will not be able to predict, and it will also not be able to guide you to management. So let us come to this gentleman. This is a case from my own which was basically, he had a CABG in 2021, LAD, SVG, RCA, and diagonal, presented with ACI just 3 months later. He had a Covishield vaccine fairly early, March and April, more than the recommended time. And look at it. See what he has done. On the right-hand side,
you have the present angio, the left system, the left is completely blocked off. Mind you, that was not there in the pre-angio 3 months ago. The angio on the left-hand side of your screen is the angio before the bypass. And you see the angio just 3 months after the bypass, see the left system. The LCX was not grafted because it was a nice artery. So why did it happen? This is a patient who did not have a single classical risk factor. He was not a diabetic, mildly hypertensive. His cholesterol was actually below normal, 77, even without a statin. And so this is the OCT. And if you see the OCT runs, it is filled with clots. There is minimal atherosclerotic plaque, but this filled with clots. So this is the stenting was easy, wasn't difficult at all. That is what any algorithm would tell you. ACS presented with an acute occlusion, TROP-T was positive, stent it and get over with it, put them onto dual antiplatelet and let them go home. But unless you think, why didn't it happen to this gentleman, you're not going to get an answer. So I did progress. I was not satisfied with just stenting him and sending him home. His vasculitis and collagen markers was negative at that stage. Coagulation and profile was the only abnormal was there's a deficiency of protein S. Now, this is something you have not come across. Deficiency in protein S in a 65-year-old woman without any history of DBT. And then you search the literature and if you'll see 1 or 2 anecdotal evidence that COVID infection and COVID vaccination causes transient decrease in protein S. So what kind of algorithm would you put this gentleman into? We started with the consult of the hematologist on actually NOACs as well. But so this was the differential diagnosis, where there's no clear differential diagnosis. There is no clear algorithm which you would put this patient into, why he had that second ACS. So this could be the prothrombotic state, protein S deficiency, allergic reaction, all of that. But you followed it up. 6 months, he started losing weight. He has worsening renal parameters. He now has ANCA positive vasculitis and additional treatment with NOACs protein S deficiency, clinical improvements. So this is what I'm saying, that if you do not look at individuals, if you do not look at the finer out of the box points and let a human being take a decision, you would have again had not only had a similar episode, but also a deterioration of his renal function. Finally, if we let it all to the machine learning, who would carry the ethics? Who would carry the responsibility? So you have an adverse reaction. You cannot say that the machine learning dictated that to you. So I think what you need to do is to be careful. Yes, it is a very, very useful tool. It is going to be as useful as a stethoscope, as useful as an echocardiogram in the practice of cardiology, but it cannot be the only future of cardiology. It has to be taken as a tool to help the cardiologist to be a better doctor and manage patients better. So the future of cardiologist is a well-trained cardiology human workforce who will be trained in clinical cardiology, in artificial intelligence, and above all, learn to question and research. Thank you.
Thank you so much. Any questions?
Yeah, it was
No, we
You already won.
You already won,
You
or
already
we
won.
should. Oh, you have given the better.
Yes.
No, but the important thing, just in continuation of his statement, where we stands right now in 2 areas, particularly this Chatsworth score guided anticoagulation therapy. We feel that there are people who still get stroke. There are people who are low Chatsworth score, and we always think if they get a stroke. So probably if we are thinking it, then we are doing justice. And if we just go by score, nothing is going to happen. And similarly, the thing of scoring system for developing ASCVD, we know that we are reading it, we are describing it in cardiac prevent, but actually what we are doing, practicing is what our knowledge says. But probably artificial intelligence is going to help our patient to be educated more. That probably the only advantage.
I think the final comment is basically artificial. If the cardiologist has to be now aware of artificial intelligence, cardiologists who are not familiar with AI are going to vanish.
Yes, sir.
I
One
think-
thing is that sir, the machine is not good if the man behind the machine is actually competent. And another thing is that our age-old clinic should always win. We equipped with artificial intelligence, but it should always win our age-old clinics.
I think
Actually, the artificial intelligence is more of a prognostic, I mean, a preventive cardiology. I mean, it gives more insight into which population of the patient you should be focusing upon to avoid future complications or future events. Because this data, this comes from the statistical data. A huge amount of statistical data is integrated. There are fixed points which are studied upon a few risk factors, and if there are any risk factors, that is reverted. So artificial intelligence is moreover, it's very important, is coming up in a big way in a preventive cardiology rather than treatment cardiology. What do you say?
Yeah, I think everything is important. You have to change with time, otherwise the time will change you. You know, when the Kodak film was dominating the whole world, and the owner of the Kodak film thought that there is no end of Kodak film and nothing can replace Kodak film. And one day, after 300 years of business, he has not changed, digitalized. He has not put the artificial intelligence or new technology into the system, and he has gone bankrupt. So it is not just one-way traffic. You can have a man behind the machine, and if you have a machine behind the man and man in between, that makes the life much easier. So machine behind the man, like you have to have technology, advanced technology, artificial intelligence, like OCTs, you have IVAs, then you see, then perhaps another level of artificial intelligence, which goes into machine learning, deep learning. We are not going for deep faking. We are going for deep learning. That means the reality is going to come after you have a machine and you have used the machine to learn further. So as Bhaskar was mentioning, that you have to train your brain with artificial intelligence, so the brain also can learn much. We do not know there is an infinity. There is no upper boundary of brain training the brain, because we are using only 1% of our brain all the time. So it is not end of or the beginning of any new thing like artificial intelligence. As Churchill says, it may be at the beginning of new era of understanding cardiology, but definitely the cardiologist much sharper than the artificial intelligence right now. But maybe in the future they get sharper even than the human brain. So in simple word, if you have a simple task to do, like robotic PCI, nothing can beat human brain. But if you have very complex scenarios, AI, deep learning, machine learning can beat the human brain. So with that, we'd like to thank you for your kind attention and move to the next topic. Over to you.
Thank you so much, sir. And we move forward with the next topic, that is how remote monitoring can be beneficial for best possible patient outcome from device implanted patient. Indian real-time scenario by Dr. Abhishek Deshmukh from USA. So we have him like online, but this is a recorded video. So it will be a recorded video. So we cannot have any question answer round for this. So we have on online on screen, Dr. Abhishek Deshmukh from USA.
Chairperson can join us, panelist, if you are there. Over to you.
So can we have the video running?
Electrophysiologist at Mayo Clinic, and I'm going to talk about the role of a remote monitoring clinic and why having a remote monitoring clinic for patients with devices is going to be very helpful for you and for your patients. So we'll start off with the case of a 74-year-old male with history of ischemic cardiomyopathy. He has a CRTD implanted and he is doing very well. EF is 35%. his NYHA class 2. But now, after feeling good for many years, his EF is dropping. He's not feeling well. He's more short of breath, and now having multiple hospitalizations for heart failure. So how often do physicians managing heart failure patients wants to see them back in follow-up? Every 3 months, monthly, weekly, or when patients call with symptoms? Now, as you think about this, and all of you and all of us are very busy with our practice, and we tend to miss out sometimes on engaging with patients who are at a high risk for rehospitalization. So for somebody like him, we can address him, maybe go up on his dose of diuretics whenever he calls us. But can there be a more systematic way and a more refined way by which we can follow this patient, or somebody in our clinic can follow this patient and without him falling through the cracks? So how do we think of a CIED, cardiac implantable electronic device? So we need to find the right device for the right patient. Then once we follow the indications, then our implant techniques have to be perfect. And then what we aim is that we should not have any complications while doing these procedures. And once the device is in, incision has healed up, no complications, then we should be all set, right? However, we also know that the patients with pacemaker, ICD, and CRT are different. So pacemaker patient is more normal QRS, not much heart failure, normal EF, may or may not have AFib. ICD patients are a little bit more sicker. They have low EF, heart failure. There are multiple medications. They might be bradycardic because of all the metoprolol what they're taking. And then there is the CRT group of patients who are much sicker, low EF, wider QRS, and more risk of rehospitalization. So even if we put a perfect pacemaker, perfect ICD, perfect CRT, our aim shouldn't end there. Because beyond the implant technique, how we should really think about device management is we need to have a routine follow-up. And again, it may not be like a cardiologist seeing that follow-up, but maybe a nurse or maybe some allied health personnel in your practice. Then if you have the remote monitoring by which this device gets monitored live throughout the life of the device and life of the patient, then we get continuous lead diagnostic information, arrhythmia burden, heart failure diagnostics. So our job is not done once we implant the pacemaker and the patient goes home, because that is the simplest part of the entire management spectrum of managing these patients. Actually, it starts after the device is implanted, and then how we can make the most of all the diagnostics, what we are able to get from that device. So once we have this, the device, maybe the complete heart block got better and patient is feeling better. But over a period of time, now that we have the device, can we improve quality of life? Can this be cost effective? And can we improve mortality by use of remote monitoring? So remote monitor transmitters have changed over the years. Initially, it used to be through telephone. Then there were some of these devices which would be hooked up by the bedside. And now most of the major companies have your monitoring, which is being done by a cell phone-like device. So the way remote monitoring works is that before the device is implanted, at least here at Mayo Clinic, our nurse talks to them about remote monitoring. What kind of cell phone do they have? Do they have a landline at home? Because that can also sometimes tilt the use of one device over the other from the remote monitoring standpoint. And then they all get discharged with a remote monitoring device to be hooked up at home. And then we start to analyze that data. And again, you don't have to analyze each and every data. They are always preset variables. So for example, suddenly threshold goes up, you get a notification. Suddenly the impedance goes up or the sensing changes and you would get a notification. It all depends how much, what all information you need to have. So there is a specific guidelines for remote monitoring that all patients with a cardiac implantable electronic device should be offered remote monitoring as part of standard follow-up management strategy. And at least where I practice in Rochester, Minnesota, it's a small town and it's a farming community. So the patients may not always have easy access to come back to see us all the time to get their device checked in person. Similarly, we get a lot of patients who come from all over the country and the world. So again, it's very difficult to manage those patients on a face-to-face basis, and that's where the device management through remote monitoring has helped us tremendously. And I think the same thing will happen in Bangladesh, in India, and all the other countries, because the access to care is much better in urban center. But if you have somebody who is not in Dhaka and is working and is living somewhere remote in a small village, how can he make sure that his device is working well and you get enough device diagnostics, and remote monitoring would be the way to do that. So the value of remote monitoring is you would know that when the battery is changing, if the battery is dying, if you have any lead or device related advisory. From the lead data, you would know the impedance, the threshold, how much percent pacing you're having, again, any advisories on the leads. Arrhythmia burden is critical because then you can predict if somebody has a pacemaker or has a device, and now suddenly you're seeing a lot of AFib. And by the way, the CHA2DS2-VASc score is high. If this patient did not present to the hospital with AFib, he or she may not be on anticoagulation. So again, getting data from device diagnostics for AFib can help us identify patients for high risk of stroke and get them on anticoagulation. And from heart failure standpoint, we can get data for thoracic impedance, activity sensors, and those kind of things can also help us tailor therapy. So coming back to our patient, the patient who was not feeling well, he had a high Opti-Wall index. So what is an Opti-Wall index? So we know that when patients get pulmonary edema, or they have more fluid built up in their lungs, because of the presence of salt and water, the thoracic impedance goes down. And the reason for that is because salt water can conduct electricity much better compared to just pure water or D5W. So once this impedance goes down because of the presence of the salt and water in the chest cavity, the logarithm of this thoracic impedance is an Opti-Wall index, and that goes up. So this information is obtained from a device because you would see that over a period of time there was not much fluid built up, and now suddenly there is more fluid built up in this time of the patient's life. So again, we would know that now that patient is having more probably heart failure type symptoms correlated with this index telling us that there is more fluid built up, then at least we can diurese this patient at home before even he can come to the hospital. And even if we go up on his diuretics, if he feels fine, you could see the Opti-Wall index going down again. So these are the kind of things which are sometimes very, very helpful. If the patient can send you a transmission saying that, oh doc, I'm more short of breath now, can we look at this? You look at this index, it is high, you can give diuretics. If you look at this index and the index is not high, then again, you may wonder whether the shortness of breath is truly because of heart failure, or it could be something else. So these kind of things are very, very helpful. Now coming back to this, our patient, we gave him Lasix, but he didn't feel better. But then we looked at his LV pacing impedance, and we noticed that his lead actually got fractured because his LV impedance is more than 2,500 ohms. So he's not, because the lead is fractured, the patient is not BiV pacing, and maybe that was the reason why he's more short of breath and having more heart failure symptoms. And it kind of correlates once his lead stopped working, the Opti-Wall index went through the roof. So these are the kind of things which can be helpful. And again, for this, the patient need not come to the clinic. All of this can be done remotely. And then you can schedule him to get an LV lead revision or something else based on this kind of data. This was the ECG with BiV pacing. Once he came to the clinic, he got another ECG. Clearly, there is loss of BiV pacing on this ECG, and that's the clue. So how to identify BiV pacing for people who are just starting out? BiV pacing, because you're pacing the lateral wall of the left ventricle in ECG principles. Whenever the activation is going towards the lead, it makes a positive wave. Activation going away from the lead makes a negative wave. Because you're pacing the lateral wall of the left ventricle, lead 1 and AVL are your lateral leads. As the activation is starting from there, your lead 1 and lead AVL is negative. Same thing when you lose BiV pacing. Now this is only RV only pacing. You're pacing from the RV apex, so that is a more inferior structure. As you're starting from there, your inferior leads are positive. As it is going more towards your AVR, AVL, they become more positive. Clear example that there is loss of biweek pacing in this patient. How about if patient is getting recurrent shocks? Well, the patient may get a shock and you may think, well, maybe patient is having VT, VF, and we should rush and send the patient to the nearest hospital if the patient is somewhere remote. But getting data from that can help, because if it is an arrhythmia, you can treat the patient. But if it is not an arrhythmia and if it is some sort of over-sensing which is happening, then we can treat the device and program the device. So this is an example of lead fracture. You'll see all this noise on the lead, which is very variable, intermittent, high frequency signal, which causes saturation of the amplifier. So this patient would be at a risk for getting inappropriate shocks. So if you can find this out on remote monitoring, then at least you can program around it or get another, or maybe consider putting in another leads. So this is some of this information becomes very, very important. Finally, device diagnostics can also help us find out AFib. As we know, not everybody, but the risk of stroke, whether it is symptomatic or asymptomatic, AFib remains the same. So if the symptomatic AFib is really the tip of the iceberg, and there are so many people who have subclinical AFib who may not be symptomatic, but they are still at the same risk of stroke. So how do we know that? So there was this ASSERT trial in patients who were more than 65 years of age, and who had a pacemaker or a defibrillator placed and no prior history of atrial fibrillation. The patient was monitored. These patients were monitored for 3 months for subclinical atrial arrhythmia. And this was the definition of atrial arrhythmia when the atrial rate was more than 190 beats per minute for more than 6 minutes. Mean follow-up of 2.5 years. And what they found that 35% of patients had high atrial rate episodes during the study. Incredible. So 1 in 3 patients had some sort of atrial arrhythmias. Again, proves the point, the more you watch, the more you look for it, you're going to find it. The implications are majority of the patients were more than 65 years of age. So the CHA2DS2-VASc score starts to grow up. And then these are the patients who can be started on anticoagulation without even getting, because you already have a diagnosis based on the device. As we know, in this study, presence of these atrial arrhythmias, the risk of stroke or systemic embolism was 2.5 times higher compared to patients who did not have any subclinical atrial arrhythmias. So again, you could prevent that stroke in a patient by doing these device diagnostics. Now, is it only for pacemaker or ICD? Well, if you're adherent to the remote monitoring, you get tremendous mortality benefit regardless of the device which is placed. So remote monitoring definitely improves mortality. It also saves a lot of costs. So again, remember, if you have a patient who is somewhere in a remote village, so for that person to come and see you in Dhaka, he has to take a bus, a train, a flight, stay in a hotel, then come and see you, and then leave back with the same route. So there's a lot of expense with this. But same, if you have remote monitoring, if you can figure out some of these things and work with the local doctor, then there is tremendous amount of finances which are saved, not only for the patient, but for overall healthcare system. And there is enough data that remote monitoring does help reduce cost of overall care. What are some of the barriers to remote monitoring? Well, the hospital where the device was placed, maybe they don't have a system in place for remote monitoring. Patient may be anxious or may just have that inertia, like, why should I do this? Sometimes physicians have an inertia that why should I learn something new now? I've put in a perfect device, great result. Why should I worry about what happens to the device? And then finally, who deals with all this data which is coming out all the time? So typical home guide model for remote monitoring, your patient gets a device, they come home, gets hooked up on the remote monitoring. And then most of these things, at least in US, are managed by nurses. So we can empower our nurses, we can empower.
Hi, good morning, everybody. My name is Abhishek Deshmukh, one of the electrophysiologists at Mayo Clinic.
They run it by a physician.
I'm going to talk about the role of remote monitoring clinic
More people
and why having a remote monitoring clinic for people.
So we take a few moments of time to just figure out why did we have that crosstalk over here. So just a moment, and then we will be back with the presentation again. No? Okay, so we have an error in the video. So can we move forward so that we can have the rest of the slides? Is it doable? So we can just have an overlook of the video that we can move forward without the crosstalk.
Remote monitoring. Well, the future of remote monitoring is all going to be through a cell phone. And this is the list of 20 countries with the maximum smartphone penetration. If you just look at Bangladesh, India, and Pakistan, 33% of the population, believe it or not, have access to a smartphone. Bangladesh a little bit more than India, and followed by Pakistan here. So we have all these people who have access to smartphone. They are on Facebook, Instagram, YouTube. Old people, the senior generation is FaceTiming or WhatsApping with their nieces and nephews and grandkids all over the world. But if they have a device, maybe we can use cell phone technology to get information from their device and get hooked up to a remote monitoring clinic. Some of the challenges is, again, who is going to manage data? Maybe artificial intelligence can help. There's always a concern for cyber security. There's also a trade-off with expectations what the doctor and the patient may have of each other with these technology, behavioral patterns. There could be a legal angle, newer technologies for remote monitoring. So the future for remote monitoring is certainly very exciting. And we learned the most about remote monitoring during the COVID pandemic because the patients couldn't travel, the hospitals were full. So what do we do with those patients? Well, we just follow them through remote monitoring and then see if there is a problem with some of these patients. So in conclusion, remote monitoring saves lives, saves times, and saves money. So it's fantastic. We need to have a robust infrastructure, but we also have a lot of young generation who are people who are IT savvy. If they have interest in healthcare, they can certainly manage this and partner with a healthcare company or a hospital to develop this. We empower the healthcare in the patient's hands so they know exactly what's going on with the data, what they are having. And this certainly would create an opportunity for job creation and certainly a new workforce who are more tech savvy, who can manage all this data and then can help and guide physicians with management for some of these patients who may not be able to come and see them on a consistent basis and identify any problems with the device, any problems with patient care management, and hopefully we can all do to make our patients live longer and feel better. So I think I'll stop there and thank you very much. Hopefully we can have some questions.
Thank you, Deshmukh, for a wonderful lecture. And tell us what? A recorded one, okay.
So this was a recorded one, so we will not have question answer round. So now we move forward with the next session, that is a collage session. And for this particular session, can I have the presence of the following dignitaries on stage, please? In the chairperson panel, may I request the presence of Dr. Shivananda Dotto, Dr. Jayant Raja, Dr. M.L. Bhansali, Dr. Bhaskar Gupta. Can we have the presence of the dignitaries here? For
first session, I think we'll go to Dr. Saranago, he's waiting. Then we'll come to Atul. Okay? Saranago, Trigwell. Talk on Trigwell, no problem? Any problem? No.
No problem at all. It will be a pleasure.
Yeah. Trigwell is waiting.
And for this particular topic, may I request the presence
Let us
of
connect to Dr. Fernando.
Okay, and so we will have the session talk on TriCLAV by Dr. Fernando Sarnago. But before that, may I request the presence of the following moderator here, Dr. Mayank Agarwal, Dr. Ritarendra Talapatra, Dr. Shumanto Chatterjee, Dr. Shubhro Shankar Chakraborty on stage, please. We move forward with an online session. We already have the presence of Dr. Fernando Sarnago.
Fernando, over to you, sir.
Okay. Hi, everybody. Thank you for the invitation for this presentation. I'm gonna just share my screen. Can you see the slides?
Yes.
Okay, so they asked me to briefly talk about the trick valve system and also to present a clinical case. I'll go briefly through the system itself and the indications, and then also a brief case just that shows how does it goes in real life. Just very quickly, we all know that surgery is not the perfect solution for patients with tricuspid problems, much more if the patient has only a tricuspid problem and not other valvular regurgitations or valvulopathies. So in this context, surgery hasn't showed to improve really survival, as you can see here. So we need something else to offer to the patients. And in this context, we've got some current interventions that previously have focused on edge-to-edge repair. Also, we're still developing some systems that allow us to replace the valve orthotopically. But the success of these therapies usually relies on very specific anatomies, and also they rely on a very specific and quite demanding periprocedural imaging guidance. In this context, we've got the trick valve system, which has got some advantages. As you can see there, it's a heterotopic bicaval stenting transcatheter strategy, okay? It's based on a streamlined fluoroscopical workflow that we're very familiar and used to, just like, or very similar to the TAVI procedures. And also the procedural planning is quite easy. It mainly relies on the CT screening, okay? In comparison to previous non-orthotopic devices, it also has some advantages, as you can see there, because previous devices had some difficulty on sizing, anchoring, the necessity of prestenting, and also a risk of embolization. The trick valve system has got two independent and separate valves, specifically designed for the IVC and the SVC. You can see the images. On the left side, the SVC valve for the superior vena cava. It has got a belly in the middle part of the valve that allows for the retention and also prevents embolizing distally. This belly should be at least half of the belly above the right pulmonary artery, just to prevent the valve going downwards or caudally. And also on the right side, you can see the IVC valve, which has got a short skirt here, just to prevent any leakage and just to avoid closing or stopping the flow from the suprahepatic veins. And then the distal part is much more bigger, just to allow for stabilization in the IVC. The valve comes pre-mounted, which is very useful and very quick, and also facilitates the procedure itself. Which are the candidates to offer this system? We've got patients with obviously TR, which are not suitable for repair. They cannot be treated with edge-to-edge therapies. And we need to offer them a CT screening, a right heart cath, and also an echo screening. The criteria are quite easy. We just need some significant V waves above 15 just to allow the valve to work properly and all the leaflets to open and close properly, and also avoid severe pulmonary hypertension to avoid early dysfunction of the valve. In the echo screening, we just try to avoid patients with severely reduced LV or RV function. And also we should try to avoid intracardiac shunts because they could increase right to left shunting after the procedure. If there's a shunt, we can close it before performing the trick valve implant. For the CT screening, you can send all the images to the company. They can analyze the distances for you. We just need some measures from the innominate vein to the RA and also some dimensions. We've got three models of the SVC from 25 to 33. This is the dimension of the valve itself. And we can cover ranges from 19 to 40 millimeters of diameter. In terms of the IVC, we also look for this minimum distance between the suprahepatic vein and the right atrium that should be above 5 millimeters. And also we've got some different sizes of the valve, which covers from 24 up to nearly 45 millimeters. Let's move on. We can, I would like to show you just a case. It's a particular case, not easy, but I think it shows you how we can use this valve in some different contexts. This was a 77-year-old female with chronic AF, also previous valvular heart disease, with 2 previous intervention and a mechanical mitral valve. She had currently severe TR due to huge tricuspid annular dilatation. She was in very bad functional class on high doses on diuretics, and she also had some comorbidities which precluded a third redo for this patient. You've got here some images from the previous echo. You can see there's a huge gap here between the leaflets of the tricuspid valve, which recommended not to attempt an edge-to-edge procedure, and also obviously severe tricuspid regurgitation. Some more images of the previous echo. You can see them here. And we perform a CT screening. These are the dimensions of the SVC. It was a special case because you can see here, just like a very tortuosity of the SVC, a huge loop here. You can see also in the right image that made it difficult to, to implant the SVC processes, as you could see later. And also afterwards, after this loop, the SVC was really huge with a very big dimension, which made it necessary to implant the valve up here above the right pulmonary artery and not distally where the SVC was too big. If you can see the images of the IVC, you can see there was a minimum dimension or length between the atrium and the suprahepatic veins. You can see them here, but because the suprahepatic veins were quite large, we thought we could implant the valve and leave the skirt here without covering all the suprahepatic veins. Just moving on to the case, for a normal standard procedure, this is the material we need. Everything is quite usual in a cardiac cath lab. We started doing the procedure with transesophageal echo for the first 4 or 5 patients, but nowadays we do all the procedures just with transthoracic echo. Just we do all the SVC implants only relying on the fluoro, and for the SVC procedures, as you could see later, we just check the amount of the valve or the amount of the system that is inside the right atrium with transthoracic echo. We do the procedure on mild sedation, invasive pulmonary, arterial pressure is not necessary. And you can see the procedure here. On the left, you can see, and also on the right, some angios, initial angios of the SVC. You can see the loop that we previously watched on the CT scan. And we also had a catheter, in this case, in the innominate vein, just to make sure where the innominate vein was, trying not to occlude that vein. This is the system. This is the SVC system. You can see it's pre-mounted. It navigates quite well. It has got a nose here, and you can go up to the place where you can start to release the valve and sheath the valve. You usually leave a catheter through the contralateral femoral vein just to check where do you want to start the deployment. You start unsheathing, and the valve starts expanding and becomes functional in place. This particular case, you can see how we can straighten the SVC as we deploy the system, and we do it slowly just to let the valve expand and stay in place. You can see the belly here is above the pulmonary artery, just to make sure that the valve stays in place. You can see the final release here. And also, it's important to retrieve the system carefully, just to make sure that the nose cone doesn't pull all the system backwards. So you can see here how the nose cone goes slowly through the distal crown, and it shouldn't be a problem. This is how it looks like in the PA projection of the patient. Usually the valve is much more longitudinal, it's much more straight, but this was a very special case. So the first SVC valve is in place, then we leave the catheter in the suprahepatic vein and we go for the SVC valve, IVC valve, sorry. You can leave the distal wire inside the atrium, or you can leave it inside the SVC. Just you can decide that in terms of how is the direction of the IVC inside the right atrium. You should try to look for a perfect alignation between the valve and the RA to IVC junction if possible. You can see here the images. You can see here on the right how we start deploying the valve. And once you're here, what you want to do is just to check that the amount of the valve inside the right atrium, it's not more than 10 millimeters. You can see here the transthoracic echo images. You can see it's quite easy to measure these dimensions inside the right atrium. And also you can put some color on just to check that there is no leaking and the valve is functioning properly. So if you're happy with the place or the height of the valve, you just go on unsheathing the valve. And this is how it looks like once you release it. This is the final angio. Obviously, the right atrium, which was huge, is still has got some regurgitation, but the valves are in place and functional properly. We could see in the hemodynamics that the right atrial pressure was ventricularized, but the V waves were avoided, and the pressure above the valve or beneath the IVC valve were absolutely normal. The recovery of the patients, it's very quick. We usually leave the patients in a recovery room for a few hours and then transfer them to a standard ward after 4 hours or so. They usually doesn't need any ongoing ECG monitorization. We only perform the day afterwards, 24 hours after the procedure, chest X-ray and another transthoracic echo, and they can be discharged the next morning. Sometimes the patients have some shoulder pain through because of the dilatation of the IVC that you can treat with analgesics or maybe with gabapentin because it's a neuromediated pain. But the vast majority of the patients don't have any complications and can be discharged 24 hours after the procedure. Usually we wait about 1 week to 10 days to reduce diuretics, just as I said before, to allow the valve leaflets to work properly. And if we perform patients with mild to moderate reduced RV functions, they may need inotropes for a few hours, days. But as I said before, I don't recommend performing these procedures in patients with severely depressed cardiac function. We recommend chronic anticoagulation in all of these patients. And this is how it looks like. The valve a week after the procedure. You can see that there's some improvement of the RV function. The valve is functioning properly on the left side with no regurgitation. Obviously, the TR stays in place. And just a few slides, 3 or 4 slides about the clinical data. There are a few papers published about the trick valve system. The main paper published is the Tricus Euro study. It's a study including these kind of patients, patients not candidates for surgery with very flat functional class, and also tricuspid regurgitation over 3, grade over 3. We included 35 patients and we followed them. We had very, very few complications. Just 1 patient died in hospital. The technical success was 97%. This is the evolution of the quality of life questionnaires. This is the evolution of the functional classes. You can see there's a clear improvement in the majority of patients. 80% of the patients were in functional class 1 or 2 at 6 months timeline. And also this is the improvement in the walk test after 6 months. There's also the combination of the Tricus Euro with the Tricus registry, and I brought this slide just to show that the improvement is maintained 1 year after the procedure, and also that nearly 90% of the patients had improvement. There's also some improvement. We've got very scarce data on remodeling and volumes of the right chambers, but what we've seen is that there is some reduction of the RV volumes with some maintenance or even a bit enlargement of the right atrium. That's why globally the right chambers stays stable, but the right ventricle reduces its size. Also, this may explain the high pressure in the right atrium, why we haven't been able to see a reduction in the NT-proBNP levels. And that's really all the data we've got nowadays, but we've got an experience of above 200 cases, and I think the evolution clinically is really good. We're waiting for more data in a long-term follow-up. And this is what I wanted to show you. I'll be happy to reply any questions if there's some.
Thank you, Fernando. After putting this valve, the RV remodels. Whereas if you put clips in the tricuspid valve, we have data in TriLuminate, RV also remodels. So how this remodeling process is different? Is there a different mechanism? But whether it works in the same principle, whether it's a trick valve or a tear, the RV behaves in a positive fashion by reducing its size, dimension, and volume.
Well, I think there's a small difference here. When you treat the tricuspid valve itself with the TE or R procedure, I mean, you reduce the pressure in the right atrium. You would also expect a reduction in the BNP levels, and the patient stays more physiologic. When you treat the patient with a trick valve system, the pressure in the right atrium stays high. And that's why, if possible, we still prefer to treat the valve. But there are still many patients that are not suitable for a edge-to-edge procedure just because they've got a pacing lead, or because they've got a primary problem of the tricuspid valve, or even because we've diagnosed the patients a bit late and the annulus is too dilated or so. I think in these patients, we still can give clinical improvement. We still can give an RV remodeling, and the trick valve system is a very easy and straightforward way to do it.
Have you ever seen the migrations of either limb, the superior one going down and inferior going up?
No. We didn't have any embolization. I think the design of the valve, it has got a radial force on the distal part just to avoid embolization, and I think it's a very safe procedure. in comparison with the previous procedures we did 2 or 3 years ago, just implanting some Edwards Sapiens valve in the caval position or so. I think
Right.
it's
So if you're asked to, to do further innovations or upgradations or improvement in your trick bulb, so what are the things you're going to improve on trick bulb? That will be the last question to you.
I think what we should improve is really the possibility to adapt to some strange anatomies. We still have some patients that do have a very angulated IVC or a very, very close suprahepatic veins to the right atrium, and also patients with a very short SVC that does not allow us to implant the valve. There are few, I think, from the CT scan screening that we perform, that should be less than 8 to 10%, but there's still some patients that we cannot offer the system. So I think the company should work a little harder in that direction.
Fantastic. Thank you, Fernando. See you again here in our country. Want to have more from you. And thank you for your time. Thank you for your contributions to ICON. Thank you very much.
Thank you so much, Dr. Fernando Sarnago, for the talk on trick valve and your contribution to EIIC Con 2023. Now we move on to the next session. That is, this session will be monitored by Dr. Naveen Bali, Commercial Head of Cath Lab, and the topic is IITPL Cath Lab, a presentation. So we will be having the speaker of this topic, Mr. Naveen Bali, Commercial Head of Cath Lab. And again, I will request if any of the chairperson or moderator is present right here in Victoria Hall, I will request them to please take their seats in the panelist. And now we start off with IITPL Cath Lab, a presentation by Mr. Naveen Bali, Commercial Head of Cath Lab.
Coming from Delhi and coming to Calcutta, I can definitely say, having a sweet tooth, that sweets in Bengal definitely taste different. I was listening to the conversation of AI when we were talking about man and machine, and I was thinking about sweets from Bengal. On a serious note, I'll be making a presentation on Atmanirbhar and medical device industry. Atmanirbhar is making India self-reliant, and I'm going to talk about industry that is closely associated to all of us, which is a medical device industry. Now, medical device industry, as we talk, is highly dependent upon imports. There are challenges, and the challenges are when you have imports, which are to the tune of about 80%, how do you make a company in a medical device industry a self-reliant industry? With this prelude, let me give you an overview of this industry. Now, Indian medical device industry is estimated to be at about $11 billion, which is expected to grow at a rate of about 35% to be close to about $50 billion by 2025, which talks about the substantial size of the industry. The industry is also cluttered with lots of players, and this industry is at a cusp where we are going to follow the other industries like the pharma industries and the vaccines. We have seen in COVID that India was a self-reliant country and also helped the world during the crisis. Same is going to be true for the medical device industry. I'm going to talk about a company and take you through a journey where I'm going to present how this company became successful in this highly competitive industry in medical device. The company that I'm talking to you about is Involution Healthcare. This company was incepted about a decade and a half back by leading professionals who are very accomplished in the field of cardiology. All put together, they have experience of over 80 years. So a company that was started in 2010, and as rightfully the name says, evolution through innovation. And this company started to offer products into cardiac consumables and also into the cardiac devices. The company introduced drug-eluting stents, balloons, and so on and so forth. And also they have one of the premium cath labs by the name of Pinnacle and Premier, which have been launched in India in last couple of years. The composition of the company is called Involution Group of Companies. It has got two parts. One is the Involution Healthcare Private Limited. This company was founded by Ashwini Sutar. It was founded by Atul Sharma, Sachin Garg, and Gaurav Agarwal. This company started their operations in India by selling cardiac consumables, which is drug-eluting stents, balloons, and guide wires. And again, there was a company called IITPL, which is Innovation Imaging Technologies Private Limited, based out of Bangalore. This company had its own strength from an imaging company called VJ Technologies and Alpha Group, which is a company which manufactures first cath lab in Asia, in India, a couple of years back. All these companies coming put together, this is how the company was formed. This is the senior management of the organization. The group is headed by Mr. Gaurav Agarwal. He's the group managing director. He heads the complete Involution Healthcare's operation. And Sachin Sutar, who's a co-founder and director, is heading the manufacturing plants of drug-eluting stents, which is state-of-art plant in Jaipur. Atul Sharma and Sachin Garg are heading the operations of the Involution Group of companies. Involution Healthcare is one of the Asia's top awarded companies. I mean, if you talk about whether you talk about R&D or talk about innovation or you talk about the quality, whatever you talk about, this company we've been acknowledged with quite a few awards from both domestic and international bodies. Indian Medical Device Association has given us the award of the Indian Medical Device Company of the Year in 2020. Good Design Award from Ministry of Commerce from Japan. In design, we've got the award, which is the most prestigious award called Red Dot Award. I'll show a small film. Those of you who would appreciate that this award is given to the best design across the industries. We've also been acknowledged as top 25 innovative companies of India and R&D Company of the Year. This is a small video clip on Red Dot. I'll just show you the video here. So this is a Red Dot Award that we've got, and it really makes us feel very proud that this is the first company in medical device and cath lab who've got the Red Dot Award for design in the likes of Google and Ferrari, an Indian company in medical device industry. I mean, look at the products that we have. I'm going to shift focus from the organization to the product portfolio that we have. We started commercializing our cath labs in 2017 when the company was incepted and started getting into cath lab business, imaging business. And within a year, we had our first cath lab, which was commissioned. And from there till today, we have been improvising and launching one model every year. So we have a range of cath labs starting from the Pinnacle to Pinnacle Pro to Pinnacle Agile. And now we've launched the top of the line Premier Elite cath labs. I'll just show you our latest offering to the market and talk about the Premier range of products that we have. This is the latest offering that we have, the Premier portfolio, which has got Premier Select and Premier Elite. This is the most advanced cath lab. You've seen the features that we have. The Premier Elite has got 3MHU liquid metal bearing X-ray tube, and it comes with a host of features and software. Without getting into the details, I'll move to the next slide to just show you the footprint that we have as an organization. We have over 250 cath lab installed in every nook and corner of the country. We have our presence across the state. We've also expanded our operations outside of India, and we have now distribution or the representative office in Asia, and we started our operations in Europe recently as well. We have, as of now, sold over 300 cath labs, all put together, and there are about 1,400 hospitals, private, government put together, with whom we partner. We have a strong distribution network of about 100 plus distributors span across 19 states and 149 cities. R&D is one of the core of the organization. We believe that innovation has to be the hallmark, how the future of cath lab or cardiology is going to shape. So we're investing quite a lot, hiring people from the reputed prestigious institutions to work with us on the latest, on the new features that we could bring to the segment. We are currently working on live QCA, dynamic coronary roadmap, virtual FFR, 3D remote rendering of entire coronary tree, tele echocardiography, and drug-eluting balloons. I'll just show a small testimony of one of the customers where we had actually sold our cath lab, and this would talk about the quality and the features that we offer in our product.
Yeah, we are very happy to have this INTPL premier cath lab installed at Jaydeva Satellite Center at KC General Hospital, Malleshwaram, Bangalore. And today we did 2 cases with this premier cath lab system. Resolution is good. Even the everything, gantry moment, the image intensifier, the moment is very good. So it almost simulates like any other high-end cath lab. So I think this is the way we go forward, because India needs at this point of time probably around going by the size of the population and also going by the burden of the cardiovascular disease in India, we might be requiring around 6,000 to 7,000 cardiac cath labs. At this point of time, we have around 2,200 cardiac cath labs. So definitely mid-sized, I mean tier 2 or tier C, tier 3 cities, this system fits in. And because we know that the treatment of heart attack is time driven, for every 30 minutes of delay, the risk of death increases by 7%. So definitely we should have more and more cath labs even in tier 2, tier 3 cities. Now cardiologists are also quite available now, because a large number of seats are being given to many medical colleges. So definitely I'm very happy and satisfied with the IITPL premier cath lab system. So I think this is the way we should go forward. Anyway, congratulations to the IITPL management and Gaurav Agarwal and all of you for making Make in India project dream come true. All the best.
So this is Make in India for the world. After having our operations in India, now we are looking towards getting out of India, taking our product to the international market, and that's the one of the milestones that we are working on. As a company, our vision is to be India's most integrated cardiac care company. We recently participated in EuroPCR. This was the first time any company, forget about Indian company, any company which has taken a live cath lab to a EuroPCR, and it was an Indian company, Involution Healthcare. We are working on R&D, which I've talked about, and also dynamic coronary roadmap and TAVI suite. So this is the future roadmap that we are investing on as an organization, and we look forward for your continued support. Thank you so much. Thank you.
Thank you. Beautifully presented, quite impressive one. And on the top of the cherry is Atmanirbhar, lower price. The imaging quality matches with any easily available standard cath lab in our country. Ease of servicing, servicing, since it is spare parts, will be available easily, rather than searching for the spare parts of multinational companies, especially during COVID time, a lot of difficulties. Now, in real-time stent boost or stent imaging, what is your future thinking? So that whether it is still 2-dimensional stent boost, or in EuroPCR there was a presentation from GE that perhaps a stent boost on with artificial intelligence, 3D volumetrics can replace the OCTs for MLA. So that is available from GE, not commercially available. So do you think that kind of imaging quality with stent boosting itself, rotatory, like you have this dynamic DCR kind of thing. So it is a GE machine rotates and takes the stent boost on 360 degree, not 360, 270 degree angle, and gives us the length, the volume, the stent expansion, the MLA in real time. So do you think that is feasible from your side?
Yes, sir. We are working on integrated AI-based dynamic QCA. With the help of dynamic QCA, we are able to generate a live stent boost, taking all the 3 dimensions. Because if you take a general cath lab from, say, Philips, GE, Siemens, they operate at a nominal speed of 12 to 14 degrees per second. Here we are able to operate at 25 degrees per second. I'm not talking about the express swing. Express swing is something else. At this 25 degrees per second, we are able to take 3 views. So in a single dose, a live stent boost with the help of AI. We are working on that project and we have already launched live QC.
In AI, you're putting few dots on,
Yes,
on the stent, what you see as a stent boost.
Yes, sir.
Then the AI itself gives you the real time. You don't have to press the
Foot switch.
button, foot switch. Actually, it's happening in front of you.
Correct.
And it is moving with your angiographic rotations.
Correct.
Your RO, LO, those kind of real time visual estimations of the stent expansion is definitely a game changer. Look, what are the things still left behind in the cath lab? Definitely more and more integration of artificial intelligence. Seeing the stent, visibility of the stent. Nowadays, people can estimate the coronary lesions not by only visual measures. They do take help of FFR, IFR, QFR, DFR, then OCT, then intravascular ultrasound. So if you can provide us that real stent view with dynamic roadmap. So dynamic roadmap definitely reduces the amount of contrast.
Yes.
Now tell me the safety of the lab, radiation, how much radiation it generates when it goes to ileocaudal.
So the most difficult view of a ileocaudal with 55 degrees angle, be it a Philips, GE or Siemens, all are using, I'm naming them because all are using a 1K detector. So when you press a 100 kilowatts generator, a load of 100 kilowatt, the excess data you have is 80%. So we are the only company in the world who started with 1344 detector. So at a lower dose, I'm getting more data and I am able to process more. So that's why if you say the grayscale levels or the millisieverts ranking, if a normal CAG of any other machine is around 7 to 8 millisieverts, we are in the range of 4 to 4.2 millisieverts. Why we are doing it? Because the patient comes once or twice if he has a real stenosis, but the doctor and the technician is always standing there in front of the cath lab. So they are more exposed to radiation. So that's why we have brought in a high definition detector. So at a lower dose, we are getting a better image quality.
Tell me one more thing. Why we have to use our foot all the time? Why it can't come on your thumb?
Yes.
That X-ray fluoro all the time, you have to put the foot paddle. Why it can be like for the first time in the world, if you can demonstrate, this is a matter of your finger, the thumb. You have to make that switch so soft so that the operator just presses the red button for fluoro, cine, and the blue button for the your fluoroscopy. Is that possible?
It is possible, sir. We have not worked on that, but something new technologies like why to have a screen.
But you're going virtual.
Yeah, I'll put a goggle, be it on your specs. I'll put a goggle, and from here you can see the how far the stent has moved. It's all in your fingers.
So you're talking on 5D reality.
Yes, sir.
5Ds.
Yes,
So
sir.
you can touch and see in front of your eyes
Correct.
that this is the LED, this is stent. Beautiful. I mean, I'm so happy that India has progressed so much, and because of you people, our GDP growth is 7.2%. And you are the
so much,
one of them. Thank you very much.
Thank you so much.
So, Vijit and the Ustad. Now we'll go on to the next presentations.
Thank you so much. Thank you again so much for making us proud on an international market. And now we move on to the last topic of this particular session. And for this, may I request the presence of Dr. Uday Shankar Das to come up on the dais and present us with pacing vignettes. The topic being pacing vignettes.
Thank you, Hajra sir. So my topic is on pacing vignettes. I'll show some of my cases before that few slides on theoretical discussion. The pacemaker evolution starts with a RV apical pacing followed by different types of septal pacing in the form of inlet, in the form of infundibular outflow apical septum. As the evolution progresses, there is come the physiological pacing. It starts with the his bundle pacing. Then there was the left bundle branch pacing, which could be selective or could be non-selective. Then came the left bundle branch area pacing. Then comes the leadless pacemaker and lead bundle or his bundle assisted CRT or CRTD. So in the since in 19 RV apical pacing is the most easily accessible. It is a safe procedure. It's stable long-term pacing efficacy. But as the pacemaker, as we know that RV apical pacing is associated with mechanical dysynchrony due to the electrical dysfunction. So that could lead to the LV dysfunction. It is well established since 1925. Then came that some concept of septal pacing. Some small institutional data shows the benefit of RV septal pacing over the RV apical pacing. It could prevent the subclinical heart failure. It could have been the beneficial for heart failure hospitalization. Can prevent the pacemaker cardiomyopathy. Can also delay the progression of atrial fibrillation. But a large number of meta-analysis and RCT shows there is no clear-cut benefit of RV septal pacing over the RV apical pacing. And 2021 ESC guidelines also did not recommend any septal or apical pacing over the other pacing sites. So then came the physiological pacing, where it is preferred whenever the pacing percentage or need of the pacing percentage is quite high volume, already having some form of LV dysfunction, systolic. And of course, if does not fulfill the CRT criteria, although some patient who are having the criteria needs the CRT, you can have the lead bundle branch pacing, but still some debatable question. So why the physiological pacing is preferred over the lead bundle RV apical or septal pacing? Because of narrowing of the QRS width, it having some mechanical synchrony, lesser chances of LV remodeling. The chances of LV ejection fraction is quite, decrement of LV ejection fraction is quite less. LV in the form of AV valve regurgitation in the form of MR or AR, MR or TR, and dilatation of the atrium. And overall, the physiological pacing has been shown proven to reduce the all-cause mortality, heart failure, hospitalization, and onset of atrial fibrillation. So there's some basic difference between the his bundle and lead bundle branch pacing, which has been shown already described by the Ullas sir, my mentor during my MMM in Chennai. And his bundle is relatively less stable, high threshold, lesser battery longevity, most effective whenever there is central conduction disease, that is minimally, that is a sick sinus syndrome or suprahesion disease. It is more of a physiological, but lead bundle is quite easier procedure than the his bundle pacing. And pacing in lead bundle, LV dysfunction, who could be the choice? Definitely, if there is some lead bundle branch block, CRT is the choice. But physiological pacing is preferred whenever there is some CRT non-responder or there is any CS tributaries bad anatomies. And definitely, lead bundle assisted CRTs in different trials had been proven that effective than isolated CRT. This is the trial which can show the changes of LV ejection fraction from baseline is quite better with lead bundle assisted CRT than the YV pacing. So then I will show some of the cases that are done by me. So it is the RAO view. It's showing that basically it looks like could have been some physiological, could have been septal, but in this typical lead, you cannot do the physiological pacing unless you hit some conduction system, and some EP knowledge would have been there before doing the physiological pacing. LAO also view looks is quite good. That is the RV lead is looking backwards towards the spine. But then comes the physiological pacing. Before the physiological pacing, you should have the two leads, one in the his bundle and another in the RV apical. And if you do the lead bundle pacing, then you should your lead bundle, I mean RV pacing lead should have been 1.5 to 2 centimeter below the his bundle leads. And there would be in RO view, there would be a line drawn from the tip of the his bundle to the tip of the RV lead catheter, and it should have been somehow over the perpendicular to that line and 2 centimeter or 1 inch below the his bundle tip. And you can, this is the final view of the lead bundle lead bundle pacing. It's LO view, it actually looks towards the 2 o'clock. This is another patient is basically his bundle pacing. In LO and towards the right, it is the RO. In it is close to the his bundle tip, and it is, if you look properly, it is more towards the 1 o'clock. So 1 o'clock is more towards the his bundle, and 2 to 3 o'clock is more towards the lead bundle. Provided definitely some EP data will also help you to guide whether it is in his bundle or lead bundle, and morphology of QRS in V1 as well. And this is the final picture of the his bundle. So first one is the lead bundle and this one is the his bundle. And this is the patient basically came, had a history of pacemaker, only single chamber unipolar in 1992. They again had a box changes in 2005-6. Had a significant pacemaker induced cardiomyopathy and had a history of NSVT during Holter. So go for CRTD. The good anatomy of the CS leads. So there's no problem of doing, but at the same time did not do the temporary, just keeping the pacemaker backup. He was fully dependent on pacemaker. And on the right side, and after putting the permanent pacemaker, permanent CRTD, I removed the right sided chambers. This is another interesting patient. This had an LSVC and a very bad anatomy. During the venogram from the left side, they have shown the no significant LSVC was there, and during the CS venogram, there is no significant tributaries that I could not found. But during the subciliate catheter, you can show that there is some one vein is tributaries of the CS, that is posterolateral vein, you can see. Then try it with the wire, that is the Grand Slam wire. Try it with the wire, over the wire with the help of subciliate catheter to negotiate the LV leads. But there was very difficult to negotiate across the tortuosity or that the bend over the branch between the CS branch and the CS main trunk. So I took the another wire but to straighten the leads, to straighten the branches, but did not cross. Used a one coronary wire or coronary balloon over the coronary wire, and it inflated say up to 10 to 12, and then the subsolid catheter was negotiated across that leash and up, I mean across that branch up to the balloon site, and then the LV wire, LV lead was used, and LV lead was finally. But unfortunately, this patient came a few weeks back that LV lead again dislodged. And this is the final slide where we can see the song. All types of pacemaker you can see in a single patient. This was done in Triple M Chennai. Initially, patient had a unipolar RV lead followed by the dual chamber ICD. Again, some issues of infection. Patient shifted to different sites, then had some LV dysfunction, went into the CRT, and finally landed up with some pacemaker, leadless pacemaker micro. That's all from my side. Thank you very much.
Thank you. So it was a beautiful presentation from none other than Uday Shankar Das. And if you have any question from the audience, do you have any question from the audience? No. Look, if you are doing LBB pacing, usually when I started doing exactly the way you have done, but do you think that RV injections with the sheath and the wire inside is important to shorten the time of find the target? Like if you go to the LO, go with the sheath, enter the wire, push the sheath, keep the wire, inject, see the septum nicely, the whole profile of the septum, and all the septums of heart do not behave equally. We do not see them equally. Sometimes like a saucer sepet, sometimes it's a straight line. If it is a straight line, easy to go like 1 o'clock to 3 o'clock. So do you advocate a routine RV angiogram? And do you advocate routine EP machine for your endpoints like your QRS or surface ECG? But like in our hospital, we have done more than 300 now LBV pacing, 87 from Biotronic, maybe St. Jude equal number, Medtronic around 60 plus last year. This year we have to add a few more numbers. Anyway, so do you advocate RV angiogram?
No. RV angio is never done. Not by me. And during my training in Triple M Chennai, they usually do not do the RV angio. And regarding septogram, once you see that, I'm more comfortable with the EP system. So after getting some good parameters, good QRS morphology, good tail VAT, then whenever I confident that is going into the hitting the conduction system, then to confirm, I do the septogram, but not before that.
Okay, so EP or surface ECG?
Surface ECG, and if you go late bundle potential, you can see you are more confident that you are more touching. So EP and surface ECG both important.
Okay, if you have the EP, then take the EP.
EP is very
If you don't have EP, then you can take help of the surface ECG and continuously.
Surface ECG quite good, quite enough.
Yeah, quite good enough nowadays. And few cases you'll get to know the know-hows, and it's pretty easy, much faster than your CRTs. If you have renal failure, where you cannot inject coronary sinus with a lot of dye, it can be an alternative to renal failure patient, 2.3, 2.5 creatinine, you don't want to give dry. You can do without angiogram, you can go directly to the septum, you can achieve a narrow QRS. Those who are having CRT failures, they are the candidates for LV pacing. And there is a new guideline in 2023, perhaps it is the future for all types of pacing and may replace the conventional pacing.
Right.
So that's where we are progressing and moving forward. And thank you very much for your contributions.
Thank you.
And now we move ahead with the next presentation.
Thank you so much, Dr. Uday Shankar Das, for your contribution to EIIC Con 2023. And before we move on to the last segment or session, ladies and gentlemen, can we have a huge round of applause for Dr. P.K. Hajra? Such a powerhouse he is, attentively from morning till now. We are just moving to the last session. And for this last session, may I have the presence of the following excellencies on stage. May I request the presence of Dr. Topon Mathia, Dr. Khetawal, Dr. Pradeep Kumar Agarwal, Dr. Mrilanindu Dash, Dr. Anando Bagchi on the chairperson panel, please. May I request the presence of the following dignitaries as moderator here. Dr. Shrotin Dotto, Dr. Kaushik Manna, Dr. Ishita Mojumdar, and Dr. Mudhumonti Panja to please come up on the moderator panel. We start off with the last session, and the first topic of it is by Dr. Shubhabroto Banerjee, and the topic is dying fistula line. So we have the presence of all the excellencies here on the panel segment, and we move forward with the first topic.
Thank you, CSI West Bengal chapter, and especially Dr. P.K. Hajra for this opportunity, for sharing my experience on how to save a dying fistula. Now, as you see, I'm not a cardiologist, I'm a vascular surgeon. So most of my work deals in and around AV fistula, which is a dialysis access line. Now, the saddest part is that we are called for saving something which is dying. In probably a first world country which is more equipped, we would be undergoing a surveillance or a monitoring of our own access. It is debatable, yes, but certainly we are only called when there is a poor clearance, that is the creatinine is rising despite dialysis. There are poor flows by the technician. He's facing problems in cannulations. There's a delayed hemostasis, something which is an index event for a central vein stenosis. If you have more time that is required for hemostasis of a fistula, you do have a strong suspicion of central vein stenosis. Then certainly swollen arms and the brunt of multiple cannulations, that is pseudoaneurysms or the aneurysmal dilatations of the fistula. Now, as an operator, what do we expect? It's not always thrombus. You can have multiple lesions which can be in the inflow, that is the artery, It can be in the outflow, that is in the vein, and it can be in the outflow anywhere. It can be around the anastomosis, it can be in the vein, it can be somewhere where the vein dips in, that is the cephalic arch, and it can be in your main vein, that is the central vein. Certainly, once you're in that case, you need to know what the armamentarium are. It's always evolving, and endovascular is the order of the day. You can see that the surgical correction or the surgeon's role is at last, but it is still not something which is out of the list. You can have mechanical thrombectomy devices, the stents, the help of the thrombolytic agents, a simple old plasty, drug-eluting balloons, and stents, which may be even covered stents in certain locations. But what is very essential is plan well, and your planning not only starts with the case, wherein most probably you're not going to get any images. Your planning will be clinical with ultrasound. If you are lucky enough, you can have a central venogram, but certainly to have fistulograms prior hand is not very common in our part of the country, and neither it is common in the institution where I do my cases. But you'll have to plan on your ultrasound and clinically whether you want a retrograde or a brachial puncture, an antegrade in the post-anastomotic vein, or whether you want a dual access for a snaring, that is whether you want it in the groin as well as in the fistula arm. Your balloons will be mostly semi-compliant balloons or balloons which can go at least to a higher pressure. The drug-eluting balloons have a better role these days, so that should be in your armamentarium. Now, just to go through these images, see, the most common site of a stenosis is the juxta-anastomotic area. This is the artery. This is your vein. It has become hairy, and this is the most common area of stenosis due to the subtle hemodynamics. Be it a brachiocephalic fistula or be it a radiocephalic fistula, this is a brachiocephalic at the humerus, and you can just plasty the outflow vein. Yes, DEBs add to the result, but once you have opened up the vein, it gives you a better access for dialysis. The same goes for radiocephalic as well. So this again is a radiocephalic plasty, which is done with a retrograde access from the radial artery, something which is very common for people who are doing coronary angiogram, but this is the retrograde artery, the wire passed on to the outflow vein. You can't see the inflow because the blood is coming with a gush from the brachial artery, but this is your lesion, and once you have plastered it out, you do get post-plasty effects, but as long as they are not leaking, as long as they are not causing a flow defect, your job is done, because your job is to give a continuous flow, which will then help in maturing the fistula further and also giving a good clearance. But as I said, that be careful of your image. Look at this. This was a plastic case that I received. The problem is the artery, the adjoining artery also has a lesion here. So once you're doing your fistulogram, irrespective of the axis that you have chosen, you should have these three things in your local field. I say local field because there is the cephalic arch and the central vein, which is to be looked as well. But in your local field, you should have the inflow artery, you should have the distal artery, as well as you should have the outflow vein, which is your point of concern. Now, once you have this, if you have just done a plasty to the fistula segment, it would most likely either shut down on table or it will not have a good flow. You need to curve your balloon into the inflow artery so that the juxta-anastomotic artery, the anastomosis per se, and the juxta-anastomotic vein gets dilated. So there is a role of planning or having the idea as to where you are suspecting your lesion. It's not like doing probably a peripheral angioplasty wherein you have a roadmap prior hand, but it is something which you need to know that the lesions can most commonly affect the juxta-anastomotic area of the vein and of the artery as well. Now, this is a case wherein we do a central venoplasty for the central venoplasty for a swollen limb. Once we're doing a central venoplasty, you have an option of your access as to whether you take it in the outflow vein. This was taken in the fistula going through the axillary vein, but this had to be snared down because the fistula would most likely not tolerate a very large caliber access. And the balloon that you require for a central vein is usually we step it up from a 10 millimeter to 12 to at least a 14 millimeter balloon. So it is better that you snare it and you use your groin access, because if you require a stent, then it would be better that you deploy it through a flossing technique through the groin, wherein you have a dual access in the arm as well as in the groin. But central vein stenosis is one of the most common causes of fistula failure and something known as a recirculation, wherein your blood, which is given into the dialysis line, keeps coming back because there is an obstruction ahead. This is an older picture which I've picked up from my residency at Medanta. This is an over-the-wire embolectomy. The over-the-wire embolectomy catheter is not so common. This is a basilic vein transposition which had thrombus. This over-the-wire embolectomy can jolly well be done in the cath lab with an arterial access, without an open access. And once you can receive or retrieve the clot, you just need to be meticulous enough to pull back your sheath and flush your sheath accordingly so that you get a good clearance. As I said, it's not always thrombus, but you have lesions and now you have thrombus, which is getting into the way of the fistula and getting it to become a dying fistula. This is one of the cases that we've done recently at the Salt Lake unit. This was a gentleman who came with something known as a warning hemorrhage from the pseudoaneurysm of a fistula. Now, why we did extreme endovascular for this gentleman was he was 78. He had a history of cerebrovascular accident. He had a coronary history as well. He's been on dialysis for, I think, ever since 9 years. He has exhausted all his fistula options. And this is his last arteriovenous option. Otherwise, we would be looking at a synthetic graft under anesthesia, which is not probably the option to do. Now, he had 2 pseudoaneurysms which were leaking. The size was calculated. We have put in a Covera, which is a covered stent, a 10 diameter Covera. And once you have sealed this, you can puncture this area and you can puncture the other area, which is close to the bone, and you can seal it during your dialysis. Now, literature says that you do not routinely puncture the covered stent, but if this is your valuable fistula, after 3 months' time, once it has epithelialized, you have no other access, you can come back and stick in 1 needle. It's not advisable, but there have been case reports which have been done. Now, he's 6 months on dialysis. You can see that the pseudoaneurysm the bleeding point has gone. It's no more red and angry. The dialysis technicians are very adept and they have put the needle exactly where we want them to be. And he's undergoing dialysis regularly. And luck was on my side because I thought that I would probably do a surgical correction, but then having seen the profile, I did not. And he landed up with his second CVA just 3 weeks after this. And I was pretty happy that I didn't do a surgical correction because, these patients are really fragile and they would be best done endovascular. But having said that, nonetheless, I'm a surgeon and there are few options wherein you can salvage a fistula surgically as well. One of them is while you're doing an angiography, it's not always about the lesion or the thrombus that I'm looking at. As a surgeon, I'm looking at if I cannot do an endovascular procedure, what other options do I have? Now, once you see this is the basilic vein. This is not the cephalic vein. This was a fistula done outside. I would call it as a bizarre fistula because I have not understood what the anatomy was. Probably this is a fistula, which is an H-shaped fistula with the artery connected to all the veins that you see. This was the main vein which was draining, but the puncturing vein was this, which in no sense of mind is good enough to take a needle. So the thing that we can do straight away is we can go in, because this patient was stable, we ligate all the branches, take a proximal control, and just reroute this vein under the skin, which is known as a transposition. So once you do this basilic vein transposition, it is the same fistula, but it has survived, whereas it was termed that the fistula is not good enough for dialysis. And this is the post-op picture. You can see a good matured vein. There are other options wherein you find that there is a stenosis, mostly at this part, that is the distal part of the fistula, wherein we can open it up and we can correct it with a surgical patchplasty. Now, this option these days are only kept for refractory lesions, which are requiring multiple or repeated plasties. Normally, you would not like to do more than 2 plasties in a year on a single fistula. But if it is requiring a plasty, let's say 6 to 8 weeks down the line, and all the other factors are corrected, that is, you do not have any other lesions, and if only this distal part is your corrective lesion, you can go in, you can take the control and just put a vein patch on this, which is known as a distal patchplasty, which still is done, but it is very rarely done, and so I do not have pictures to share at this moment. The most common complications that you see apart from the surgical cases are hematomas, but keep in mind these are mostly self-remitting. Now, we have a study wherein we did ultrasound-guided fistuloplasty on a series of patients. They say that until and unless you have a hematoma surrounding the fistula, you have not done a successful plasty. Now, that's pretty aggressive, but just the thing to be kept in mind is that these hematomas are mostly self-remitting. If they're doing some nonsense, they would be tackled mostly with a balloon tamponade, and very rarely you would require a stent to occlude them. But still, there are challenges. The challenges is that the timely referral, where we are doing the cases, if it's in a smaller setup, it's a C-arm, which does not give good imaging, especially for the central vein. If it's in a hospital, slots are an issue because, as we know, the cardiovascular disease is just expanding. So doing something for the fistula is probably still an issue with the slots. And then once you calculate back, what is the remuneration and the availability of the hardware and the energy you spend, because most of the hardwares and the balloons do not match with the coronary hardware and they need to be procured. And these are the logistical challenges, but there are challenges scientifically because the patency rates are varied. If you search the literature, they would be as bad as 40 to 80% for the next 6 months. And if you see the data, they are mostly for 6 months to 12 years. So this is not a one-time solution. This is not a one-time disease. This is not a one-time solution. And there have been studies which say that nearly 50% may require intervention or re-intervention, which is true. I mean, we cannot hide out from the fact. Then there are other challenges as to whether you pick up surgery or you do endovascular. Both are good, none is bad, but the patient is not good, he's pretty fragile. So we have to search as to what the correct option is. And then since I'm in West Bengal, there are typical challenges. If the procedure is not covered by scheme, if it is not supported, it's a chronic disease, it drains the patient, it takes a mental toll on the patient. Repeated procedures done by someone who is not still having gray hairs like me, it's a low durability in my hands worldwide as well. And the high cost, there are multiple questions. So probably, if we can formulate some kind of a scheme support or some kind of a understanding as to where a fistuloplasty cost can be supported by the existing schemes, we could probably serve our patients better. There is a logical thinking that the cost of one fistuloplasty will give me 5 fistulas or 10 fistulas, but scientifically you cannot get 10 fistulas in a single person. So the scientific idea is to keep one single fistula or an arteriovenous axis to run as long as possible. Keeping everything in mind, keeping the logistics in mind, probably this is one of the ways where you can address a dying fistula with only an outflow vein lesion by doing an ultrasound-guided fistuloplasty. We had a series of patients who had close to 80% success rate on ultrasound-guided fistuloplasty till cannulation. This was published in the Indian Journal of Vascular and Endovascular Surgery in 2016. But to keep in mind, this will not address a central vein stenosis and a cephalic arch stenosis. Thank you very much, and thank you for your presence once again.
Thank you. You have any question, my co-panelist? Any comment? Satyen, any comment? Yeah.
Yes,
Not
sir.
to me, not to him.
I mean, yeah, to him, of course. Now, interesting session. Thank you for keeping it. I have a question about you. When you put a stent, you put it in the arteriovenous junction. Am I right?
This is stents are better not put for the fistula vein. These are
Balloon,
mostly
only balloon.
balloon and drug-eluting
Drug-eluting balloon.
Okay.
Stents are reserved for cephalic arch and central veins.
There are some people in Calcutta who put stent also.
You are right. And the other thing I wanted to know, what antiplatelet you recommend after doing drug-eluting balloon angioplasty?
So this is a high flow circuit, and most CKD patients will have some form of coagulopathy. For the stent patency, we do not recommend antiplatelet. If we go by studies, probably only clopidogrel has got an advantage here. But we do not require antiplatelets per se for the stent. If they are on any antiplatelet for the systemic disease, we just continue that. Otherwise, a single antiplatelet mostly.
Thank you.
Subroto, what should be the ideal point of entry? I mean, for your fistula access, whether you go transfemoral, direct ultrasound guided access to your fistula, or you first go radially, see the health of the fistula going from the radial, do the arterial angiogram and see the venous phase. Number one. And number two, is there any role for intravascular ultrasound to know what could be the mechanism of fistula failure? Like if you see a lot of thrombus, maybe thrombosuction, or if you see a lot of fibrosis, or is a valve which is calcified. Do you think there is a place, though the cost increases, but if you have like Ox intravascular ultrasound from Philips for peripheral, you need 8 French catheter to have this Philips ultrasound in your venous system. Do you think that makes you wiser?
Two questions basically. First is regarding the access. I usually choose it on an ultrasound myself. If it's juxta-anastomotic, I would take a radial access to find out how close it is to the anastomosis. If it's upstream, then I would like to choose a branched vein or the outflow vein on the ultrasound. If only I'm suspecting a central vein or a cephalic arch lesion, I will take a simultaneous groin access. Regarding the intravascular ultrasound, I think if it's in the arm, if the lesion is in the arm, I would be pretty happy with my conventional ultrasound. If I'm looking to deploy a stent, especially in the cephalic arch, which is one of the commonest area, I would love to have an intravascular ultrasound for the simplicity of the exact location of the stenting.
Right. So if you're doing the brachiocephalic, and if there is a tight lesion, so there may be a chance of perforations.
Right.
So how do you prevent that? And if you have a perforations, how do you manage that? I mean, covered stent or
So
vein occlusions?
usually these are fibrotic veins. So if we are not overzealous, if we are easing it out, like normally, if I see that if it's a tight stenosis, I would floss it, and then I would start with 8 millimeter balloon and then gradually step it up to 10, 12, and 14. If it perforates, first tamponade. If it doesn't, covered stent. But they really perforate to require a covered stent. They do, but they rarely do.
When do you kill the fistula?
Sorry, sir?
When you kill the fistula, kill.
When I kill a fistula.
Yeah.
Electively, if I were to kill a fistula, is a patient with having refractory heart failure, who has no other causes. He's not good enough to undergo application surgery. So I would electively shut down a fistula. And apart from that, infections and bleeding are other causes, but electively, if the patient is having refractory overload certified by a cardiologist that there is no other causes, so I can go in and ligate the fistula.
All right. So if you have a large pseudoaneurysm, the case which you have shown here, then covered stent or surgical ligations or a coil?
For the case that I have shown?
Aneurysm.
Sir, it would not honestly take a coil because these are mostly degenerated walls of the fistula adhered to a skin. So a coil would not be an option. Ligation is no option because I have nothing to give him. He is suffering from only local bleedings. He has no cardiac issues with him. He was not fit for another access. So naturally I had put a covered stent so that the fistula life is prolonged.
The next would be non-surgical fistula creations, like, arteriovenous connection, when it is going to come to your hand?
So I've read about it. I have neither used it nor have I been trained at it. I would love to use it once I have it.
All right. So, Madhavanti, you want to go for radial artery and radial vein connections to the PTCA and a needle there, puncture it and create a fistula? You heard about it? No? Okay. So there are newer methods of connecting artery and vein in the leg for peripheral claudications. There are 2-3 companies. They are beautiful gadgets and gears to create surgical fistula by non-surgical means. So brother is yeah.
I suggest you include them in your WhatsApp group. So they will know, what you are talking. They would have known it. Non-surgical.
WhatsApp group. Okay. So this will be next time. Subhabrata he's got a beautiful pair of hands and very versatile, very humble. Always comes for the help in our hospital. And he saved many limbs. He has saved many fistulas with his full dedications for the patients, love for the patients. And with that, I'd like to thank you for your kind contributions, kind attention, and for coming
Thank
here.
you, sir. Thank you very much.
We have come almost to the end of today's session in Hall Victoria. So there are 2-3 housekeeping announcements. One is the gala dinner is waiting for you. Probably will start at 8:30. And we'll have a lucky draw over there. Those who will be present at exactly at 8:30, they will get this prize. It will not be handed over by post or by any other means.
Sir. Dr. Hajra,
Okay.
sir.
So and then, there is a bioskill development village by Orijit Dotto. We'll have a bovine heart there in Biotronic, or I think about St. Jude village. Debu is there with St. Jude. And if you're really interested, seeing, touching, feeling, cuddle the dead bovine heart, right now you can go there. The rest of the people can join the hall Minerva, and it will
Dada,
continue
এখন
up to
talk আছে আমার।
8:29. Then we'll join you for the dinner. And thanks
Dada।
for being here.
No,
And
so
tomorrow-
we have one more
One more?
session.
Okay.
Yes, we do have one
For
more
Ramdev.
session.
Okay.
Yes.
So
this
that will
will-
be the last year.
Yes. So sir has already said what has to be done, what has not to be done. Everything has to be done actually. So now we move forward with the last session of this particular day 1. And the last session is how to save dying rhythm by Dr. R.D. Yadav. He will be joining us online. So he's already with us. So we start off with the last session of the first day of EIIC Con 2023.
Welcome, Dr. Jadhav, Dr. Hajra here.
Good evening, sir.
I'm really sorry.
Are you able to hear me, sir?
Notice that you are already popped up.
Dada, are you able to hear me?
Yes, I can hear you. I can see your boldness.
Okay, thank you.
Beautiful,
So my topic,
beautifully bold. Yeah.
first of all, I want to thank that you have given some topic for Icon 23. So the topic is dying rhythm. So let's start. So what are the rhythms which causes death? Sinus arrest without escape beat, complete heart block without ventricular escape, ventricular fibrillation or fast ventricular tachycardia with hemodynamic compromise, like this patient. This patient came with syncope and no ventricular beats, no atrial beats. He is having cardiac arrest. Cardiac massage was done, and immediately temporary pacemaker was put in and found to be having electrical standstill and assist. So here we put TPI, and with TPI he recovered, and then we put permanent pacemaker, dual chamber permanent pacemaker, and he is alive. So ventricular asystole ECG review showed asystole can also be related to intrinsic conduction system disease. In this situation, the pause of electrical activity may be brief and result in syncope. However, spontaneous recovery of sinus rhythm may occur. Treatment for this form of asystole is permanent pacemaker implantation. But those patients who come with cardiac arrest like this, having chest pain, they may be having late presentation of VF with asystole. They need cardiac desynchronization immediately and followed by re-ECG and repeated desynchronization. DC cardioversion should be done to bring the patient into rhythm if they have a chest pain because of myocardial infarction, VF, and late presentation. They will have like this. Then patients having prolonged ventricular asystole because of paroxysmal complete AV block, where lot of one ventricular extra give rise to multiple P wave, which is non-conducting. This is called phase 4 heart block, where it requires, is a cause of sudden death, where requires permanent pacemaker. It's an absolute indication for permanent pacemaker. And patient may not have conduction system disease from beforehand. Only one ventricular ectopics lead to, or atrial ectopics lead to complete AV block, ventricular asystole, where PPP will be there without ventricular beat, and once one junctional beat will come, a radial premature beat will come, the ventricle recover. So here there may not be intra-Hesian conduction defect from beforehand, suddenly it will appear, but most commonly if the patient is having intra-Hesian conduction defect or infra-Hesian conduction defect. So this is called paroxysmal AV block, which is different than that of the, like this patient having RBBV, first degree heart block, left hemi block, and develop this type of block. Here, how will you distinguish from paroxysmal AV block due to AV node disease, AV conduction, that is vagal effect, where you will see PR prolongation from baseline, but during PPPP, that is the arrest, where only PP will be there, the cycle length is shorter. Subsequent cycle length is relatively shorter as compared to baseline, because if there will be AV block, the cycle length will be prolonged, PP interval will be prolonged if it is because of the vasovagal reaction or vagal effect. So vagal AV block, that is called vagal AV block. Whereas in paroxysmal AV block, it's always cycle length will be shorter than the sinus cycle length. And this is the mechanism. This is called phase 4 conduction block in the Purkinje fiber. So this is same thing has been demonstrated, and this paroxysmal AV block, as I told you, require permanent pacemaker and is an absolute indication for permanent pacemaker. So same, this is one of the patient having atrial ectopic led to ventricular asystole, and one ventricular ectopic led to recovery of the patient. This is the same similar patient. I can show many of them. Now I am going to show you another patient, short couple PVC induced torsade D points recurrent VF. So this 69-year-old female underwent SOL lesion surgery of brain 3 months back, presented with history of recurrent syncope. She underwent echo, which showed no regional wall motion abnormality, ejection fraction 60%, CAG showed normal coronaries, electrolytes were within normal range, 24-hour Holter showed short couple PVC induced TDP, that is torsade D points, polymorphic VT and VF, spontaneously recovering to normal sinus symptom. Her baseline ECG is normal without QT prolongation. She was admitted in CCU, where she is having recurrent cardiac arrest 9 times during the cardiac defibrillation, and monitored during cardiac arrest showed VF like this. This is in the Holter, so long VF, and recurrence long VF recovering spontaneously to sinus rhythm. This is another VF recovering to sinus rhythm. This is another onset of short couple PVC induced VF recovering to sinus rhythm. This short couple PVCs in couplets. This short couple PVC in some of them are bigeminy, some of them quadrigeminy, and this is the short couple PVC induced torsade, which spontaneously terminated into sinus rhythm. And this is the same patient in Holter showing multiple episodes of VF recovering spontaneously with the sinus rhythm. And this is in CCU having VF needed cardioversion, sometimes spontaneously shock. This is another VF, several VF, almost 50 times VF has occurred in the CCU where we have cardioverted, and then this is another VF. And then what I did is all the antiarrhythmic drugs have failed. So what I did is put on left stellate ganglion bupivacaine injection by ultrasound guided, and then put on high dose verapamil 80 milligram 6 hourly orally, and flecainide 150 milligram twice daily. And after that, she had no VF, no shock, no BPCs, and this is the ECG, which is absolutely normal looking ECG. After 2 days of suffering, she got. Actually, the patient was admitted to other cardiologists, and they gave it to me. You control it. I cannot handle this type of VF. And so, how to do the left stellate ganglion block? This is longus colli muscle, and T1 and C7 vertebra. The stellate ganglion is there, stellate like. So here you do the ultrasound and find out the carotid artery, and here you punctured. I will show you the Doppler. here, this is called Chassagne tubercle, and Chassagne tubercle is convex. This is the artery, this is the longus colli muscle. You have to inject like this. And here Chassagne is C6, you have to come to C7, where the chest is horizontal line. There will be the transverse process of the longest transverse process of the C7 vertebra is horizontal, and between the carotid artery and the thyroidal artery, you puncture the needle, go here, inject the bupivacaine 5 to 7 ml, and the VF or VT immediately terminates. And this is the injectable area, and you can get rid of this disease. So she received about 50 DC cardioversion in CCU in 2 days' time, failed with all the initial anti-arrhythmic drugs such as Midodrine, beta blocker, Maxilatin, Lidocaine IV, and therefore did vascular ultrasound guided bupivacaine injection at the bedside. Left stellate ganglion, which led to stoppage of any VT-VF and even short coupled PVC. Started high dose of verapamil, 80 milligrams 6 hourly daily, along with the 150 milligram of flecainide twice daily. Then I put her on 2 dual chamber ICD and discharged within 2 days. And short coupled PVC induced TDP is relatively rare disease and may lead to sudden cardiac death. This patient responded well with ultrasound guided left stellate ganglion blockade by bupivacaine injection on verapamil 80 milligram 4 times daily, flecainide 150 milligram twice daily. She is free of any arrhythmia, and over 1 year of follow-up, she is coming to show me without any shock over this period, and she is doing fine with this medicine. And these are the studies which are published in the literature. Similar cases has been shown, short coupled PVC induced torsade and VF spontaneous recovery, and several of these has been shown. And these patients, and this patient is another one, short couple, another VF, and all this required is either you do PVC ablation, because this PVC arises from the Purkinje fiber, or you do left stellate ganglion blockade, and we did left stellate ganglion blockade. I can show you several of such cases. This is another VF like this, and thank you for giving me the opportunity to talk something about the dying rhythm.
Thank you.
Thank you. So before we move forward, I just like to say that this is not the last session. We have one more session, so kindly stay back for the last session. This is not the last session. Please stay back. Over to you, sir.
Yeah. So, Jadhav,
Yes,
when
sir.
you see a young patient having a dying rhythm like a complete AV block for long, no escape, and a straight line, do you think in future we'll go for ganglionic ablations or parasympathetic so that they can avoid a pacemaker?
Sir, ganglionic ablation is still not established treatment for sick sinus syndrome. Sick sinus syndrome is thought to be because of excessive vagal outflow from the ganglion of the heart. And so the people are ablating the ganglion which is around the pulmonary vein and around the septum. And what they have found that the sick sinus syndrome has disappeared, but this has not been shown in prospective randomized study. So only few case report, observational studies only. They have not given absolute say that in sick sinus syndrome you need a ganglion blockade. Or ganglion blockades have also been used in vasovagal syncope, where it has got some effect, but not remarkable effect, so that it should be come in the guideline. So in these two conditions, ganglion blockade has been tried, but it has not been even slow pathway ablation. Slow pathway ablation leads to vagal effect decrease and leads to increased heart rate and sinus node recovery. So even slow pathway ablation has been demonstrated to remove the sick sinus syndrome, but this has not been demonstrated in large studies. These are incidental study where they have found that if you will do the slow pathway ablation, you will do the ganglion blockade, the sinus node dysfunction recovers.
Right. So in neurocardiogenic syncope, right superior vena cava.
Near right superior vena cava and the septal side, there is a ganglion, and that ganglion you block by RF ablation through the endocardium.
Okay.
And then
So another question, if you have a dying atrial fibrillation, that means your AF ablation did not work, your drugs are not working, whether you go for vein of Marshall alcohol injection versus epidural ablation and LVV pacing?
no, if the rate is not controlled, sir, then we will go AV node ablation. If rate is not controlled with all the medicine you have applied, then you need AV node ablation and biventricular pacemaker or left bundle branch pacing.
Vein of Marshall alcohol injections?
Only that is for persistent atrial fibrillation, which is not responding to PVI alone. Pulmonary vein isolation you have done, but still the AF is recurring. Then you do vein of Marshall alcohol embolization to make the mitral isthmus line complete.
Yeah, so BOM or bomb ablation can be done only in the selective case. Any question from my panel? Madhuvanti? You
Any
have to have a
questions?
question. Dr. Panja,
So what are the indications of ganglionic blockade in which cases we use?
At the present moment, some evidence is with the neurocardiogenic syncope. And only few case reports of sinus node dysfunction.
Thank you, sir.
Thank you, Dr. Jadhav. Thank you for being with us. And would have been much better if you have come over here for a
Next
cup
time,
of tea
sir.
with us. Thank you, sir. So
Next
he
time,
keeps
sir.
coming to Bengal.
Yes,
and
yes,
really
yes. It is my home.
Yeah, so he's your second home.
Ha.
Over to you.
I live in near Durgapur. My house is near Durgapur.
Thank you, sir.
So there is always a next time. So we will be glad if you could join next time with us.
Definitely,
Thank you
definitely.
so much, Dr. Yadav, for your contribution. And now we move on to the next topic. And the next topic, the presenter will be Dr. Vaibhav Patil. So I will request sir to please come up on the dais. And now the topic being complex case with Prestine. So this is the last topic of the day. So finger crossed, I'm not sure. So I will request everyone to please stay back until and unless I get the next update. So as of now, we have on podium Dr. Vaibhav Patil talking about complex case with Prestine.
Hello, good evening, everyone. I'm presenting these two cases, one with IVAS, one with OCT. I want to just discuss some points. This is one case, 53-year-old male, intraval MI, he had thrombolized, had done PCI to LAD and L6 in 2010, and again he had came with ISR. His angio was done outside. I'm just showing you angio. So you can see the L6 OM1 is having near total occlusion. It's ISR. The stent is seen visible. So near total occlusion. The RC is non-dominant. LAD is a 70 to 80% lesion in the mid-distal LAD. So LAD, the OM1 was crossed with filter FC wire, and then small balloon 1.5 balloon I have dilated. The thing was the patient having the reports of 3/16 OM1, and this vessel is not looking, this stent is not looking 3/16. So I was in doubt. So that's why I want to do IVAS for this. So what stent to put? So better optimization, I have taken IVAS as a imaging technique. Lesion was dilated, pre-dilated, and then IVAS was done for at this moment. Right image is IVAS. Here we can see the 2.85 was the maximum diameter, was the distal reference diameter. So what was my eyes seeing that the stent is not 3/16. The diameter of the stent is not 3/63 definitely. So I was skeptical in that. So that's why I have taken Prestine plus 2.75 into 40 millimeter at the OM level, overlapping with the previous stent. So I come to know the exact anatomy of previous stent why it was instant restenosis, that one thing. And another one thing was what was the next stent's diameter and the length. So with the IVAS optimization, it was done, and post IVAS I have taken shoot. This is a post IVAS shoot pullback. We can see the two layers of the stents are there. One which was done 10 years back, and probably it was CTO 3 or 6 months back it was closed. And yes, sir.
What is that structure which is moving on the corner on the IVAS? This structure moving, floppy structure?
At the 7 o'clock?
No. That from 1 o'clock to 3 o'clock?
Just a second.
Oh,
This is a vein, sir. This
due to hybrid?
This is a vein.
A vein, which vein?
The 1 to 2 o'clock, sir, you are asking?
Yeah, 1 to 2 o'clock. There is something
Yeah.
moving as a floppy curtain,
Yeah. The black shadow you just asking, this coming and going.
Yeah.
Yeah, that might be
It's
the
moving
vein.
like a curtain.
Yeah.
Yeah.
Yeah. Right upper corner you are telling this way. It is, the arrow is not coming there. So this might be the
Could be a vein.
Vein, yes.
Okay. Okay.
Yeah. The next and the LED lesion I have treated with pre-dilated and then post-dilated. The stent put was a pristine 2.75 into 44. That's as a routine case. So the IVAS optimization was done. This is the final result for the right side. You can see stent in stent is there. So previous stent on paper it was mentioned 3 into 16, and what I have put 2.75 into 40. So IVAS cells in pre-evaluation, the diameter of previous stent, and optimization of the stent implantation, the exact morphology and the cause of ISR we come to know, and the exact diameter for the next stent I have chosen with the IVAS optimization. This is the first. Then the next I want to discuss this 75-year male patient. I have done this case 2 weeks back. I had done distal LCX in 2015. Had came for the urology fitness, came from urology fitness to us, that he was asymptomatic with walking up 2 flights of steps. He is so symptomatic, and proximal LED and osteoproximal LCX was deceased. So this angio was done outside. So I have done again angio, and previous stent was patent. So we have decided to do bifurcation stenting. So LED and LCX stent was put. So LCX and LED pre-dilated 2.5 into 12 balloon at 12 atmosphere. Then pristine plus 3 into 32 stent was deployed in from ostial LCX to the mid LCX. And you can see the angle at right side, exactly 90-degree angle. And so I want to take as a T-tap. Then Lippmann to LED was taken 3.5 into 38, which was deployed from the Lippmann to the proximal LED. And the wire was recrossed, another wire was recrossed, and blue wire recrossed from the Lippmann stent to the LCX, and previous wire to the LCX was taken out. So again 3.5 into 12, both kissing balloon was taken, LED and LCX, and simultaneous kissing balloon was done for the LED and LCX. And the pot to the Lippmann was done 4.5 with 4.5 into 6 millimeter NC balloon at 14 atmosphere. The pre and post OCT I have taken. Post OCT pullback was shown that the Lippmann MLA is near about 6 millimeter square, and MSA for the proximal LED is 4.95. In the last shoot, I will just show you how inferior aspect of the proximal LED was looking. I was skeptical that it got dissected or not. So I have taken this OCT picture. So this is a OCT picture here. 2-3 pictures are not very good, but I will show you. This is a pre from LAD to the Lippmann OCT run. These are again segmental from distal to the proximal. This is again pre. This is also pre frames. This is a post PCI Lippmann LAD OCT run without dilatation. So at the bifurcation, it was not very well opposed, and proximally also not opposed. So post stenting, post OCT, I have again dilated, and what was done, and then I have taken this shoot. So post PCI Lippmann LAD OCT analysis, this is, you can see the stent studs are very well opposed, and at the bifurcation also very well opposed. There is no the stent had not come into the Lippmann, the L6 stent had not come into the Lippmann, and again I was very skeptical. I have taken again that only proximal Lippmann I have done pot. So I have taken only that shoot again, OCT run. So it was shown that the optimization is good at the Lippmann also. This is again same shoot. This is the final angio. So T3 good flow, Lippmann proximal LAD and osteoproximal L6. So bifurcation stenting. So OCT for the all bifurcation of the Lippmann and proximal proximal LAD and proximal L6, you have to do either IVUS or OCT. So this is a need. If you are doing in-house, IVUS is there, you can go with the IVUS, or OCT if it is available, you can go with the OCT. Okay. Thank you from my side. I am using this stent since 1 year. So it's a good trackability in L6 only. That's why I have shown only this L6 as others, because I don't know, for L6 this angle and because of the anatomy, probably we are not very keen to do these kinds of cases, but the pristine stent had went as a good bailout for this one. Yeah.
Thank you, Vaibhav, for coming and showing us a couple of beautiful cases. In our hospital, AMR Dhakura, we put around 350 stents, 350 stents. Out of that, almost 190 to 100 is pristine. It's not that primitive. It is basically one of the state of the art of the Indian stent, and good pushability, trackability, visibility, and all sizes, I mean, long, length are available. And there is only fear in our mind that it may not work. So it does work. We have almost now 2 years follow-up of pristine, a large number of patients, and a few hundreds, and they have not come back. So it's a matter of confidence on pristine on Indian stents. Though I do not use so frequently, because if everybody starts putting pristine in my hospital, then other companies will have some kind of conflict of interest issue on me. So we are quite balanced. Like some people they put pristine, some people put MNC plus Indian origin stents, but there is no stigma now on many Indian stent which are supported by large data, efficacy data, MACE data, safety data. So we're building the confidence on pristine and pristine-like stents. And with that, I would like to open discussion, have some comments from my fellow colleague. First, Madhuvanti, type of stents. Yeah, you have. Yeah.
Nice presentation, Dr. Vaibhav Patel. So my question not regarding pristine, but how do you size the first case? So you said that the stent was 3x16.
316 was noted when it was
deployed.
No,
first
when it was done at the outside center.
Outside center.
And when I have done angio, it was not there. So we are we know that it might be 2.5 or 2.75. When we are the patient was posted for the plasty, our resident came that, sir, this was the report, and I have seen personally that it's really 3/16. So I was not believing. That's why I have done IVAS. So what was the reason for this ISR? That also I found it was not post dilated properly, probably that time. That's why this
Yes. So
ISR
there
had
is a possibility of recoiling this under expansion of the same stent,
Yeah.
and which ultimately increase the risk of instant restenosis in the later date.
Yes, yes.
So in the now when you deployed your stent, you downgraded the 2.75.
And I of
So the
course that-
rationale, whether you should you thought about modification of the previous stent with
Yeah, the MASA I have increased before the previous, because it was totally occluded. When patient presented to us, it was near total occlusion. So I opened it, but we don't know what was the, probably this might be the fresh ACS patient had came, and patient having ST elevations in anterolateral ECG leads.
Thank you. That's
So
the rescue kind of
probably
thing.
that
So
might be the reason that stent went, but LED was not very tight, so this was the culprit reason probably. So it was fresh and it opens easily. So, but with IVAS, I come to know that this stent was not dilated up to 3. That's what I want to show. And I also want to take 340 stent, but still again, chances of dissections were more probably, because and it was not looking, artery was not looking 3. Yeah.
Okay. Thank you.
Excellent two cases. I want to involve in the discussion of both the cases in a simple way. Regarding your first case, we have put a longer stent in the OM. Was it fair enough to consider a DEB in that case?
Yeah, but cost of the therapy will be more. These patients was under CGHS scheme. So if you ask one more drug-eluting balloon, so that was the one, that might be the one possibility. But the cost of this stent, but again, if the results are suboptimal, we have to again use for this stent. So the cost of the therapy or the total procedure cost will be more. That's why that option was also there. But in some of the kinds, means like this last 3 months, this is CGHS, this body, they are asking why you want these kinds of therapy. So we have to give upfront guidelines. That was also one good option. So I have used for this another cases. So drug-eluting balloon was also one of the good choice for that.
Regarding the second case, we have used T stenting in the left mental LED bifurcation.
Yeah.
Could have another bifurcation methods like a mini crush or a DK crush would have been used in this case.
Yeah, the angle was exactly 90 degree. That's why I used T.
Putting a T in a T stent is you need to be so much precise and so much on the ostium. It's very difficult. I think not a very huge number of cardiologists like us are so much confident about putting it in the ostium. And a deformed ostium is not always circular, so that your stent edges cover all of the circumference of the ostium.
Yeah.
So we eventually get 1 or 2 starts in one of the dimensions inside the main vessel.
Yeah.
From the branch. So that's why. But these are a very
It was modified T plus small crush, because I have done after only L6 stenting, I have done kissing technique with both simultaneous kissing, post dilatation balloon in L6, and again here pre-dilatation balloon in a proximal LED to the left main. So it was moreover overlapping with the T and mini crush.
Thank you. Nice cases.
Thank you.
Madhavanti? Yeah. Okay. Madhavanti had the same queries whether the drug-eluting balloon or a small stent proximally, distally with the drug-eluting balloon. This kind of hybrid things are reality. And thank you very much for your presence. Thank you very much.
Thank you so much, Dr. Vaibhav Patel, for your contribution to EIIC GON 2023. Now, ladies, and I would extend my thankfulness to all the elite panelists
Don't
here.
miss the lucky draw.
Yes. So coming to the end of the first day, So there are a few things that we will be inculcating. That is one, first being all of you have to report to Tech Village because we have a bio-skill session going on, which will be conducted by Dr. Arijit Datta. Along with that, at 8:30, we will be having the lucky draw. The winners will be announced and the winners will be given prize if they are available and present in the hall. So Hall A is your place at 8:30 to be reported. So this is the end. Thank you so very much. Again, seeing you tomorrow at day 2 of EIICCon 2023.